0.7 months with a hazard ratio of 0.158. And the most common variant associated with this mutation were D538G, Y537S, and the E380Q, and the Y537N, the most common. And remarkably, palbociclib provided OS benefit regardless of ASR1 mutation status. It's important again to note that in patients with ASR1 mutation treated with the combination of fulvestrant palbo, they had treated with fulvestrant and the placebo had only 20.2 months median overall survival compared to 27.7 for patients treated with combination of palbo and the fulvestrant and have ASR1 mutation with a hazard ratio of 0.59, suggesting that the combination of palbo fulvestrant can overcome the ASR1 driven endocrine resistant. And the same is true for the PIK3CA mutation. It was detected in 21.5% of the patient. Patient with PIK3CA mutation had a median overall survival of 24 versus 30 months with a hazard ratio of 1.44, so poor prognostic factor. And once again, the palbociclib provided OS benefit regardless of PIK3CA mutation, as you can see in the Kaplan-Meier curve and also in the lower bottom right part of this slide. And then the investigator looked at the OS by the B53 mutation, and the B53 mutation was detected in 17% and was associated with the most aggressive feature. The median OS was 19.9 months for patients with this mutation versus 31.8 for patients with wild type B53. And clearly there is a benefit maintained with palbo treatment in this population and across the two groups. So palbociclib appeared to be beneficial also in patients with B53 mutation. Patient that progressed in PALOMA-3 went to receive additional systemic therapy, and this is the classification of different modality. The majority of the patient, irrespective of the cohort or hormonal treatment, received chemotherapy either in the first, second, or third line, and patient also received endocrine treatment and sometimes in combination with mTOR inhibitor. And a small group of patients received CDK4/6 inhibitor, particularly patients who were not treated with palbo in the PALOMA-3 study. 15 patients are still receiving the combination of palbo fulvestrant. 3 patients are still receiving the placebo fulvestrant. And the most common adverse event was essentially similar to what has been reported. Neutropenia, leukopenia are manageable, small fraction of infection, and in general, the safety profile was similar to what has been previously reported. So in conclusion, an improvement in the OS with palbociclib and the fulvestrant continues to be observed with more than 6 years of median follow-up in patients with hormonal receptor positive, HER2 negative advanced breast cancer that have progressed on prior endocrine treatment. This prolonged OS benefit is particularly evident in patients with endocrine sensitive disease and those without prior exposure to chemotherapy in the advanced disease. And this is the only study where analysis is possible. Finally, the OS is generally favorable with palbo across the group of the patient identified by ASR1 mutation, PIK3CA mutation, B53 mutation as detected by the circulating tumor DNA, and no new safety signals were identified. And these findings support the continued use of palbo fulvestrant as a standard of care for patients with luminal advanced breast cancer. And with that, I would like to thank you all for your kind attention.
Thank you, Dr. Mit'ab. Thank you for your review of this updated abstract in last ASCO 2020. And we'll move to the second talk. Before that, I would like to thank Dr. Isam and Dr. Abdulaziz and Dr. Mirfat and all organizing committee to give me this opportunity to share this educational meeting with you. So our next speaker will be Dr. Khair. She's a well-known national speaker. She's a medical oncology consultant at Dr. Sulaiman Al-Habib Medical Center, and she will review with us updated overall survival result from MONALEESA-3 post-menopausal patient with hormonal positive, HER2 negative advanced breast cancer treated with fulvestrant with ribociclib. So, Dr. Khair.
الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه وسلم. Good afternoon, everybody. First, I would like to thank the organizing committee, Dr. Assam Marshid, Dr. Abdelaziz Al-Hamad, and Dr. Marfat for the invitation to participate in this conference. I extend my thanks to the Dr. Aisha Al-Harbi for this nice introduction. The abstract given to me is the phase 3 Mona Lisa 3 study, ribociclib plus fulvestrant versus fulvestrant plus placebo extended update survival analysis. As you all know, ribociclib is one of the CDK4/6 inhibitor, which was approved for treatment of advanced hormonal positive HER2-negative breast cancer. Recently, Mona Lisa 7 study, which is a phase 3 study conducted in a premenopausal woman with hormonal positive HER2-negative metastatic breast cancer, was presented at ASCO and showed survival advantage, overall survival advantage. The study that I'm going to present is the Mona Lisa 3 trial, which the study which I'm going to present is the Mona Lisa 3 trial, evaluating, as I mentioned, ribociclib, fulvestrant versus fulvestrant placebo in postmenopausal women and men, hormonal positive, HER2-negative metastatic breast cancer. This is the updated overall survival. What's interesting about Mona Lisa 3 study, there was a pre-specified boundary. If it's reached, they have to do survival analysis. And it was presented earlier, the first landmark analysis at 36 months as well as 42 months, and median overall survival not reached yet. And this is the updated one that I'm going to present now. This is the design of the study, Mona Lisa 3 study, which is a phase 3 randomized 2-to-1 ribociclib plus fulvestrant versus placebo plus fulvestrant at a dose of ribociclib 600 daily for 3 weeks, 1 week off, and fulvestrant 500 milligram Q28 days, with exception of 1 extra dose on day 15 of cycle 1. What's interesting about this, or important point to note, is that 50% of patients enrolled in this study in the first line setting, where they completed either more than or equal 12 months of prior endocrine therapy or de novo metastasis. This is the overall survival in the overall population, men and postmenopausal women, advanced breast cancer, with first line as well as second line. And with an extended follow-up of more than 4 years, almost approaching 5 years, still the experimental arm demonstrate a clinically relevant survival advantage. If we looking exclusively to the patient treated in the first line setting, we can, as you see, there is marked improvement in the overall survival with almost not reached the overall survival, while it reached in the placebo arm 51.8 months, which give almost 36% risk reduction in death in the experimental arm as compared to the placebo arm. Again, even in the second-line setting, still ribociclib fulvestrant demonstrated a 6 months longer median overall survival over placebo in the second-line setting, 39.7 in the experimental arm versus 33.7 with a hazard ratio 0.78. This plot, first plot diagram, which showed that there is a consistent overall survival benefit over all subgroup, even with second line or first line, those with more than 3 sites analysis, even with visceral aggressive disease, lung or liver, as well as men and women. This is overall survival based on endocrine sensitivity. And again, there is a survival advantage in endocrine sensitive as well as endocrine resistant. What's important to note is the time to first chemotherapy. In the experimental arm, there is nearly 20 months delay in the first subsequent chemotherapy use over placebo arm. And I think this is very important point and interesting point, clinically relevant to our patients. Chemotherapy-free survival, which is defined from time of randomization to first a subsequent second-line therapy. It's also showed difference of approximately 10 months longer with the experimental arm, ribociclib plus fulvestrant over placebo fulvestrant. Another point, which is progression-free survival, second progression-free survival, which is defined from time of randomization to documented subsequent progression of disease from starting second point or second line with our chemotherapy or other. And this is again showed improvement with fulvestrant, especially if it's used ribociclib in the first setting. In terms of adverse events, there is no major changes from the previous Mona Lisa trial with long-term follow-up. And the most common, as you all know, hematological toxicity, neutropenia, leukopenia, anemia, and thrombocytopenia. With regard specifically to pulmonary toxicity, there is no more observed complication in terms of interstitial pneumonitis or hepatic toxicity with long-term follow-up. Again, QT interval reported in the placebo arm 1.2 versus almost 3% in the experimental arm with long-term follow-up. So in conclusion, this exploratory analysis with an extended median follow-up of overall survival almost to 56 months, almost 5 years, still ribociclib, fulvestrant maintain the overall survival benefit in postmenopausal patients with hormonal positive, HER2 negative, and this benefit was consistent across most patient subgroup in this setting. With ribociclib, fulvestrant, median overall survival 53.7 versus 41.5 months, with a hazard ratio almost 0.73. Again, Mona Lisa 3 remains the only randomized trial evaluating CD46 to demonstrate an overall survival benefit in postmenopausal patients, men and women with hormonal positive, HER2 negative advanced breast cancer in the first line setting. Ribociclib showed a delayed in use of chemotherapy of almost more than 20 months, which is really interesting. Finally, no new safety signs were detected with long-term follow-up approaching 5 years. With this, I will conclude, and this is the acknowledgement of all patients participated in this study. And finally, I would like to invite you all to our first hereditary cancer syndrome that it will be held next month, 29th, 30th October at Al Faisal University. Thank you.
Thank you very much, Dr. Al Khair, for the nice presentation of this abstract. I would like also to thank the organizing committee for inviting me to participate in this meeting. So the next speaker, it's my pleasure to introduce Dr. Ahmed Al-Wabari. He's a consultant medical oncologist at King Fahd Specialist Hospital in Dammam. Dr. Ahmed is going to speak about olaparib in the adjuvant setting, Olympia trial. This is after neoadjuvant chemotherapy in patients with germline BRCA1/2 mutation and high-risk HER2 negative early breast cancer. So please, Dr. Ahmed, the floor is yours.
Thank you for the introduction. I would like to thank the organizers for the invitation. I'm tasked to talk about the Olympia trial. And this is my disclosure. And the agenda today, a background, then we'll move on to talk about the Olympia. Some reason, okay. So BRCA mutation in general tends to produce a very aggressive breast cancer, breast tumors. They tend to happen at younger age and with high grade, with a tendency for brain metastasis and contralateral breast as well, disease, as well as a high risk for recurrence. Depending really on the source you look at, anywhere between 50 and 70% cumulated risk of having breast cancer with germline mutation of BRCA. Around 10% of all female breast cancers are associated with the BRCA mutation, and 20% of all familial breast cancer. In general, BRCA1 is more frequently associated with triple negative, and BRCA2 is more associated with ER positive and with male breast cancers. So the BRCA gene in its normal form is required for the DNA repair mechanism called homologous recombination. And when there is a mutation in the BRCA, the DNA repair mechanism or the cell finds itself forced to use a non-homologous enjoining and base excision repair, among other form of DNA repair. To do that, PADRM1 molecule has to be recruited for this process to happen. So if you inhibit PADRM, then you disrupt the DNA repair in the patients, or in the cells where there's BRCA mutation. Generally speaking, there are two forms of mutations in terms of BRCA or BRCAness. There's the germline, where all the DNA of the patients, of the cells of the patients are affected. And there's a somatic alteration where there's only the tumor cells are affected. We will be talking about the germline mutation in this talk. So in the neoadjuvant setting, PARPs and inhibitors have been used. Certainly one of the pilot studies by MD Anderson, 6 weeks of neoadjuvant talazoparib, then patients go for surgery and systemic therapy, and the primary endpoint is PCR. And it certainly showed, though this is a small number of patients, it showed that it increased the percentage of PCR and the residual cancer burden 1. And interestingly, it induced PCR on both metaplastic as well as lobular, so both ends of the spectrum of the disease grade and response to chemotherapy. The I-SPY2 recruited patients and randomized them to receive the standard chemotherapy as a neoadjuvant, Taxol and AC. And then the experimental arm is adding veliparib and carboplatin, and it showed that certainly in triple negative patients, the combination of veliparib and carboplatin induced more PCR than standard of care. Now, the brightness also was done in the neoadjuvant setting. This time, 634 patients were randomized to receive veliparib carboplatin and Taxol, or placebo carboplatin and Taxol, or placebo Taxol. Then all these patients, they went to go on AC, then surgery, and the primary endpoint is PCR. Unfortunately, this is a negative study. In fact, veliparib did not increase the PCR rate over the carboplatin arm, but increased the side effects. So based on that, the fact that we have the olaparib or the PARP inhibitors in the neoadjuvant that has some success, and as well as in the metastatic that has a positive studies in the metastatic setting approved for BRCA mutation. The Olympia is a phase 3 randomized trial that studied patients who have a high-risk disease with BRCA mutation. So men and women with BRCA1 and 2, with HER2 negative, high-risk primary breast cancer who completed the definitive local treatment, more than 6 cycles of adjuvant or neoadjuvant chemotherapy, including taxane and anthracycline with good performance status. 1,836 patients. They were stratified by the histology, so triple negative, who had prior neoadjuvant chemotherapy and PCR, or adjuvant chemotherapy for N1 or node positive disease, or T2 or more. This is the majority of the patients, 1,509. The other group is the hormone positive group with a prior neoadjuvant chemotherapy and PCR, and with CPSEG score of 3 and more, or those who receive adjuvant chemotherapy for N2 disease, or 4 lymph nodes and above. And this is 325 patients in this group. So the randomization was to olaparib 300 milligram BID for full 1 year as adjuvant treatment versus placebo for 1 year BID. And the primary endpoint here is invasive disease-free survival. Secondary endpoint, distant disease-free survival, overall survival, and safety. This is a pre-specified interim analysis that was triggered because of 165 events, invasive disease and death, that occurred in the first 900 patients enrolled. As far as the baseline characteristics, you know that BRCA tends to happen in early or younger patients. So these are patients in their 40s. BRCA1 was 70%, and BRCA2 was around 28%. Co-mutation of BRCA1 and BRCA2 is rare, and certainly less than 1% of patients enrolled in this trial. As far as chemotherapy goes, neoadjuvant and adjuvant chemotherapy, 50-50%. Majority of patients received the anthracycline and taxane. Only 26% of patients received platinum as neoadjuvant or adjuvant therapies. Once again, the premenopausal status of patient, more than 60% of patients were premenopausal, and more than 80% had a triple negative disease. More than 70% of patients had stage 2A and above. In the intention to treat analysis, the primary endpoint, which was the invasive disease-free survival, was certainly positive. The difference is 8.8%. Olaparib was 85.9 versus the placebo 77.1. The hazard ratio 0.58. That means that olaparib reduced the risk of invasive recurrence of death by 42% with a positive p-value. When you look at the incidence of second primary non-breast cancer, also 50, that was a 50% reduction in those cancers, including CNS metastasis, regional, local, contralateral, even second primary non-breast malignancy. They were also reduced by 50% in the olaparib arm. The invasive disease-free survival, the 3.5-year follow-up showed that the hazard ratio of 0.61, still the difference is 8.8%. So there wasn't a significant drop in the with the 3.5-year follow-up. Now, when we look at the subgroup analysis, I pointed out here that
Ahmed?
yes.
Sorry to interrupt you, but you have 2 minutes.
Okay. So the Olympia subgroup analysis here showed the patients who have received carboplatin as adjuvant and neoadjuvant, they were actually benefited from olaparib, which is interesting in my opinion. So the distant disease-free survival, which is a secondary endpoint, was showed 7.1% in favor of olaparib. So overall survival, though the hazard ratio 0.68 and p-value of 0.024, it did not reach statistical significant predefined by the statistician. 70% of patients completed the treatment according to protocol. Less than 10% of patients discontinued the treatment due to adverse events which were mild in the olaparib. In fact, anemia was the only one that's grade 3, more than 5%, and in less than 5% of patients required blood transfusion, and mostly single blood transfusion, and the quality of life, the health-related quality of life was not negatively impacted by olaparib. So the bottom line is that this is a new standard of care for patients with BRCA2, BRCA1 and 2 mutation, that there is an improvement in the invasive disease-free survival, as well as distance disease-free survival, and the safety profile was favorable. And this is, as we said, it's a standard of care now for patients to be tested in the early breast cancer stage to see if they are eligible to go on olaparib. Thank you very much.
Thank you, Dr. Ahmed, for your nice and excellent presentation. We'll move now to our next speaker, Dr. Talib Bouhlega. Dr. Talib Bouhlega is a consultant of medical oncology in Princess Sultan Military Medical City in Riyadh. He will present for us the data of ASCENT trial, the assessment of sacituzumab govitecan versus treatment choice by physician treatment choice in triple-negative metastatic breast cancer. Dr. Talib, the mic is yours. Dr. Talib. So, Talib, we cannot see your slides, and we didn't hear your voice.
if Dr. still have some problems, we can move to Dr. Murshid and then to come back. Or you are okay now? Are you okay, Dr. Talib?
Dr. Talib, you're muted.
Okay, just give me 1 minute because I already go out from my presentation. Yes, just give me 1 minute. I'll share my slides. Just. Sorry for this delay. Is it sharing now?
Yes.
Yes.
Sharing.
Sorry for this delay. Okay. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Sorry for this delay, and I would like first to welcome the audience and also to thanks the organizing committee and Dr. Majid for this nice introduction for me. I'm going to present the SNET trial, which is about the sacituzumab govitecan versus single agent chemotherapy in metastatic triple negative after 2 or more line 2 or more line of chemotherapy. As you know, the SNET trial is about the sacituzumab govitecan use, which is the antibody drug conjugate consisting of anti-TROP2 antibody conjugated via hydrolyzable linker to the topoisomerase 1 inhibitor, which is the SN38. It is recently get FDA approved. This trial was presented in the last ASCO after the phase 1 and 2 from the basket trial. So the design of this trial is it is an international randomized open label phase 3 trial. They recruit 529 patients, randomize the patient to 2 arms. The blue one, which is the sacituzumab govitecan group, and this is given IV 10 milligram per kg day 1 and day 8 every 21 day as a cycle. And the second arm is the physician choice of single agent chemotherapy. They include capecitabine, eribulin, gemcitabine, and venetoclax. The eligibility criteria was metastatic triple negative. They allow patient who received 2 or more line of chemotherapy, and also they allow patient who they had a recurrence within 12 months of receiving their neoadjuvant chemotherapy. And it should be a measurable disease by RECIST criteria, and also they allow patient to recruit in this trial with the brain mets if they have a stable disease more than or equal to 4 weeks before treatment, and the performance status, the ECOG is 0 to 1. The primary endpoint was progression-free survival. The secondary endpoint was investigator-assessed progression-free survival, overall response rate, a duration of response, safety. This is the baseline characteristic of this trial. It is well distributed between the 2 arms. As you see here, but if you look to the median age is around 54 in both almost 2 group, and also the tumor location, majority is lung, liver, axillary lymph node, and bone. Most of them, they receive previous chemotherapy 2 or 3 line of the patient, and also they allow patient to receive taxane as a new adjuvant treatment. This is the subgroup analysis between for a patient more than age of 65. As you see here, most of the patient is female, of course, and the performance status again it is 0 to 1, multi-ethnicity, prior chemotherapy 2 to 3 lines they receive it, and germline BRCA 1 or 2 was negative for almost all the patients. This is the subgroup analysis of the median progression-free survival between the age of 65 and more than 65. As you see in both curve and the Kaplan-Meier curve, there is a clear separation between the two lines, between the blue and the orange one, and the median progression-free survival in age less than 65 years is 4.6 months with hazard ratio of 0.46 with significant p-value. And also in age group more than 65, still the sacituzumab govitecan show improvement in the median progression-free survival reached to 7.1 a month compared to the chemotherapy, which is 2.4 with a significant hazard ratio of 0.22, and also the p-value, significant p-value. This is the same thing, the subgroup analysis for overall survival as a secondary endpoint, and it show improvement in the median overall survival in the age less than 65 by 11.2 in the sacituzumab govitecan group compared to the chemotherapy with hazard ratio 0.5. And if you look to the right side of your screen, in the age group more than 65, still the experimental arm, which is the sacituzumab govitecan group, show improvement actually more by 15.3 compared to chemotherapy, which is 8.2 with significant hazard ratio 0.37 and even p-value, significant p-value. This is a table that shows the response rate for experimental arm and also the chemotherapy, and also in age of less than 65 and more than 65. You see there is a good number in the sacituzumab govitecan group. They achieve a response compared to the chemotherapy. If you see in the left side of the table, it shows the response rate total number is 60 patients compared to the chemotherapy, which is 11. And if you look to the complete response in the experimental arm, 7 patients, they achieve complete response compared to the chemotherapy, which is only 2. And the partial response, most of them, which is around 53 patients compared to the chemotherapy. The median duration of response, if you look to the down of this table, is 5.8 in the age group less than 65, and age of more than 65, they reach to 7.1 months, the duration of response compared to the chemotherapy, which is less, about 3.6 months. This is just to show that the majority of side effect, as expected in this trial, they have more side effect in the sacituzumab govitecan group. They almost there is around 153 patients. They have side effect compared to the chemotherapy, which is around 115 in the age group of less than 65, and also the grade 3. Almost they have good number in the sacituzumab govitecan compared to the chemotherapy. The most side effect in the sacituzumab govitecan group, it is neutropenia, which is around 51% compared to a chemotherapy, which is around 30 to 35. Leukopenia, diarrhea, anemia, and febrile neutropenia, they had more in the sacituzumab govitecan group. This is just to summarize the subgroup analysis for progression-free survival. The median progression-free survival in the sacituzumab govitecan group is 5.6 months. compared to the chemotherapy. If you look at by eribulin is around 2.1 and virilibin is 1.6, gemcitabine is 2.6, and it is actually the hazard ratio is 0.41 with significant p-value. The overall survival event, the median overall survival is 12.1 months compared to the chemotherapy, which is less than almost 7 or 8 months. Response rate more with sacituzumab govitecan group more than the chemotherapy in terms of complete response or partial response. This is the subgroup analysis for patient. They receive a neoadjuvant chemotherapy, then they receive they have the recurrence. Later on, they receive the treatment arm, which is sacituzumab govitecan group. The median progression-free survival 5.7, and also the median overall survival is 10.9 months compared to the chemotherapy, which is 4.9. Also, the response rate is greater with this experimental arm than the chemotherapy. Even with a stable disease, they have better in the experimental arm. This is the side effect subgroup analysis of the side effect in the sacituzumab govitecan in a group of patients. They receive the neoadjuvant chemotherapy and they develop recurrence. The majority is neutropenia, alopecia, diarrhea, nausea, vomiting, and as you see the number in the experimental arm, they have more than the chemotherapy, and this is consistent actually with overall study population. There was no treatment-related death. Before I go on that slide, there's only one recorded case, but that was happened in the virilibin arm due to yes.
Sorry for interruption. You have 1 minute.
Yes, the conclusion. So this subgroup analysis in the phase 3 SNA trial show improvement in the progression-free survival, overall survival, and response rate in both age group, more than 60 or less than 60. This is a recently approved, and I think it is good drug now, especially for triple-negative breast cancer, as we have less option for them, only the chemotherapy. And now it is the immunotherapy. There's ongoing study that evaluating the sacituzumab govitecan and earlier setting, New Star and Sasika trial, which I think it need maybe in 1 year, maybe we'll have this result. Thank you. I'm sorry for the delay.
Thank you, Dr. Talib Bhlega. Now we'll move for next abstract review by Dr. Assam Murshid. He's a meeting actually chairman, and he's a director of Oncology department in Prince Sultan Medical Military City, Riyadh, and he will review the trastuzumab plus endocrine therapy or chemotherapy as a first line for metastatic breast cancer with hormonal positive, HER2-positive breast cancer. Dr. Assam.
Thank you very much, Dr. Aisha, and thanks everybody. You have to excuse us. Actually, this weekend is very hectic for BSMMC. We have just launched our Cerner system, and as head of department and as super users like Dr.
So Dr. Assam, can you load your voice more?
Sorry, I couldn't hear you.
We can't hear you well, Doctor. We can't hear you well.
Now you can?
Yeah.
Okay. You can hear me well now? It's not coming up.
Dr. Talib, can you please stop sharing?
I already stopped my sharing. I'm not sharing anything now, Dr. Meta.
Thank you, Otor. Today, it's not a good day for IT for us. With this. Shall I say? We got it on. All right. The abstract which I'm going to present today is abstract 1003, which was presented by the colleagues in China. It represents the testing trastuzumab plus chemotherapy or hormonal therapy as a first-line treatment of HER2 positive, ER positive disease. This is a randomized open label phase 3 clinical trial. Okay, so as we know that metastatic breast cancer with hormone positive, HER2 positive represent about 10% of all breast cancers. And almost the standard or the preferred treatment for those patients being HER2 positive usually is chemotherapy in combination with anti-HER2 medications. But in certain occasions in our practice, we are using hormonal therapy for patients either who are postmenopausal or patients who are not quite fit for chemotherapy or patient concerned about toxicity. But until this trial, almost that there was no evidence comparing chemotherapy plus anti-HER therapy head-to-head with chemotherapy plus hormonal therapy. The trial design, it's a randomized open label phase 3 clinical trial of many centers in China with eligibility criteria of patient older than 18 years of age, histologically confirmed metastatic breast cancer, hormone positive, HER2 positive disease with a disease-free interval of more than 12 months, with the major stratification factors of these patients actually based on the adjuvant endocrine therapy received, based on the chemotherapy, based on the disease status, i.e. recurrent versus de novo metastatic disease. And patients were randomized 1-to-1 into two groups. Group A to receive endocrine therapy plus trastuzumab, and Group B to receive chemotherapy plus trastuzumab. And the primary endpoint was progression-free survival, as calculated from the time of occurrence of the event. Secondary endpoint included, I can't see the slides, but anyhow, I'll just go ahead pretending that I'm seeing it. The secondary endpoint included overall survival, as well as response rate, objective response rate, and the safety profile. That's Mustafa. Okay, and this is the statistical analysis. We know that from the previous trials, which actually phase 2 or the practice, the median progression-free survival for chemotherapy is around 9 months, and for hormonal therapy with trastuzumab is about 7 months. And this is a non-inferiority trial with an inferiority margin of 1.3. And they have enrolled, actually, the enrollment started in September 2013 until December 2019. Again, the criteria of inclusion with the patient expectancy, life expectancy should be more than 12 weeks, disease-free interval of more than 12 months with very good performance status, and etc., as we mentioned before. So of the 412 patients assessed for eligibility, 392 patients were included and 20 excluded, either because they did not meet the inclusion criteria or because of declining or declination to participate in the trial, and patients were equally randomized between the two arms with almost very similar discontinuation rate, and the main discontinuation reason was disease progression progression, as well as death, adverse events, patient decision to withdraw from the trial, or they lost follow-up for one reason or the other. And currently, at the time of presentation, according to the presenter, there were about 8 patients in Arm A continuing treatment and 6 patients in Arm B continuing treatment. This is the baseline characteristic. As you can see, all characteristics were very well balanced between the 2 arms, and majority of patients were perimenopausal, and about 70% of patients had progression after adjuvant or relapse after adjuvant therapy. 30% of patients were de novo metastatic disease, and majority of patients had one site of metastasis. 30% of patients had 2 or more metastatic sites, with around 60% of visceral involvement in both arms. And all patients, almost 80% of patients were hormone positive ER/PR together, and about 20% of patients with either ER or PR positive. Around 30 up to 35% of patients had a disease-free interval of less than 24 months, and majority of patients, about 40%, had a disease-free interval of 24 months, namely those patients who progressed or relapsed after adjuvant treatment. The previous anti-HER therapy was given in about 20% of patients, and previous neoadjuvant treatment was almost like 70% of patients. And almost like 70% of patients receive one type of endocrine therapy, with their aromatase inhibitor for about 42% and tamoxifen for about 30% of patients. In terms of progression-free survival, there was a statistically significant difference, slight difference in favor of hormonal therapy. And that did not translate into overall survival, since the overall survival almost was similar in both groups. When you look at the subgroup analysis, you can find that most of the subgroups actually had similar outcome as the primary group, but there was an interesting observation that patients who relapsed within less than 24 months, they had better response in terms of chemotherapy, and those who relapsed of more than 24 months, they had better response to endocrine therapy versus chemotherapy. And also younger patients seems to be responding much better, a little bit better to chemotherapy rather than to endocrine therapy, although as we know, we cannot draw conclusions from the subgroup analysis, but this actually raises a question later, or a research question to explore this in the future. Of course, we know that the toxicity with chemotherapy is significantly higher than those for hormonal therapy, and there was no treatment-related deaths. In conclusion, trastuzumab plus endocrine therapy was non-inferior to chemotherapy plus trastuzumab, with fewer toxicity, of course, in the endocrine therapy arm. And in the exploratory analysis, as I said, that patient who had disease-free survival more than 24 months, they may benefit from hormonal therapy better, and it's better tolerated, of course, than chemotherapy, and it might represent a choice for those patients. It depends on your individual decision in the clinic. The same thing with those who had progression less than 24 months, they may respond to chemotherapy better, so chemotherapy may be preferred to those subset of patients. At the end, trastuzumab plus endocrine therapy could provide more convenient treatment to allow for better tolerance of those patients. And thank you very much for your listening.
Thank you very much, Dr. Issam Morshid, for a nice presentation, as usual, of this abstract. So over the next 25 minutes, we will go through this abstract discussions, which will be presented or discussed by Dr. Nikki Levitt. She is a medical oncologist from Churchill Hospital in London, United Kingdom. So she will go for this abstract discussion. Please, Dr. Nikki, the floor is yours.
Thank you. So I'm just trying to share. Are you able to see my slides?
Yes, yes.
Fantastic. So first of all, I would very much like to thank the organisers of this meeting for inviting me to come and discuss the abstracts. This is my disclosure slide. So first of all, I wanted to talk about triple negative breast cancer because there have been two very exciting developments discussed already this afternoon. Firstly, the role of sacituzumab govitecan in metastatic triple negative breast cancer. And secondly, the Olympia study looking at the use of adjuvant olaparib for germline BRCA mutated cancers, of which the majority were triple negative. So first, we've already had very well presented the phase 3 study of sacituzumab govitecan for metastatic triple negative breast cancer that was published in April of this year. In this study, patients were randomized 1-to-1 between sacituzumab govitecan versus any single agent chemotherapy of physician's choice, not any, and the over 50% of patients were treated with eribulin. All patients has had a prior taxane, and this was third line or later treatment. The primary endpoint was progression-free survival. Over 400 patients were entered into this study, and approximately 61 had brain metastases, which were excluded from this primary analysis. As you would expect with triple negative breast cancer, the median age was quite young at 54. And this study showed an improvement in the progression-free survival from a really very disappointing 1.7 months for the chemotherapy arm up to 5.6 months with sacituzumab govitecan with a hazard ratio. And at the cutoff point, there were still patients who were on sacituzumab govitecan, but none left on the chemotherapy arm. And the overall survival showed an improvement in overall survival of nearly 6 months with very impressive response rates. And sacituzumab govitecan did show more myelosuppression and diarrhea than chemotherapy, but was generally well tolerated. And just to remind people of the curves, this is the waterfall plot here showing a very impressive response rate for sacituzumab govitecan and clearly better than chemotherapy. This is the progression, chart A is the progression-free survival for patients without brain metastases, and D is the progression-free survival for everyone, and then the overall survival for patients without brain metastases in chart B. But you can see good separations of the curve. This is clearly a very positive trial. I just wanted to remind you of the forest plot, which really shows that sacituzumab govitecan was active in patients irrespective of age, race, geographical area of treatment, the number of prior chemotherapies, whether or not they had previously had immunotherapy, whether they had visceral disease, and whether their diagnosis was initially of triple negative breast cancer or whether their cancer had become triple negative on metastasizing. So it is now a decade since the EMBRACE study showed the benefit of eribulin in triple negative breast cancer. So I think we've waited quite a long time for a new advance in this area. I accept that there has, of course, been immunotherapy, but this is the first agent which has shown activity really across the board for triple negative breast cancer. I think this trial shows real clear clinical significant benefit for patients. And the data suggests that it is superior to our current practice with eribulin. The toxicity is manageable, and I think this trial confirms sacituzumab govitecan as standard third line or later therapy for the treatment of metastatic triple negative breast cancer. And as mentioned, there are a number of further studies underway looking at this agent, both within triple negative breast cancer earlier on, but also in other cancers. I wanted to change tack now briefly and just go over again the Olympia study, which is the first phase 3 trial of an adjuvant PARP inhibitor for breast cancer. So as discussed, the Olympia study looked at patients who had germline BRCA1 or BRCA2 mutations and who had significant disease. So they either needed to have disease left after neoadjuvant chemotherapy, or to have high risk disease if they were in the adjuvant setting of either T2 or node positive triple negative breast cancer, or if hormone receptor positive, they needed 4 or more lymph nodes to be involved. And this is because there was concern that olaparib may predispose women to be more likely to get myeloid dysplasia, and it was felt that that therefore patients needed to be at really higher risk of their breast cancer before entry into this study was warranted. Patients were randomized 1-to-1 to a year of olaparib. And just to remind you that over 70% of patients had BRCA1 and just under 30% had BRCA2 mutations. The invasive disease-free survival showed an 8.8% improvement at the 3-year mark, which was had a good hazard ratio and was statistically significant. One of the things that I think oncologists worry about with invasive disease-free survival is that is contains quite a lot of later cancer diagnoses, including contralateral breast cancer and ipsilateral recurrence. And what we very much worry about is actually the incidence of metastatic disease, so distant disease. And what was very reassuring in this study is that when the distant disease-free survival was looked at, that again showed a significant improvement, so 7.1% at 3 years, with a good hazard ratio that was statistically significant. So olaparib prevents metastatic cancer from occurring. The overall survival data showed a numerical improvement in overall survival at 3 years. That's not quite yet statistically significant, but I think you can see that these curves are separating, and I would anticipate that this will become statistically significant with further follow-up. Looking at the subgroup analyses, again, it's reassuring to note that olaparib appeared to have benefit across the pre-specified stratifications, in particular for both hormone receptor positive and triple negative breast cancer, and regardless as to whether it was a BRCA1 or BRCA2 mutation. Side effects were, as we would expect, more nausea, fatigue, and neutropenia, but appeared very manageable. So this is the first trial to demonstrate the benefit of a PARP inhibitor in the adjuvant setting in breast cancer. The data presented were a pre-planned interim analysis and showed a significant reduction in the risk of invasive relapsed disease. It was effective in both triple negative and HER2 positive and hormone receptor positive cancers. The overall survival is numerically there, but not significant yet, but it is very early follow-up, 3 years for an adjuvant study. But I think that this is practice changing for patients with germline BRCA cancers with high-risk disease. In the UK, we look at patient age, whether they have triple negative breast cancer, and the family history to decide which women we offer BRCA testing to. And I very much hope that this study will mean that we're able to expand BRCA testing to women with hormone receptor positive, 4-node or more positive disease, because we now have something that we can add in that is likely to be of benefit to them. Changing tack, I now wanted to talk to the updates on overall survival data for the 2 CDK4/6 inhibitors presented, Paloma-3 and Mona-Lisa-3. Paloma-3 is the trial of palbociclib and fulvestrant in postmenopausal women. And the important difference between this and the Mona-Lisa study, which is with ribociclib and fulvestrant, is that in Paloma-3, patients were allowed up to 1 line of chemotherapy for advanced disease. That was not allowed in Mona-Lisa-3. So looking first of all at the Paloma-3 study with palbociclib and fulvestrant. So as I've just said, patients were allowed up to 1 line of chemotherapy, and they could have progressed on or after endocrine therapy in the adjuvant or metastatic setting. This is the updated overall survival for these patients, and we can now see that, that there is a statistically significant improvement in median overall survival with the addition of palbociclib. Interestingly, this overall survival advantage appears to be largely limited to those patients who have not had prior chemotherapy. In the roughly 1/3 of patients who had prior chemotherapy, you can see the survival curves really overlie each other. And when that was looked at in a bit more detail, it appears to be those patients who had visceral disease who really did not get overall survival advantage from the palbociclib. In this updated study, they also presented the data looking at various genes which are commonly mutated in metastatic breast cancer. And I've just put up the picture for the ESR1 mutation, which again is a poor prognostic. Mutations in ESR1 give you a poor outlook. But just to say that palbociclib improved the outlook both in wild type and mutated ESR1, and that similar curves were followed through for both PIK3CA and TP53 mutations. And just heading over to the MONALEESA-3 study, this is with the ribociclib, again with fulvestrant in postmenopausal women. In this study, there was no prior chemotherapy allowed, but patients could have had up to 1 line of prior endocrine therapy for advanced disease. So slightly different entrance criteria to the 2 studies. This is looking in the first line, for women with the first line hormone, so those who'd relapsed more than a year after completing adjuvant chemotherapy or with de novo breast cancer. And this showed a significant improvement in overall survival, with the median overall survival not yet reached for ribociclib. In the second line relapse definition, so a more endocrine resistant population, we now have an improvement of at least 6 months in overall survival with the addition of ribociclib. So there was a meta-analysis last year which has shown that the addition of CDK4/6 inhibitors produces a significant improvement in overall survival, both with aromatase inhibitors and also in endocrine resistant patients with fulvestrant. I think the PALOMA-3 study brings palbociclib into line with the other CDK4/6 inhibitors, which have shown the improvement in overall survival earlier on in follow-up. And I think the data suggests that the benefit from CDK4/6 inhibitors is greatest when used earlier in the disease pathway, when patients are as endocrine sensitive as possible. My view of these studies is that there remains very little to choose between the CDK4/6 inhibitors in terms of efficacy, and I think we need to be very careful not to be very careful when looking at the different studies. I have just put the overall survival data up for these studies. I think the only thing that I would say is that when you look at the patients without prior chemotherapy in PALOMA-3 and compare them to those patients who were second line in the MONALEESA-3 studies, you do get very similar outlooks. And I think that that just shows that there is probably little difference between these agents in terms of efficacy. Just before I move on, I just wanted to mention that at the European Society of Medical Oncology meeting, which happened last weekend, there was data presented on MONALEESA-2, which is ribociclib and an aromatase inhibitor, so first line treatment, which is the first trial to show an improvement in overall survival in that setting. And there's now a median overall survival for over 3 years, which is, again, great news for patients as we creep forward with better treatment. So then finally, I just wanted to talk to the HER2 positive study that was presented. And this was an open label non-inferiority study that was carried out in China for patients with HER2 positive metastatic breast cancer who were randomized 1-to-1 to receive Herceptin with either chemotherapy or endocrine therapy. And the non-inferiority criteria were that were pre-specified were met. As we might expect, there was less toxicity seen in the endocrine therapy arm, but it also looked as though for those women, many of whom were younger, who were also younger, if they relapsed in under 2 years, then they possibly did get benefit from the chemotherapy and the subgroup analysis. So again, in the UK and the NHS, we really have to give anti-HER2 therapy with chemotherapy in the metastatic setting, despite the fact that I think we are all aware that there is synergy with endocrine therapy. And so I very much hope that this study will enable us to look again at this, because I think we all accept that Herceptin with endocrine therapy is a good option for more frail elderly patients who perhaps are not fit to have chemotherapy. However, for the majority of younger, fitter patients, I think treatment has evolved since then. And if I may, in the very last few minutes of my roundup, given that I was asked to talk about practice-changing treatments, I will just also mention the Destiny 3 study, which was presented last weekend at ESMO. This is a phase 3 study for metastatic HER2 positive breast cancer, and is looking second line after patients had received a taxane and Herceptin. 60% had also received pertuzumab, and patients were randomized to receive either trastuzumab deruxtecan or Kadcyla. Please excuse the rather dodgy nature of my slides, but I thought you would be interested in just seeing this very hot off the press data, which really shows that there is the primary endpoint for this trial was progression-free survival, and you can see that these curves separate very widely with benefit of TDXD. So the 12-month progression-free survival rate with Kadcyla was 34%, improving to nearly 76% with the TDXD. Looking at the subgroup analyses, TDXD appeared to be superior regardless of hormone receptor status prior pertuzumab treatment, whether or not patients had visceral disease, the number of lines of prior therapy, and whether or not patients had brain metastases. The overall survival data are promising. The curves look to be separating, but the data are not quite yet significant. The waterfall plot for overall response, Kadcyla is a good drug. This is a good waterfall plot. I think this is an exceptional waterfall plot with 95% of patients gaining some kind of benefit for the TDXD. The the safety data are reassuring. The most common adverse event causing discontinuation of TDXD was pneumonitis, which was an adverse event of special interest. And you can see that there is significant pneumonitis with TDXD, and certainly in comparison to Kadcyla. The other adverse event of special interest is the cardiac toxicity, which was really very manageable in both arms. So in conclusion, it does look as though TDXD has been demonstrated to have a clinically meaningful and statistically significant improvement in progression-free survival in comparison with Kadcyla, second line in HER2 positive metastatic breast cancer. There are encouraging overall survival data and a reasonable safety profile. And I just thought I would share this last slide, which came up from this discussion session after that, as I think it just gives a very nice now way of moving forward with lines of therapy for HER2-positive metastatic disease. And I hope that I have completed my session in time. Thank you.
Thank you, Dr. Nikki, for this nice and excellent discussion and presentation. We'll keep the question at the end of the session. And now we'll move to our next speaker. Our next speaker, Dr. Prof. Jean-Marc Nables. Prof. Nables is a well-known medical oncologist. He's a consultant medical oncologist in King Saud University. He will present for us a keynote lecture about the role of CDK4/6 inhibitor in adjuvant setting and who is the patient who will benefit from adding CDK4/6 inhibitor in the adjuvant setting. Prof. Nables, the floor is yours.
Yeah. Thank you very much for this very nice introduction. It's a pleasure actually to be here today, and I want to thank Dr. Essam Murshid for inviting me to participate in this meeting. Thank you very much. I was asked to look at CDK4/6 inhibitor in adjuvant breast cancer. What is the patient profile? And you know that we got some data recently. Yeah, sorry. So we got some data recently in adjuvant setting, and I think it's I was pleased, to be able to give some thoughts about the data we have available at this point. So what you know, and we just saw it right now, is in advanced breast cancer, the CDK4/6 inhibitors are clearly working very well. We start even to see survival improvement, significant survival improvement with palbociclib and ribociclib. So clearly these drugs are now totally standard in advanced breast cancer. The real question now, and when you look at the development of drugs, this is an old slide I presented in San Antonio 20-something years ago. The development of drugs usually is following a very specific path. We start in metastatic with single agent and we combine them with other agent. And only when really we see something in metastatic, we move to early breast cancer. In particular, when we start to see improvement of progression-free survival, improvement of overall survival, well, this is really the sign immediately to move in early breast cancer. Classically, we have seen significant improvement in early breast cancer when we had really significant improvement in advanced breast cancer. So the problem we are going to see with the CDK4/6 inhibitor, we start to have data, and it's interesting to look at them. Right now, we have 4 major trials actually running or already presenting data. 3, we have data. And with abemaciclib, the Monarch E trial. The Natalie trial will come later with ribociclib. What you have to realize is these trials, in fact, are interesting. The first Penelope trial, in fact, was using 1 year of adjuvant palbociclib. The second trial, the Pallas trial with palbociclib, was using 2 years, 2 years of exposure, and the Monarch E is using as well 2 years. And the Natalie, which is the last one, I think, which is running right now, I think we won't get result before first result 24-25, is using 3 years. And I think it's probably coming from what I'm going to show you, because there are some information we are getting from the first trials that are really starting to show that maybe we should actually extend the exposure to the CDK4/6 inhibitor. The Penelope B trial was done by the German group. Was a small trial. In fact, when you look at the sample size in adjuvant setting, 1,250 patients is a very, very, very small. Neoadjuvant chemotherapy, so patients who are not actually in complete remission, which is usually the case in this type of population, were actually randomized after surgery between palbociclib, the usual dose, versus placebo. 1 year of palbociclib versus placebo. You look at the results, clearly, I mean, they are not showing a significant improvement. When you look very carefully at the curve, the hazard ratio clearly was 0.93, so it was not good. But when you look at the curve, I was very interested because at the beginning, the curve are starting to dissociate, actually, and you realize that the microphone. Okay, it's working. I was cut for the microphone. I'm really sorry. So in fact, when you look at the curve, in fact, it's very interesting because at 12 months and 24 months, the curves were actually dissociating, which is very interesting. And then they got back together. I was very puzzled by this because somewhere started to think that the duration of exposure might be a significant factor in the use of CDK4/6 inhibitor in adjuvant setting. And when you look at the mechanism of action, actually, of CDK4/6 inhibitor seen on this slide, you all know this mechanism of action. It's a blockade, in fact, of the cell cycle. And the question is, in my mind, if you remove the blockade at some point, what's going to happen? I mean, we have previous history with bevacizumab, you remember, Avastin, in which anti-androgenic compound, in which, in fact, all the trials show progression-free survival improvement. That was clear. Never, ever any survival improvement. And we discovered progressively that after discontinuing bevacizumab, there was a rebound effect, actually. So the question here, when I saw this first data, I was kind of puzzled because, in fact, I'm wondering if the too early stopping of the CDK4/6 inhibitor in early breast cancer is not, in fact, impacting potentially the effect, the long-term effect in adjuvant setting. Well, so the PALAS trial is a different trial. It's a phase 3 open label study of palbociclib as adjuvant endocrine therapy, slightly different type of population. But the first thing you need to realize is the power, statistical power is much higher. Sample size 5,600, or really significant. And the randomization is done between palbociclib for 2 years this time, with endocrine treatment versus endocrine treatment without palbociclib. So you see here we have improvement, increase of the duration of exposure, primary endpoint in invasive disease-free survival, secondary endpoint are classically distant recurrence free metastasis, local regional recurrence free metastasis, overall survival, and safety. You can see the statistical plan on the right. Target ratio 0.75, 5,600 patients. So we are in a very, very good statistical process. And the data, you look at the population characteristics, you look that they are very well balanced between the two arms, actually. There is no significant difference. The primary endpoint initially at the second analysis was at 351 events, IDFS events. And then the big surprise, I think, when I look at these results, I was somewhere very, very surprised because you realize that the hazard ratio 0.93 for IDFS, duration of response 102, so absolutely no difference. And I was very surprised by that. And then subgroup analysis, as usually, no big difference. I mean, when you look, there is no positive test of heterogeneity, so you cannot say anything significant. The difference may come from safety and tolerability, in fact, because when I started to look at this trial, neutropenia grade 3 and 4 are relatively high. I mean, with palbociclib arm, close to 60% if you combine both of them. And in fact, this in fact, this problem may have induced a lot of discontinuation. And when you start to look at the rate of discontinuation, there is a significant rate of toxicity, so decreased doses, and rate of discontinuation. And when you look here at the reasons for treatment discontinuation, I mean, you have close to more than 40% of patients actually at the end had significant decrease of doses and then discontinuation, and which really, I mean, somewhere induce a downgrading, in fact, of the scientific hypothesis. I mean, if you have more than 40% of patients who are discontinuing the drug, ultimately, there is a real problem. So at the end, you might not have any more the power to show a difference. And this is a little bit shown here by these slides, showing to you that, in fact, when you look at the hazard ratio for palbociclib intake according to the duration, you realize that when you take the population which actually got the treatment for 2 years, actually, which is exactly what we're looking for, where the hazard ratio is significantly going down. So as opposed to those who stopped earlier. So somewhere, I'm talking as a methodologist of trials here, but this trial has a big flaw, actually, which is coming probably from the fact that the management of the toxicity, because neutropenia, in fact, of CDK4/6 inhibitor is not that dramatic. I mean, you need just to manage, follow the guidelines well. I have run a trial myself, a prospective phase 3 trial, in which we saw that people, our investigators, sometimes were managing the neutropenia toxicity of CDK4/6 inhibitor in a very weird way, tendency to decrease the doses very quickly. Well, in fact, it was not mandated according to the guidelines. So in those big trials, this quality control of the safety, adaptation of doses, and discontinuation is something which is extremely important. And you are going to see that it may make a difference with the next trial, actually, this argument. The next trial is the Monarch-E trial, extremely well-designed trial. I mean, the phase 3 trial, adjuvant setting. So luminal HER2 negative patient, node positive, high risk early breast cancer. We're talking about node positive, high risk only. So there is a substratification. I will not enter into details. The power, extremely high. I mean, 2-arm trial, 5,637 patients. It's very, very close to the scientific hypothesis of the PALAS trial. And the randomization between abemaciclib plus standard care endocrine therapy versus standard care endocrine therapy. So a very well-designed trial. Primary endpoint, invasive disease-free survival, as usually, and the secondary endpoint are displayed here, including overall survival. So the primary outcome analysis, I mean, was planned at 390 events with 85% power, assuming that the hazard ratio, the 0.73. So you can see it's very similar to the PALAS, where the hazard ratio in the scientific hypothesis was 0.75. So we are really in the same type, and this is a two-sided alpha for 0.05. For the ITT population, the number of events was 395. So there are some key analysis here. Well, you can have them, read them. So the accrual, as you can see, 2,808 patients in the abemaciclib arm, and 2829 in the hormone therapy arm alone. The critical point in this slide is the median follow-up. Median follow-up here is 19.1 months, which in early breast cancer, luminal breast cancer adjuvant treatment is extremely short. I think extremely short. I was actually surprised that by this very, very short median follow-up. When you start to look at the curves here, I would advise you to look at the upper curve, because the other one is not really, I mean, it's just giving you the impression it's massive. In fact, it's not. But nevertheless, I mean, there's a difference in favor of abemaciclib. The hazard ratio is 0.713, so which is really showing the 28.7 relative improvement in the odds to be free of disease in favor of adding abemaciclib as opposed to not having abemaciclib. Confidence interval, the upper limit is below 1, so clearly the p-value is going to be significant, and it is significant, 0.0009. So these results are, I think, extremely interesting. Showing, so when you look at the subgroups, clearly no subgroup is more beneficial than the other one. The test of heterogeneity is not identifying any subgroups which would lead to raising an hypothesis on the subgroup. All the p-values on the right are actually not significant. So you cannot tell much, and this is really the base of the talk, which patient to choose, actually. If we want to treat, who should we treat? So you are not going to get significant information from this subgroup analysis, unfortunately. It's like in metastatic setting, where it seems to work with all subgroups are benefiting. The problem is who are the patients in clinical practice we should prioritize. And you are not getting the answer here in this subgroup analysis. KI67, well, we're entering into subgroup analysis, so no value actually from my point of view. So distant relapse-free survival, so that was one of the secondary endpoint. It's clearly showing the same, I mean, hazard ratio 0.687, so it's significant. I mean, there is clearly something, there is a signal which is very, very important. When you look at the side effects, well, we knew from metastatic setting that the profile, the toxicity profile of abemaciclib different than the toxicity profile from palbociclib or ribociclib. We are more in the GI toxicity, diarrhea, and in fact than really neutropenia. And that's maybe what's somewhere may make a difference. There was some dose reduction. But in fact, what is very important to notice is in the discontinuation, and I think this is probably one of the big difference with the PALAS trial, in the sense that significantly less discontinuation. We are talking here about around 27%. I remember you have in PALAS is 42% discontinuation. So there is a significant, and I think the toxicity profile actually people are more afraid of neutropenia than grade 2 or 3 diarrhea. In fact, you can manage that relatively easily. Neutropenia in the psyche of the medical oncologist, we are thinking chemotherapy and febrile neutropenia, which is not the problem, in fact, here. But still, I see that one of the differences here is that the exposure, in fact, to abemaciclib in the MONARCH-E trial has been significantly more pronounced than the exposure to palbociclib in the PALAS trial, which may explain actually that we see something at 19 months. What then I've seen at ASCO, a very interesting exercise, which is really an analysis of subgroup. I mean, you wonder what people are doing to get something published as abstract in international meeting nowadays. I mean, I was horrified by that, because when you look at it was exposure to neoadjuvant. Exposure to neoadjuvant was said, in fact, to show something, but as you look at the subgroup analysis, initial analysis, the test of heterogeneity is completely negative. The p-value is 0.151, which means that you are not allowed to go much beyond that. I mean, this is not leading anywhere. And nevertheless, we saw presented a subgroup of subgroup in which in patients with prior neoadjuvant chemotherapy. So you can see here the population description of the various types of chemotherapies, the taxane with anthracycline or anthracycline without taxane or taxane with cyclophosphamide. And you get this type of slides, which from my point of view are totally useless. because it's just saying that if you get neoadjuvant chemotherapy, well, you may get a little bit more benefit until you didn't get neoadjuvant chemotherapy in favor of abemaciclib versus no abemaciclib. This is totally wrong conclusion. I'm thinking so. I wanted to show it to you because we're talking about ASCO 21. I'm utterly horrified by this type of thing. It is a waste of time and energy even to read it. The last trial, the Natalie trial, is really the one with 3 years, with ribociclib, and it's 3 years exposure to CDK4/6 inhibitor. And I think this is a very interesting trial because it will help us understanding a little bit better what's going on with CDK4/6 inhibitor. I'm waiting now for a 5 years trial, the trial with 5 years exposure to CDK4/6 inhibitor. In conclusion, I mean, I will stop here. Should we use CDK4/6 inhibitor in adjuvant setting? From my point of view, globally, the jury is still out. I think, honestly, basing a full strategy on some preliminary data with 19.1 months median follow-up in adjuvant setting of luminal HER2 negative tumor, this is a little bit borderline. The first problem is, are we going to see in the monarchy? We need more follow-up, because if we see the PELENOP B, the curve starting to dissociate, 1 year you stop, and 2.5 years, the curves are getting together. So my first question is, let's see what's going to happen, because I'm kind of a little bit leery. So the duration of exposure, from my point of view, with what we know, is extremely important. And you can see the philosophy of the trial started with 1 year. The first trial was PELENOP B. And then people understood maybe 2 years will be better. And then Natalie with ribociclib, it's 3 years. So, and I guess it might be 5 years ultimately. If it's 5 years, we might see really significant improvement. The problem in adjuvant setting here, as I was saying before, there are some differences between palbociclib and abemaciclib in terms of toxicity. And I think the potential differences in 2 years exposure in the PALACE and the MONARCH-E trial might be explained by the problem of toxicity, which was poorly managed in the PALACE trial. And finally, are there any profile we could today propose abemaciclib? I think with palbociclib, we have no argument to give palbociclib in adjuvant setting in 2021. With abemaciclib, some of us might be attracted by the fact that with a 19.1 month median follow-up data, where we might have some patients who could potentially benefit. Why not? I think the problem is no subgroup, or which patient should we potentially treat if we want to treat? I have no idea. So after that, this is what I'm calling the art of oncology. It's yourself in front of your patient who is deciding. Maybe the worst one, we think maybe, although the better one, they benefit as well. So after that, it's a discussion with the patient. At this point, I'm quite reluctant myself I'm not using actually at the present time CDK4/6 inhibitor in adjuvant setting, because I'm not sure that the data are strong enough. I'm afraid that in the monarchy, I want to see like data with 3 years or 4 years median follow-up to see if the curves are not getting back together. So, and the ribociclib, we'll see. I give you an appointment in 24, 25, and we'll see the first result at that time. Thank you very much.
Thank you very much, Prof. Nawals, for nice presentation. So now we have like 10 to 15 minutes. We'll open the floor for discussion and some questions. So if any question, so maybe I will start with one question.
Excuse me, there is no, we cannot hear your voice. If you can. Still, we cannot hear your voice, if you don't mind. Yeah.
Okay, so the question is, we have these CD4/6 inhibitors. So which one to use in the clinic if I have the 3 medications? We know that is on which patient profiles and according to what. So Dr. Mud'ib or Dr. Al-Khair,
I think so far from all the trial, we know that we need to use either one of them, but at least in the first line, it's more beneficial than second line. We will look at the difference between what I choose. It depends on the side effects and the patient in the front. It will be individualized according to the patient and what is her comorbidity. Maybe if I have a male patient, I lean towards ribo because at least there is data, though I believe all will be the same.
Okay, thank you. Dr. Mud'ib, please.
Yeah, so thank you again. So I totally agree with Dr. Al-Khair. I think all the 3 medications are efficacious in the metastatic setting. They have some different toxicity profile. We have now the encouraging result, as Dr. Nikki mentioned, from the last week Mona Lisa 2 trial, which actually showed a significant overall survival of approximately 12.5 months. So as mentioned again by Dr. Nikki, this is really very encouraging time for our patient. We know before that the median overall survival for the luminal metastatic disease is 3 years. Now we have 64 months, so we are exceeding the 5 years landmark. And if you will look at the control, the AI in the Mona Lisa 2, the median overall survival was 51 months. So this is again with the control. I think now the clinical trials, they are choosing and selecting really very appropriate patient for the clinical trials. Still, we don't have data from the Paloma 2, so the overall survival data are immature. Still, we don't have data from the Monarch 3. So I think this data will be published maybe at the end of the year. This is what I have in regard to this topic. I don't know if Nikki has different opinion.
No, I think I very much share the opinions already voiced, that really the efficacy data is very similar across all 3 agents. And so really you're looking at side effects. I think ribociclib does perhaps have the better data for younger women treated with gaserelin and hormonal therapy. Lily would like you to believe that that abemaciclib may be slightly better for those patients who've got visceral disease. I think we all like the simplicity of the palbociclib. I really think it's a matter more of side effects currently than any efficacy data.
Dr. Amin, can I ask a question for Dr. Nabholz?
Yes, of course. Go ahead.
I really enjoy, Prof, your talk about the adjuvant CDK4/6 inhibitor. And since we are talking about the CDK4/6 inhibitor, my question is, there is really very interesting data from the Mona Lisa trial when they looked at the molecular subtyping of the hormone receptor positive, HER2 negative. And it's instead of just looking at the clinical feature, why we don't look at the molecular subtyping? So it was published in the GCO, and they showed that patient who has triple negative subtyping, they don't benefit from the CDK4/6 inhibitor. The luminal A, the luminal B, they benefit from this agent. So what do you think about this and the clinical decision?
Well, I think you are right. I think, I mean, so far what we know is that it's working in luminal A and B. I think the problem from the trials is that the luminal A are much more indolent than the luminal B. So when I'm hearing people who have to choose, which is because unfortunately we're in some countries where we don't have access for all patients. I'm hearing mixed responses. People are saying to me only luminal B should be treated because it's a bad disease, in brackets. Luminal A with hormone is enough. What I think is all these patients actually are benefiting. The problem is within the groups, who is really benefiting? So we are still in this problem in the clinic. I mean, when we have patients, when we have access to CDK4/6 inhibitor without limitation, well, it's easy. I mean, you give hormone therapy plus CDK4/6.
No. Hello? There's no voice.
Metastases and luminal B visceral metastases, because we know they're going to relapse quickly, so we need to act. Why not? I think, but also I would say to you, if you choose luminal A with bone metastases, the improvement in progression-free survival in months is much higher. So the problem is until we're going to get reliable, upfront, predictive combination of factors, extremely difficult. So at this point, if I can, I will give to all of them. Now to choose between which ones, it's a pragmatic. I agree with the previous speakers that in fact they are very similar in terms of efficacy. There's no doubt about it. What I'm seeing in our region is there might be some differences because of toxicity. Because the management of toxicity, I've been amazed, as I was saying, even within trials, prospective trials we run, that people were not managing the neutropenia the way it should be managed. And somewhere the diarrhea might be easier to manage. So, and that's what explains maybe some differences in some trials. So the practicality is also important in the choice of drug.
I have one question for Dr. Assam and Dr. Nikki, if you can comment on it. The HER2 trial, the one by Chinese, we know that the standard of care is to start patient with metastatic first-line setting on dual blockade, like pertuzumab plus. And what they did is only trastuzumab plus chemotherapy versus endocrine therapy with, what do you think about the design?
Okay, I think the design was based on the standard at the time that they have thought of the trial, which was trastuzumab plus chemotherapy, and that was the standard of choice at that time. Whether adding pertuzumab, we know that adding pertuzumab to chemotherapy actually
Sound. We cannot hear Dr. Assam.
صوت مشوش.
Can you hear me now?
Yes, we can.
Okay. I think someone Nick will just go away today. Anyhow, what I was saying, I think you didn't hear everything, so I shall start from the start. Okay, the question of Dr. Malkhair was the design of the trial did not include the standard of care now, which is the dual inhibition plus chemotherapy. And my response was that at the time they have sat down the steering committee and they have designed their trial, the standard of that time was trastuzumab plus chemotherapy. And I think that was the standard of care they have compared their investigation on arm 2. But we know that later on, when you add pertuzumab to trastuzumab plus chemotherapy, it was superior, so the benefit is still there. And the most important thing in this trial that it tested the combination of anti-HER2 plus endocrine therapy in the first line setting for patients with metastatic breast cancer is not inferior to the combination of anti-HER2 plus chemotherapy. And we know that based on the biological data, we thought we all the time we think, or we know that HER2 positive patient, they do worse and they need chemotherapy with the HER2 initially, and then you continue maintenance on HER2. I think the same thing goes for endocrine therapy. What I'm interested in is that the long-term follow-up of, because we use endocrine therapy actually continuous, okay, until progression, apart from chemotherapy where we give about 6 cycles and then we stop and we maintain with the anti-HER2. I'm interested actually to find out the long-term data of the continuous use of hormonal therapy with anti-HER2 until progression, whether it is superior in terms of survival or not, plus adding the combination of, I think I'll let Dr. Naples, I think there was no superiority of each over the other. It was only, it depends on the menopausal status.
Yeah, I think I was a little bit surprised by this trial actually. The fact of comparing hormone therapy to chemotherapy with anti-HER2, well, I agree it would have been more optimal to get a double hit, but even the single hit with trastuzumab is not necessarily spoiling the question hormone versus chemo. The concern I have is double. First, we know, and I'm working in Middle East and running trials in the area before having run trials globally. The experience we had in China when I was running the HER2 program with Denis Lemon at UCLA was the problem of reliability of definition of HER2 positivity. So the first problem I have with this trial is I'm not totally convinced that this is it should be checked and it should be double checked because the results are very surprising. I mean, what we knew from UCLA, the initial data in terms of hormone sensitivity in HER2 positive tumor, tamoxifen that seems to be the least powerful. AI a little bit more powerful, and the best drug was the fulvestrant, the Faslodex. So, and we have experience with Faslodex plus anti-HER2, I mean, which is pretty good. So I'm kind of surprised because they had a lot of tamoxifen, as far as I have understood, in this trial, plus AI. So I would not draw any definitive conclusion on this trial. I would rather say, well, maybe there is something, though a confirmatory trial should be done and well done with the control of the HER2 positivity.
Yeah, can I comment, Prof, to the same question of Dr. Malkhair? And this is to support also the PADRM trial, which is a phase 2 clinical trial, which looked at the trastuzumab and endocrine treatment. In one arm, there's a pertuzumab, trastuzumab, and endocrine treatment. Actually, the dual anti-HER2 plus endocrine treatment was superior to the mono anti-HER2 treatment. So yeah, I agree that this clinical trial is just as mentioned by Nikki. We can use it for the frail patient who might not tolerate the chemotherapy, and we might extrapolate by adding dual anti-HER2 treatment. Nikki, any comment?
I think most of the good points have been made. I think it would be very nice to see whether there could be a trial in the more frail or the older patients, looking at maybe weekly Taxol versus an AI with dual blockade. I think that would be very useful and helpful. I think that the trial as presented, as was said, I think patients started recruitment from 2013. So when that trial was designed, it probably was a reasonable standard of care. I'm not quite sure how much. I don't think it's likely to be hugely practice changing in 2021.
I think there is a question from the audience, Dr. Amin. Yeah, the question, Dr. Amin. There is a question from the audience. One of the audience. I would like to direct it to Dr. Wabari, and we can hear a comment from Dr. Nikki regarding in the patient with hormone receptor positive and BRCA positive with the new options of CDK4/6 inhibitors and PARP inhibitors, how it can fit, how we can arrange the treatment in such a category of patient. Dr. Ahmed?
Yeah, I think evidence is strongly behind olaparib at this point. If there is a germline mutation, and obviously patient fits the criteria for olaparib, I would go with olaparib. In case of no germline mutation and the patient has very high risk disease, like into high grade and whatnot, I do consider adding abemaciclib for these patients, given the current evidence. I understand that the evidence has lost some momentum with more follow-up, but at the current point, I suggest that for those with high-risk patients, abemaciclib can be offered, especially for those young patients. Thank you.
I have a question for Dr. if you don't mind.
Yes, go ahead.
For Dr. Mativ and Dr. Nikki.
For the sake of time, we will make this question.
For premenopausal ladies with metastatic breast cancer, hormonal positive, and they presented with leptomeningeal disease and brain mets and also other visual disease, do you still recommend to give an oral CDK4/6 inhibitor with endocrine therapy, or you go ahead with the chemotherapy?
I think my experience of women with leptomeningeal disease is that it is a very miserable prognosis with a life expectancy of weeks. And actually, I think if you have true leptomeningeal disease, you should be focusing on really good palliative care and making sure that they have the best possible quality of life, because I think their life is going to be very short. I don't think there's probably any benefit from chemotherapy. If they were good performance status, I might try endocrine therapy in hope rather than expectation.
With oral CDK4/6 inhibitor, endocrine, if they have good performance status?
Yeah, I think I probably would, but I don't think there's probably evidence to back me up. Because I think sometimes I'm treating the doctor rather than the patient.
Actually, I'm faced this one in one of my patient. She presented with leptomeningeal disease after adjuvant treatment. So the question is to start what? Chemo or oral CDK4/6 inhibitor? And she's not in visual crisis.
I suppose I would say that there's pretty good evidence that chemotherapy doesn't work. So I think that there may not be evidence that the hormonal therapy with the CDK6 inhibitor does work, but there is perhaps less evidence that it doesn't work. So I think I would go with the hormone therapy and the CDK4/6 inhibitor.
Okay, thank you.
I think Yes, last comment from Dr. Malkhair.
I want to comment on the previous question with the PARP inhibitor, BRCA mutant plus hormonal positive. If we have the sequence, we prefer, I think there is data showing that those with the BRCA mutation, they don't respond well to CDK4/6 inhibitor. So we will start with PARP inhibitor first, and then if they progress, we use the CDK4/6.
Okay, thank you very much. By this, for the sake of the time, we know there is a lot of questions, but we will close this session. Thank you very much for all speakers for their nice presentation, and we will move for the next.
Okay, thank you, Amin. Thank you, guys. Thank you, Professor Dr. Malkhair, everybody. We are ahead of schedule by 1 hour because of a mistake in typing the schedule itself. So what we will do now, we'll break for about 10 or 15 minutes for prayer and just for coffee. We'll reconvene here after about 10 to 15 minutes, please. Okay, so 4:45 according to Dr. Nasser. Thank you very much, and we'll see you in 10 minutes time. نبدأ مع مين أول واحد؟ بس اتأكدوا اوكي طيب بسم الله الرحمن الرحيم. We'll start the satellite symposia starting with the Eli Lilly and Company symposium, which is the abemaciclib in metastatic breast cancer, a real life experience, which is going to be presented by Dr. Abdullah Twergi. Abdullah is a senior medical oncologist consultant in the Comprehensive Cancer Center in King Fahd Medical City in Riyadh, and he is an expert, well-known expert in the field of breast cancer. Abdullah, please, you have 20 minutes.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Assam, for such introduction, and thanks really for sponsoring this activity. So I have been asked to share some of our experience with abemaciclib in metastatic breast cancer with supporting data. So that's my disclosure. So the first case I have is a 55-year-old with a history of left breast cancer, T3N1, hormone positive, HER2 negative. She was diagnosed and treated in 2018 with a neoadjuvant chemo, mastectomy, radiotherapy, then tamoxifen, as she was perimenopausal at that time. She came at her regular follow-up in December 2020 with a bone pain and abdominal discomfort. She lost a bit of weight over the last 6 months. She was postmenopausal and her performance was quite good. Because of those symptoms, I have requested a bunch of staging workup, including CT scans and bone scans. And as you can see here, those scans showed extensive bone and multiple liver mets. The largest was at segment 6 and measured 4.6 centimeter in size. Her labs also was okay, and she wasn't really in a visceral crisis. It has been 2 years from her initial pathology, so I thought maybe I should repeat the pathology from the liver to reassess the receptors, and hopefully we might get some also biomarkers. Liver biopsy was consistent with invasive ductal carcinoma. It was a grade 2 ER/BR positive, HER2 negative. Ki-67 was a bit highish at 30%. So in summary, we have this lady with metastatic breast cancer, hormone positive, HER2 negative, with bone and liver mets. She progressed or relapsed while on adjuvant endocrine. In such scenario, what would be the first line treatment? So as you know, the treatment for metastatic hormone positive breast cancer is quite evolving from 1970 with different endocrine therapy, tamoxifen, AI, then fulvestrant, then development of number of targeted therapy that was started with mTOR's inhibitor. But with the arrival of CDK4/6, those agents have changed dramatically the way we treat breast cancer. And now we have 3 FDA-approved agents, including palbo, ribo, and lastly, abemaciclib. And all of these agents was approved either in first or second line in combination with endocrine therapy. The only exception, probably the abemaciclib, which also has been approved as a monotherapy in subsequent treatment. As all of these agents were tested in a first-line setting with different endocrine partner, but mostly aromatase inhibitor. What we have seen is consistent benefit with PFS with any one of those combination strategy with almost similar hazard ratio, as you can see here in red. Those PFS benefit was also supported by an overall survival benefit that was seen and was seen in most of the mature data from a second line setting, and some selected also trial in the first setting that also has been updated a while ago. Monarch 3 was a phase 3 trial that has been addressed abemaciclib in front line setting combined with aromatase inhibitor. This trial included postmenopausal women. Some of them have number of concerning clinical findings, such as prior endocrine or chemo in both adjuvant or neoadjuvant, short disease-free interval, as well as the visceral involvement. The primary endpoint for this trial was met with doubling of PFS from more than 1 year to 2 years and a half, and in favor of the combination arm. Such benefit also was seen in some of those concerning clinical findings, such as liver mets in one of the exploratory analysis from 7 months to 15 months, including also those with short disease-free interval of less than 36 months from 9 with endocrine therapy alone to a 29-month with the combination. Such benefit also was seen across all the subgroup of patients that were included in this trial. The response rate was also an important endpoint, especially to patients with a visceral disease or liver mets in particular. And this was also found to be more than 50% with the combination arm. And in fact, this benefit or this response rate was sustainable as well. Though we are adding new agent and with its own toxicity, but despite of that, the quality of life was maintained, and we can see that in both arms in the Monarch 3. So the summary, we have this lady with metastatic breast cancer, hormone positive, HER2 negative with bone and liver mets. She relapsed while on adjuvant endocrine with short disease-free interval of less than 36 months. In such scenario, what will be your first-line treatment? So what happened with this case? This lady was started on a combination of letrozole with CDK4/6 inhibitor, which was abemaciclib in this case. Patient was having a very nice response on liver mets, and the maximum response to date was exceeding 50% on one of the largest lesions, as you can see here. Treatment was well tolerated with only grade 1 to 2 toxicity that did not really require any dose reduction to date. The second scenario I have is another lady with, her name is Salha. She is a 60-year-old lady with and diagnosed earlier as metastatic breast cancer that was confined to bone only. Her initial diagnosis was at private hospital where she did mastectomy with the pathology proven invasive lobular carcinoma. It was a grade 2 ER/PR positive, more than 95%, HER2 negative, and low Ki-67 of less than 5%. At that time, CDK4/6 was not really widely available, so she was treated with a single agent letrozole. When I saw her, she was doing well on that. So therefore, I carried on just a single agent letrozole. And frankly speaking, she did quite well for more than 3 years on a single agent. And this really had the question about the proper timing and the sequence of combo treatment. Anyway, patient was presented in January 2021 with worsening bone pain. She was postmenopausal with multiple comorbidity that are listed down here, but her performance was quite good and reasonable. So her repeat images was consistent with the further disease progression with bone only with compression fracture at one of the spinal lesion. When I deal with bone mets, the interpretation might be quite difficult. Therefore, I always look at the tumor markers, and because it might be quite useful to tell you where the disease is going. And here is the tumor marker, as you can see, is going up. And such finding plus the symptoms and images, it's mean that we have to do some changes. So in summary, we have this lady with metastatic breast cancer, hormone positive, HER2 negative with bone-only mets. She progressed while on single agent AI. In such case scenario, what will be your preferred second line therapy? So in such scenario, we have different options. Definitely, this time you need to add CDK4/6 agent, and you need to change also the aromatase inhibitor to fulvestrant. And in this table, we have all the supporting data. All of those trial was positive with similar hazard ratio. That also later on, we also have survival benefit that showed in the earlier slide and also was discussed earlier in this meeting. Monarch trial was one of those trials that looked at abemaciclib. It was a phase 3 for those who have been progressed on a prior endocrine therapy. It was randomized to either fulvestrant or fulvestrant with addition of abemaciclib. 20% of those patients included were de novo or bone-only mets, and 50% have visceral, 25% have primary resistance tumor. The result was in the line of other trial with a significant benefit that was seen at progression-free survival. It was doubled from 9 to 16 months on the earlier presentation. And here also we have seen an overall survival benefit with almost kind of a 10-month absolute difference in the favor of the combination. Patient now, they can live for 4 years or more. Those also with concerning clinical finding, primary resistant were included in the pre-planned subgroup analysis, which showed also significant benefit in both PFS and overall survival with almost 7-month gain in overall survival. Same thing we have seen with visceral involvement, both PFS and overall survival showed a clear benefit, and another 8 months to the survival for those in favor of combination treatment. Response rate, even in a second line setting, we have seen same 50% response rate that also was durable as well. And most importantly, other endpoint, which I believe also as are important clinically, is the time to chemotherapy. With those agents, you can able to delay the need of chemotherapy by another 50 months. Anyhow, back to this 60-year-old lady with hormone-positive breast cancer with mets to bone only, and she progressed on a single agent letrozole after 3 years of the treatment. She was quite symptomatic, and initially she got palliative radiation to the spine where she has bone pain. But the question is, what will be the second line treatment? After that, this lady was in fact started on a fulvestrant with CDK4/6 inhibitor, and this was abemaciclib in this case. She was having bone-only mets, and as you know, the images was not quite useful. So while patient was on a single agent letrozole, the tumor markers was going up, and that was going with her symptoms that I have mentioned earlier. She was treated with palliative radiation to the spine, and then she was started on a combination from January 2021. As you can see here, the tumor markers start to go down together with her symptoms, and as well as there was some sclerosis finding that was seen in the bone scan suggestive of response. she have tolerated the treatment quite well, apart from a grade 2 diarrhea and fatigue, in which that led to holding the drug for only 1 week, then we resume at the same dose. As you know, the classical side effect that we have for CDK4/6 is more kind of hematological toxicity. When it comes to a grade 3 toxicity, neutropenia is one of the commonest with all CDK4/6 inhibitor. It seemed common with palbo and ribo in more than 50%, less with abemaciclib in around 20%. QT prolongation is somehow classical for ribociclib compared to other CDK4/6 inhibitors. On the other hand, GI toxicity, especially the diarrhea, is more classical with abemaciclib compared to palbo or ribo. Grade 3 per se is occur in 9% in patients with treated with abemaciclib. Liver toxicity, though it's less common, but it should be not overlooked, and because this might be serious if left untreated. Transaminases, as you can see here, is less common in less than 5% in both abema and palbo, around 8% with ribo. And lastly, the fatigue, which seems somehow classic class effect, and it's occur in a 2% across all those with CDK4/6 inhibitor. When you treat with a patient with abemaciclib, you need always to keep your eyes on a diarrhea. Grade 3 diarrhea is across MONARCH trial ranging from a 10 to a 20%. It's a bit higher with the earlier trials, MONARCH 1, but it's become less as we move on with MONARCH 2 and 3. To be proactive, you should know that when it does happen, and then you can see that the time of onset usually in the first 2 weeks. So the education and being proactive measures is always the key. What's quite reassuring is most of this will be recovered as we move on over the time. And as you can see here is the severity of a diarrhea get less as we move on. It seemed high in the first few cycles, but the severity get less as we move forward. So education is really important, and the moment you prescribe abemaciclib, I think is the time where you need to prescribe also loperamide and educate your patient what they should do if this happened. With the first sign of loose stool, you should start loperamide and get more oral fluid. And then you need to grade that just to know what you should do. For both grade 1 and 2, for example, dose reduction, most of the time is not really required. It might be required for a grade 2 if this has persist or recur despite dose delay. But definitely, those must be reduced when you come across a grade 3 or 4, or you have more than 7 loose motion occur, or after suspension, or if someone get hospitalized because of that. With this, I think I have reached to my last slide, and so thank you so much for listening. I hope I'm within the 20 minutes, Dr. Assam.
4 minutes. We can have some questions if you are interested, or shall we move into the next one? Okay. Abdullah, I have just one comment. I'd like your input in that. I do say that some of the side effects where you can prevent it or actually decrease the impact of it on the quality of life is a challenge as much as of the treatment outcome. And the most important actually thing in the setting is diarrhea. Diarrhea, though, is very disturbing, okay, very embarrassing, but if you dealt with it to prevent it as early as possible, you could actually improve the quality of life of your patient. And when you see the initial trials of abemaciclib, where the incidence of diarrhea was about 85 to 90%, where they did not use upfront antidiarrheal agents, and then you compare it to the real-time or real-life practice, that we see diarrhea very less frequently than what was reported in the initial trial. So what do you think about this?
I am 100% agree. I think the diarrhea, it's probably is one of the common side effects that we do see with different agents, but if this left untreated, it might be quite serious. So the education is really important. First, patients need to be aware that this is a very common side effect, and not just common, but it can happen within the first few weeks. So patients need to be aware. They need to have the prescription ahead of time. They should be instructed what they should do if this happen. And also they should have kind of hotline, especially the first, it's not just a short follow-up at your clinic, but also they need to have some communication. When they have a complaint or they have issues, they should have kind of an hotline where they can reach you just to have more instruction, what they should do, and what are any recommendation that you would do. And if you put that ahead of time, and if patient aware, and they know what they should do when it happen, and they already have the prescription, and they know that they can reach you at any time, I don't think the area would be a problem. And usually, as we can see here in the last few slides, it's probably common the first few weeks, but as we move on, this area is not been a problem. And I do prescribe loperamide in the first with the first prescription. But when I follow up those patients after 2 or 3 months, they're not really longer require loperamide. So most of the time the diarrhea is being controlled, or probably the loperamide, and the issue is not really becoming a big issue as the patient start to learn how to work on that, and is not really a significant problem. Probably is in the first few months only.
Thank you, Abdullah. And really, it was a pleasure hearing you talking to us today. Thank you very much, and we hope to see you in person later, inshallah. Now we move to the next satellite symposium, which is for Novartis Oncology, and the topic is moving toward precision medicine for advanced breast cancer. And our speaker, a distinguished speaker we have among us today, Dr. Aisha Al-Harbi. Dr. Aisha is a consultant medical oncologist at King Fahd Military Hospital in Jeddah. Aisha, the floor is yours, 20 minutes with discussion. Thank you.
Okay, thank you, Dr. Aisam. And also I would like to thank Novartis to give me this opportunity to present this topic. As we said, Doctor, as we are in the era of precision medicine, and we're treating now our tumor based on the molecular biomarker. So PIK3 inhibitor is an example of that. So just I will go briefly about the introduction about metastatic breast cancer and magnitude of the problem. Then I go just simply or quickly highlighting the concept of dual targeted agent in hormonal positive, HER2 negative metastatic breast cancer. Discuss the role of PIK3 pathway in hormonal positive, HER2 negative, and review the clinical evidence of alpelisib in hormonal positive, HER2 negative metastatic breast cancer. How to manage the common toxicity of alpelisib, and finally highlight the latest NCCN guidelines regarding hormonal positive, HER2 negative. As we see here, 18 million of cancer diagnosed. This is as per a global count from WHO in 2018, and the metastatic breast cancer range from 5 to 15 or higher in some country. Around 65 or 2/3 of cases are metastatic breast cancer are hormonal positive, HER2 negative. If we go to our Saudi or our kingdom data, this is from Saudi Cancer Registry in 2016. We see here about 15 to 18 of cases diagnosed in advanced stage. Median age of breast cancer patient is 47, so diagnosed very young. This reflects how disease has considerable impact on patient and family. Half of cases of early stage will later develop metastatic disease, and 2/3 of cases are hormonal positive. We know the trend since last 15 years trying to combine targeted agent with hormonal therapy, and in hormonal sensitive cell they will depend on estrogen for activation of estrogen receptor pathway. In the setting of endocrine resistance, other pathways are activated, such as PI3K or mTOR pathway, with the idea of dual target agent may help in suppress tumor progression or cellular proliferation. So the first study that including the target agent with hormonal therapy is Bolero-2, which has showed some benefit of with about 10.6 months of PFS versus hormonal therapy alone. Other pathways are involved in cell progression and tumor proliferation, which is CDK4/6 inhibitor plus cyclin D1 complex. With activation of this pathway leads to cell proliferation and also tumor progression. There are 3 oral target agents that targeting this complex, which is palbociclib, ribociclib, and abemaciclib. And we know all the first trial that lead to approval of this CDK4/6 inhibitor as a front line, which is Paloma-2. Then the other 2 trials, Mona-Lisa-2 and Monarch-3, which was discussed in detail with Dr. Abdullah. It has similar BFS value and make big shift in the treatment of hormonal positive, HER2 negative. It was really practice changing. But unfortunately, despite that, not all patients will progress with CDK4/6 inhibitor. So there is one pathway that leads to patient to progress or develop resistance to CDK4/6 inhibitor. One of this pathways activation of PI3K ACT mTOR pathway. So activation of this pathway leads to acquired resistance to the CDK4/6 inhibitor. So what is PIK3CA mutation? PIK3CA mutation, as we said, the activation of this pathway lead to endocrine resistant in hormonal positive, HER2 negative advanced breast cancer. Actually, it's really a common mutated gene. It's about 40% of patients with hormonal positive, HER2 negative has this mutation. So patients with PIK3CA mutation will face worse prognosis, as has a negative prognostic biomarker in breast cancer. When to do the test, as per NCCN guidelines, it should be as initial metastatic diagnosis or as initial workup in metastatic breast cancer, hormonal positive, HER2 negative. We can do this either through tissue biopsy or liquid biopsy. If we did a liquid biopsy and the result was negative, as this kind of biopsy has low sensitivity to the PIK3CA mutation, we have to do a tumor tissue biopsy. PIK3CA gene actually has two subunits, either catalytic and regulatory subunits, and PI3K isoform has 4 isoforms. Alpelisib is targeting the alpha isoform, which is 50 potent than the other isoform. So the trial that studied the efficacy of alpelisib in hormonal positive, HER2 negative advanced breast cancer is SOLAR-1, which is phase 3 randomized control trial that includes men or post-menopausal women with hormonal positive, HER2 negative advanced breast cancer, recurrence or progress in prior aromatase inhibitor, identified PIK3CA status, and measurable disease, or at least has more than 1 lytic lesion, patient with good performance status. And a number of population about was 570 patients. It consists of 2 cohorts. The cohort one that consists of PIK3 muted cohort, and the other one is wild type PIK3CA, which was randomized to alpelisib 300 milligram OD daily plus fulvestrant 500 mg intramuscular versus hormonal therapy alone, which was fulvestrant. Similar that to PIK3 wild type. The primary endpoint was PFS in PIK3CA muted cohort. Secondary endpoint was include overall survival PFS and overall response rate and safety profile. Baseline characteristic, we see the median age of patients about 60, most of them are Caucasian. Also, lung and liver mets was involved in the trial. And we noticed here that a small percentage of patients was involved that receive a prior CDK4/6 inhibitor, about 6%. As we can see clearly, the curve was separated early. This is BFS curve with hazard ratio 0.65 and median BFS 11 months versus almost double the placebo group with hormonal therapy. Patient with wild type has no efficacy in patient with wild type PIK3CA with hazard ratio 0.85. Offer response rate, all patient has patient with alpelisib plus hormone treatment, 26% offer response rate versus 12.8% in the placebo group. Patient with measurable disease, such as patient with liver and lung mets, has double response rate to the placebo group. This is BFS result by subgroup. At first events that the most three at first events patient develop while they are on alpelisib, hyperglycemia reported 63%, with grade 3 32%. Its mean blood sugar was more than 500 milligram per deciliter. Also, the second most common is diarrhea, which is about 57% of patients, and the rash. Other side effects like diarrhea, nausea, and decreased appetite and vomiting. Only 6.3% of patients discontinue alpelisib due to hyperglycemia, and half of this percentage, which is 3%, discontinue the treatment due to rash. What about the overall survival result from the SOLAR-1? As we see here in the curve, overall survival was increased by 7.9 months, which was numerically increased, but it was statistically not significant with hazard ratio 0.86. If we see that patient with lung and liver mets, that we see the overall survival increase by 14 months. As we see here, median overall survival 37.2 in alpelisib plus fulvestrant versus 22.8 in placebo plus fulvestrant with hazard ratio 0.68. So it seems that patients with measurable disease such as lung and liver mets will benefit from alpelisib. Overall survival with PIK3CA mutation in plasma ctDNA DNA that we see hazard ratio 0.74, median overall survival 34.4 versus 25 in placebo plus fulvestrant group. Also the alpelisib delayed time to first chemotherapy with median delay to the first chemotherapy 23.3 month in alpelisib plus fulvestrant versus 14.8 in placebo plus fulvestrant with hazard ratio 0.72. So in conclusion, 7.9-month numeric increase in median overall survival was observed with alpelisib plus fulvestrant as compared with placebo plus fulvestrant in patients with hormonal positive HER2 negative PIK3CA mutated advanced breast cancer. Subgroup analysis suggests overall survival improvement with addition of alpelisib to fulvestrant in patients with liver and or lung mets and those with mutated PIK3CA and ctDNA. So further adding of alpelisib to fulvestrant delayed time to the first chemotherapy. So statistically significant prolongation of PFS observed in SOLAR-1 is supported by numeric increase in overall survival. Is alpelisib effective after CDK4/6 inhibition in advanced breast cancer? As we know that in the SOLAR-1, a small percentage of patients has received prior CDK4/6 inhibitor. So this was the purpose of BYLieve study result that was done by Hobrogo. So BYLieve study was open label 3 cohort non-comparative trial. The inclusion criteria was men or post-menopausal women with hormonal positive HER2 negative advanced breast cancer with PIK3CA mutation. Last one of prior therapy, CDK4/6 plus hormonal therapy, systemic therapy, or hormonal therapy. Patient with good performance status. Measurable disease was included in the study, and more than lytic bone lesion. Actually, that consists of patients selected to go for alpelisib plus fulvestrant if they have prior CDK4/6 inhibitor with hormonal therapy, with aromatase inhibitor. Other patients selected to go for alpelisib plus letrozole 2.5 mg if they receive CDK4/6 inhibitor plus fulvestrant. The other group of patients, they are selected to receive alpelisib plus fulvestrant 500 mg if patients who progress on or after aromatase inhibitor and receive chemotherapy or hormonal therapy. So primary endpoint, a proportion of patients alive without disease progression at 6 months, secondary endpoint PFS, BF2, overall response rate, overall survival and safety. Demographic and baseline, we see that median age patient about 58. Most of patients are Caucasian, and 59 of patients has good performance status. And also about 89 of patients has prior medication therapy in metastatic setting. Also 77 of patients has line of prior endocrine therapy in metastatic setting, and 6.3% of patients previous exposure to fulvestrant or chemotherapy as first-line treatment. And about 59% of patients has secondary endocrine resistant as per ESMO guidelines. We see here the primary endpoint for the prior CDK4/6 inhibitor and aromatase inhibitor cohort was met with 50.4% of patients alive without disease progression at 6 months. Secondary endpoint within PFS 7.3. So that by leaflet trial that confirmed what was noted in the SOLAR-1 trial. With if you go to the here overall response rate, it was about 17.4 in all patients with BRCA3 mutation, and almost 21% in patients with measurable disease. Clinical benefit rate, it was all about 45% in all patients with BRCA3 mutation, and 42% in patients with measurable disease. So by leaflet trial just demonstrate clinically meaningful efficacy of alpelisib plus fulvestrant and BRCA3 mutant hormonal positive HER2 negative advanced breast cancer post progression on CDK4/6 plus aromatase inhibitor. Primary endpoint, as we said, it was met. The PFS was 7.3. A small number of patients in SOLAR-1 with a prior CDK4 exposure in alpelisib arm, 44.4 were alive without disease progression at 6 months, and median PFS was 5.5. If we go to the safety profile, we see that side effect related discontinuation were 20% in BYLieve trial, compared with 25% in SOLAR-1 trial. So BYLieve support use of alpelisib plus fulvestrant for hormonal positive HER2 negative advanced breast cancer on both the CDK4/6 inhibitor setting, and confirm, as we said, confirm data from SOLAR-1. Management of side effect with alpelisib, as we said, the common side effect, hyperglycemia, rash, and diarrhea, which is about range from 50 to 30% of population that reported in the study. The rare the side effect pneumonitis and pancreatitis. Hyperglycemia, what the pathogenesis or understanding of the process behind the hyperglycemia and related to alpelisib. If we go to the left side picture, we see when the insulin bind to its receptor, tyrosine kinase receptor, interact with PI3K, that leads to activation of cellular process and stimulate the glucose transporter to move to the cell surface to drive glucose uptake. With that, the glucose in extracellular level will decrease. In contrast with the presence of PI3K inhibition, that glucose transporter stay inside the cell, and the glucose will accumulate in extracellular site. So as we said before, overall that 65 of patient was reported with hyperglycemia, grade 3 to 4 is 37%, and also it's median to time to onset of grade 3 about 15 days from initiation of the treatment. The good news that only 2 cases of ketoacidosis were reported in the trial. In SOLAR-1, the initial protocol was permitted patient with hemoglobin less than 8%. Then they changed or modified the protocol to hemoglobin A1C should be less than 6.4. Patient was characterized at the time of the study entry as normal, pre-diabetic, diabetic, according only to the lab value of fasting blood glucose and hemoglobin A1C. As we see here that about 56 of patients are pre-diabetic, 40 are normal population, only 4% of patients are diabetic that default in the study. What we have to do pre-initiation of alpelisib, we have to test for fasting blood glucose and hemoglobin A1C, optimize the blood glucose before initiation of alpelisib. So patient while in alpelisib, we have to monitor closely blood glucose or fasting blood glucose and hemoglobin A1C. Regarding the blood glucose and fasting blood glucose, we have to do at least once per week in the first 2 weeks, followed by at least every 2 weeks and if clinical indicated. In patients with hyperglycemia, we have to monitor at least twice a week until fasting glucose decreases to the normal level. The treatment with anti-hyperglycemia medication monitoring at least weekly for 8 weeks, then every 2 weeks. Hemoglobin A1C we have to monitoring every 3 months. So I'm monitoring glucose level to enable early detection and early treatment of hyperglycemia. So avoid the complication and discontinuation of treatment. As we mentioned that hyperglycemia or the peak of high blood glucose will be in the first 2 weeks, then decrease toward baseline fasting blood glucose level. So increased fasted blood glucose and hemoglobin A1C were more observed in patients with diabetic or pre-diabetic at baseline per lab value. This is the grade of high blood sugar. So will depend on the grade. Will either continue the treatment, interrupt, or reduce or discontinuation of alpelisib. If you just go, for example, for a grade 1, if patient has blood sugar from 140 to 160, we have to start with oral hypoglycemic agent with cooperation of endocrinologists. So we usually start with insulin. We usually start with oral hypoglycemic agent. Then if you grade 2, we can upgrade the treatment or add another treatment. As I said, it has to be with endocrinologist help. So alpelisib dose modification due to hyperglycemia in SOLAR-1 trial, as we see here, 28.9 of patients has dose reduction due to hyperglycemia. Dose interruptions about 26.8 patients, and discontinuation, as we mentioned before, only in 6.3% of patients. The second most common side effect related to alpelisib is rash. The percentage of rash was reported in about more than 50 of patients in the trial, and about grade 3 to about 20% of patients. And discontinuation because of rash at about 4% of patients. Incident usually start within 13 days of initiation of the treatment. So initiation of antihistamine or starting an antihistamine prior to rash onset may decrease the incidence and severity of rash. So for all of the grade, we have to consult dermatologists. So depending on the grade, we'll interrupt or continue or discontinue the alpelisib. So for skin toxicity, any grade, as we mentioned that we have to consult dermatologists, and the treatment usually with typical steroid. Sometimes we require to use oral antihistamine, depending on the grade or low dose of corticosteroid. Diarrhea, third most common side effect is diarrhea. So diarrhea also it's reported in about more than 50% of patients. The grade 3 it's about 7%, and discontinuation due to diarrhea in about 3% of patients. Minute to onset, it's about 130 days from initiation of the treatment.
Dr. Aisha, you have 1 minute.
This is the grade will be depend on the grade will discontinue or interrupt the medication. We'll go through quickly about the rare side effects such as pneumonitis and pancreatitis. So for any patient has chest symptoms, we have and is on alpelisib, we have to consider pneumonitis as one of our differential diagnosis. So if it's approved or confirmed, we have to discontinue the treatment. This is pancreatitis. Depending on the grade, we'll manage our patient. And this is my conclusion: dual inhibition of hormonal positive and PI3K, by the way, has been proven to be effective in estrogen-resistant hormonal positive HER2 negative. PIK3CA is the most commonly mutated gene in hormone positive, HER2 negative advanced breast cancer. And we have to know it's generally stable mutation. So we can do in the new biopsy or archival specimen, either from the primary or metastatic breast tissue. So as per NCCN guidelines, the PIK3CA mutation has category 1 to be tested in all our patients with stage 4 hormonal positive, HER2 negative. If you go to the NCCN guideline, the latest NCCN guideline 2021, we see big shift in a big change in the treatment protocol. If you go to the first line treatment, we see the aromatase inhibitor plus CDK4/6 inhibitor. If we go to the second line, which has PIK3CA mutation, our first option of treatment is abelacib plus hormonal therapy. With that, I will conclude. Thank you, Doctor.
Thank you, Dr. Aisha. Do you have any question? Okay. Thank you, Dr. Aisha, for the nice presentation, and thank you, Novartis, for supporting this event. Now we move to the final satellite symposium and the breast session, which is for Pfizer, and it's going to be presented by Dr. Majd Al-Jahil about palbociclib combination and advanced metastatic breast cancer real-world data. Dr. Al-Jahil is the director and consultant medical oncologist at the Oncology Center in King Fahd Hospital Specialist Hospital in Medina. And Dr. Majid, the floor is yours, 20 minutes, including the discussion, please.
Thank you, Mr. Chairman, for your nice introduction. And thank you again for your kind invitation and all the organizing committee. And thank you, Pfizer, for inviting me to present this satellite symposium. Today, I'm going to present the data of palbociclib in real-world evidence. So the difference between clinical trials and real-world evidence, randomized clinical trials are the gold standard in evaluating clinical benefit. Real-world data can supplement randomized clinical trial result and add to the body of the evidence in the more heterogeneous population of patients in everyday clinical practice. So what is the major differences? The randomized clinical trial designed to show causality, and patients are randomly assigned to treatment or comparator. There is pre-specified protocol defined for inclusion and exclusion criteria, endpoints with minimal variation in care. The data and the patient are highly monitored and controlled in a controlled environment, while real-world studies can evaluate only association, unable to determine causality. Patients are usually not randomized. The data are observational in routine clinical practice setting, outcomes based on clinical judgment with variability in patient care and adherence, and usually routine clinical practice with broad patient population. And as we know, observational retrospective analyses are not intended to direct comparison with the clinical trials. First study is the real-world evidence for palbociclib in real-world evidence is IRIS. IRIS is IBRANCE real-world insight. It's a retrospective chart review. The objective is to study the demographics, clinical characteristics, treatment pattern, and clinical outcomes for US patients who receive palbociclib in line with the labeled indication in real-world setting. The study design is retrospective medical records review of 652 patients by 65 physicians. The patient population are hormone receptor positive, HER2 negative, metastatic breast cancer treated with palbociclib plus aromatase inhibitor or palbociclib plus fulvestrant. The physician eligibility criteria: oncologist, hematologist, or gynecologist who are treating more than 5 patients with hormone receptor positive, HER2 negative, advanced or metastatic breast cancer patient. The patient eligibility criteria: adult patient confirmed to have hormone receptor positive, HER2 negative, metastatic breast cancer, no prior or current enrollment in an interventional clinical trial for metastatic breast cancer, and received palbociclib combination therapy in advance in accordance with the label indication. Patient must have initiated 6 months or more prior to chart extraction for patient who received palbociclib plus aromatase inhibitor, and 3 months or more for patient who received palbociclib plus fulvestrant. Here we can see the patient characteristics of iris. The median age around 65, and the majority of the patient are white Caucasian, in both for both palbociclib plus aromatase inhibitor and fulvestrant. And we can see that the majority of the patient here who receive aromatase inhibitor, about 65% receive it as for de novo metastatic, while more than 80% of the patient who receive palbociclib plus fulvestrant are recurrent disease, had recurrent disease, and the majority of the patient are performance 0 and 1, about 80% of the patient. And we can see here around 50% of patient in the palbociclib plus aromatase inhibitor have visceral metastasis, and 40% for patients who receive palbociclib and fulvestrant had visceral metastasis. Here we can see the combination partner of aromatase inhibitor with palbociclib. Majority, about 80% of the patients receive letrozole, and 15% of the patients receive anastrozole, and only 5% receive exemestane. Palbociclib, about 80% of the patient receive palbociclib plus aromatase inhibitor as first line, and palbociclib plus fulvestrant, about 57% of the patients receive it as a second line, and 12% of the patients receive it as a third line. Here we can see the palbociclib dosing. The initial dose for both palbociclib plus aromatase inhibitor and fulvestrant, and we can see that about 78% of the patients received the recommended dose in the clinical trial, 125, but there is about 22% of the patients who received started with the lower dose. And again, about 28% of the patients receive lower dose in the fulvestrant patient group. This is actually the starting dose, and we can see the adjustment, the dose adjustment. There is 97 in the palbociclib plus aromatase inhibitor. About 19.7% of patients had dose reduction. More than 98% due to side effect and toxicity, and 14.4% of the patients who received palbociclib and fulvestrant had dose reduction. Again, it's due the majority, more than 95% of the patient, due to side effect and toxicity. The clinical effectiveness for patients who receive palbociclib plus aromatase inhibitor, more than 60% remain progression free at 2 years. We can see here about 65% of the patient at 24 months remained progression free. And for patients who receive palbociclib plus fulvestrant, more than 75% of the patient remained progression free at 1 year. You can see here almost 80% of the patient at 12 months remained progression free. And if we can see here the subgroup analysis for patients who receiving the palbociclib and plus aromatase inhibitor, the subgroup were stratified by age, performance status, and visceral status. As I mentioned, the visceral disease is about 50% among the patient who receive the aromatase inhibitor plus palbociclib, and majority of the patient are ECOG 0, and around 50% of the patient are more than 65 of age. Here we can see the progression-free rate based on the subgroup analysis. And we can find here at 24 months, if we just focus in the 24 months, the patient who are younger than 65 doing less, doing worse than the patient had age of more than 65. The progression-free rate is 69 here compared to 59. And patient who had excellent performance status had excellent progression-free rate in compared to equal group 2 or more. And the patient who had visceral disease had less progression-free rate in compared to patient who had non-visceral metastasis. Regarding the survival, we can see that at 24 months, patients who are younger than 65 had better survival, and patients with excellent performance status had ECOG 0 and 1 had better survival rate in compared to ECOG 2 and more. And patients who are visceral metastases are at 7.2 and compared to non-visceral 90.7, which is a minimal difference between the two groups. If we see the same certification for patients who receive valbociclib and fulvestrant regarding performance status, age, and metastatic site, we can see that the patient who are younger than 65, the progression-free rate is better than patients who are more than 65 at 12 months, and patients who with excellent performance status are doing better than, or the data actually not available for more advanced or poor performance status. And the patient, there is minimal difference between the patient with visceral and non-visceral disease regarding the progression-free rate at 12 months. And regarding the survival, if we can see that at 12 months, the patient younger than 65 had a better survival rate, and patient with the excellent performance status had also showing excellent survival rate, and patient who had non-visceral disease had better survival rate than patient who has visceral disease. What is the study limitation? It did not include control arm. Clinical events could not be educated based on clinical criteria used in randomized control trial. Adverse reaction were not captured in this study, relied on availability of detailed complete patient record, dependent on the correct completion of the case report form. Data were only collected from physicians who were willing to participate, introducing a potential selection bias. Data collection process was not validated. Follow-up period was not uniform or consistent with that of the clinical trials, and follow-up time were different for the patient group receiving valbociclib plus aromatase inhibitor versus patient who are receiving fulvestrant due to difference in the length of the time of these combinations were commercially available. Data are specific to this sample and may not be generalized to the population as whole. Subgroup analyses are exploratory and may not power to detect statistical difference between groups. In summary, for IRIS, physician reported clinical outcome in patients who received valbociclib in combination with aromatase inhibitor or fulvestrant demonstrated landmark progression-free survival consistent with the randomized clinical trial data. Ongoing studies are required to deliver mature clinical outcome data beyond 12 and 24 months in real-world setting. Frequency of valbociclib dosing reduction was lower in both patient group compared to Paloma's trial. This may be due to unobserved bias where the physician selected a specific patient to start on lower dose than the recommended dose in the clinical trial. The other study is the placebo, the valbociclib real-world first-line comparative effectiveness study. They used the Philatron Health Analytic database. The advantage of this database is a large, the size of this database, about 2.4 million active patients at the time of the study. It reflects different experience in more than 280 cancer clinics in the US. and a single common data set with systemic approach to data extraction. And the Flatiron Health Analytic database has been utilized for over 100 peer-reviewed publications to provide insight into real-world clinical practice. The study design the objective of this study is to determine the real-world effectiveness of first-line use of Ibrance plus letrozole versus letrozole alone in cohort of women with hormone receptor positive, HER2 negative metastatic breast cancer treated with in routine clinical practice across the United States. The method of this trial is observational, retrospective, analytic, observational retrospective analysis of electronic healthcare records, conducting using de-identified patient data from Flatiron Health Analytic database. The eligibility criteria: adult women with hormone receptor positive, HER2 negative metastatic breast cancer. The data collection started from February 2015 till February 2019, and there were more than 770 patients randomized to receive randomized. They received also actually palbociclib plus letrozole, while 658 patients receive letrozole alone. The primary endpoint is real-world PFS, secondary endpoint overall survival. They used the stabilized inverse probability treatment weighting was applied to a patient to balance baseline demographic and clinical characteristics between the two cohorts. The stabilized inverse probability of treatment weighting is a statistical approach increasingly used in retrospective trials, where randomization is not possible. Patients are weighted differently in the sample to create two cohorts that have balanced characteristics. So after adjustment with the SIBTW, we can find that the both arms are equally balanced. With as we see here, the median age is about 66 or 67. And we can see also the majority of the patients are white, with 68% of the patient, and majority of the data or the patient are treated in community hospital, about 95% of the patient in both arms, and majority of the patient we can see that are performance ECOG 1 in about 32% in both arms, and we can see about 61% of the patient had visceral disease in both arms, and about 40% of the patient are de novo metastatic, and the number of site of metastasis, 50% in both arms had one site of mets. So the real-world performance, the real-world progression-free survival in patient treated with palbociclib plus letrozole versus letrozole, median follow-up was 24.2 months, and for Ibrance plus letrozole, and 23.3 months for letrozole. And in an observational retrospective first-line comparative effectiveness study in the real world, median PFS was significantly longer among patients who receive Ibrance in combination with letrozole versus letrozole alone, with hazard ratio of 0.58, reducing the risk of disease progression by 42%. You can see here the median progression-free survival in the adjusted analysis, 20 months compared to 11.9 months with hazard ratio of 0.58. And if we can compare it, and here we are not comparing, just to review the data of the Paloma 2, the hazard ratio is 0.56. Of course, we cannot compare the retrospective with the trial with the randomized clinical trial. And if we can see here the subgroup and the benefit of progression-free survival among the different subgroup, a consistent improvement in PFS for patients who receive palbociclib and letrozole versus letrozole alone were observed generally across all study subgroup. And if we see the overall survival data, the median overall survival not reached in the Ibrance arm in compared to 43.1 months in the letrozole arm with hazard ratio of 0.66 and in reducing the risk of death by 34%. And of course, the Paloma 2 survival data is not mature yet. And this consistent overall survival benefit of palbociclib plus letrozole versus letrozole alone was observed generally across all study subgroup except the race. So what is the study limitation? It's observational retrospective database analysis. Cannot conclude causality, are not intended to direct comparison with randomized controlled trial or other real world study, may have missing data or errors in data entry and incomplete capture of comorbid condition and performance status, bias related to treatment selection, and disease progression was based on individual treating physician clinical assessment or interpretation of radiographic or pathological result, not using standardized criteria such as RECIST criteria. Significant censoring in the overall survival analysis highlight the need of subsequent evaluation with longer follow-up. Subsequent treatment may have impacted the overall survival outcome. Subgroup analyses are exploratory and not sufficiently powered to detect significant difference. Finding from the Philatron Health Analytic Database should not be generalized to other population. Safety data not included in this trial. The study strength point is the study sample size, more than 2.4 million actively treated cancer patients. The availability of comparative control arm, the use of statistical techniques such as SIBTWI balance with patient characteristic and hence minimize bias due to lack of randomization. So the summary of the real-world comparative study, in real-world setting, first-line palbociclib plus letrozole more effective than letrozole alone in heterogeneous population and among various patient subgroup with hazard ratio of 0.58 and with significant p-value 0.002. The observed hazard ratio was 0.582, representing 42% reduction of risk of disease progression and death. There is also the hazard ratio for the overall survival was 0.66, representing 34% reduction in risk of the death with patient who receive palbociclib plus letrozole compared to letrozole alone. This data is complement the superior clinical efficacy observed with CDK4/6 inhibitor in combination with an aromatase inhibitor in randomized clinical trial. Thank you.
Thank you, Majid. So if there is no questions, thank you, Majid. Thank you, everybody. I'd like to close the session. We will go for 10 minutes break to pray Maghrib, since the Adhan was 2 minutes back, and we reconvene back here at around 6 o'clock for the next session. Thank you very much, and God bless.
Good evening, everybody. Thank you very much for attending the breast session. And now we'll start the lung session. We have a very interesting talk, and it's my pleasure to join this session with Dr. Mohammed Al-Shaghi. Dr. Mohammed Shaghi is a consultant and the head of the palliative team in Prince Sultan Military Hospital, the military medical city, and will have also chairing with us Dr. Ashraf Farag. Dr. Ashraf Farag is a radiation oncology consultant, and he is working on the lung and the head and neck. This session will be the same as like the breast session. We'll start first with the abstract, and we encourage a speaker to stick to the time, which is 10 minutes. And then we'll go for a discussion by Dr. Christian Groh, and then we'll go for the keynote session lecture. In the meantime, I would like to thank the organizing committee and thank Dr. Morshid and Dr. Abdelaziz Hamad for holding this meeting for the second year. Without further delay, I would like to start the session with our first speaker, Dr. Abdullah Al-Tugri. Dr. Abdullah, he is medical oncology consultant and the head of the medical oncology department in King Fahd Medical City. He is known for everybody. He will give us one of the important abstract, which is a surgical outcome of phase 3 Checkmate 816 trial, nivolumab plus platinum doublet chemotherapy versus chemotherapy alone as a neoadjuvant treatment for patients with resectable non-small cell lung cancer. Dr. Abdullah, the floor is yours. Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Dr. Murfit, for the introduction, and thanks for such opportunity to present this abstract about the surgical result from a Checkmate 816 randomized phase 3 clinical trial comparing neoadjuvant chemotherapy plus nivolumab versus chemotherapy in patients with resectable non-small cell lung cancer. Single-arm phase 2 clinical trial incorporating neoadjuvant checkpoint inhibitor have shown encouraging efficacy outcome in terms of PCR, event-free survival, and overall survival without compromising the feasibility of surgery for patients with resectable non-small cell lung cancer. And this trial previously has been presented earlier with a primary endpoint, which was the PCR. And at that time, it showed a significant improved pathological complete response after neoadjuvant nivolumab plus chemo, where PCR was defined as no viable tumor cell in the primary tumor or dissected lymph node. Indeed, on the intention to treat analysis, including all patients who did not go for resection, 24% of patients treated with nivo plus chemotherapy achieved PCR compared to only 2.2% in the chemotherapy arm. Here in this update, they have presented additional efficacy data segregated by the disease stage, as well as the key surgical outcome from the Keynote 816. Enrolled patients have resectable stage 1B to stage 3A based on the AGCC7 with an ECOG 0 to 1 without known sensitizing EGFR mutations or alteration. Patients were stratified by disease stage, PD-L1 expression, and 6. 358 patients were randomized to 1-to-1 ratio to either nivolumab plus chemotherapy or chemotherapy alone, where 3 cycles of therapy were planned in the neoadjuvant window. Surgery to be performed within a 6 week after the last dose within the adjuvant treatment and within the 2 weeks from restaging performed by the images. Invasive mediastinal staging. Restaging also was performed at the treating team discretion. After the surgery, patient has an option to receive an adjuvant chemotherapy or radiation as per the local standard. No adjuvant immunotherapy were permitted. Primary endpoint was PCR and event-free survival. Secondary endpoint also was including major pathological response and overall survival. There was some exploratory endpoint, including objective response rate, feasibility of surgery, as well as surgery-related adverse event. Baseline characteristics were balanced between the both arms. About 1/3 of patients has an ECOG 1 and half were squamous histology. 2/3 of patients have stage 3 disease, and majority had nodal involvement at the baseline. And nearly half of those patients were enrolled from Asian countries. 98% of patients received neoadjuvant treatment in both arms, with 9% more patients completed the prescribed 3 cycles in the nivo plus chemo, with a total of 94%. Here also 16% of patients had their surgery canceled in the nivo plus chemotherapy arm, while 21% in the chemotherapy arm. The reason for cancellation were including patient declining surgery, unresectable disease, or probably poor lung function. However, the cancellation of surgery due to neoadjuvant therapy toxicity was only 1% incidence in each arm. 83% of patients in the nivo plus chemo arm proceeded to surgery, while median duration of the operation was 180 minutes, whereas 75% went to the surgery in the control arm. The average time was around 217 minutes. Not sure what really mean by the less surgical time. This probably has to do with the surgical complexity in patients who did not receive nivo. So, when analyzed by the baseline staging, there was no clinically significant difference were noted in terms of surgical cancellation or delay on the surgery in the stage 1 or 2. However, in patients with a stage 3 disease, there was additional 8% more surgical cancellation in the chemotherapy arm versus patients who treated with nivo and chemotherapy. With regard to the surgery delay, there were no clinically meaningful difference in the time to the surgery, with median time around 5 weeks in both arms. Procedure was delayed, occurred beyond the 6-week window, with only 21% who had the surgery with nivo chemo, and only 18% in the chemotherapy arm. So only 4% delay due to adverse event, as we can see here in the chemo plus nivo, while only 7% in the chemotherapy arm. The PCR by the stage, here we can see that the neoadjuvant nivo plus chemo showed an improved PCR rate compared to the chemotherapy alone, regardless of the stage. PCR occurred in 40% in patients with the stage 1B, though the sample size here probably is quite small. Similar and impressive magnitude of PCR incidence was also seen in the stage 2 as well as in the stage 3. The depth of pathologic response also was also different in patients with a stage 1B or 2 were treated with nivo and chemo. The median residual tumor was 28% versus 79% in the chemo treated patient, whereas also the median for the stage 3 was only 8% residual fibril tumor in the nivo plus chemo treated cohort, as opposed to 70% in the chemo treated patient. When it comes to thoracotomy, which was most of the frequent surgical approach in both arms, followed by a minimally invasive conversion approach with no dramatic difference according to the baseline staging that I can see. The only difference here probably is more minimally invasive procedures for stage 3A in the chemo immuno versus the chemotherapy alone, with higher rate of conversion in the chemotherapy arm. With regard to the extent of the surgery, lobectomy was the most common type of surgery across the stage subgroup, and was more frequent in the nivo plus chemotherapy arm than the chemotherapy arm, with 77% versus 61% accordingly. Here also we have seen 13% increase in the rate of pneumonectomy in patients treated with chemotherapy alone compared to chemotherapy or chemoimmunotherapy arm. Also here we can see the rate of R0 resection was numerically higher in Nivo and chemotherapy arm as compared to the chemo-treated patient with 83 versus 78%. And the median number of the lymph node dissected were higher in both cohort with no clinically significant in both arm. With regard to the length of the stay in the surgery, here you can see the median time for hospitalized was around 10 days in both arms. When analyzed by the region and length of stay, it's not really different. Probably what we see is the difference in the geographic region rather than it's a true difference between both arms. Finally, the addition of Nivo to chemotherapy did not really increase the surgery-related adverse event in the Checkmate 816. The any grade surgery-related adverse event were 41% in patients treated with Nivo and chemotherapy, while 47% in the chemo-treated arm. Grade 3 and 4 surgery-related adverse event were around 11 and 15%, as you can see here in the table on the right. Most frequent observed complications within 90 days after surgery was anemia, pain, wound complications with a similar rate across both arms. The one exception is—
1 minute, Dr. Abdullah, please.
Yeah, what is the only exception is probably the pain, which is kind of twofold higher in the chemo-treated arm. And that's probably have to do with the kind of surgery that was. I think that's probably the last slide. In the summary, and based on the other of this trial, the primary endpoint of the PCR was met with the new adjuvant Nivo and chemotherapy versus chemotherapy. Patient who had improved PCR rate and great depth of pathological response, and this was seen regardless of this disease stage. The study continued to be mature for other primary endpoint and for the other primary endpoint, which is the event-free survival. Regarding to the surgical outcome, numerically greater percentage of patients treated with new adjuvant Nivo and chemo versus the chemotherapy who had definitive surgery and complete resection, while few patients probably had under pneumonectomy. Majority of patients also in both arms had surgery within the protocol specified window. New adjuvant Nivo and chemo treatment was well tolerated, and with the addition of Nivo to chemo did not really add much to the post-surgical complications. Finally, the safety and the surgical outcome data reported as so far from the Checkmate 816, along with a significant improvement in the pathological complete response, support that the Nivo in combination with chemo might be a kind of attractive new adjuvant options that for the resectable non-small cell lung cancer, but probably longer follow-up we need for this study, for this trial. Thank you so much. This is the acknowledgement, and thank you so much for such opportunity.
Thank you very much, Dr. Abdullah, for the excellent presentation, and we'll keep the questions at the end. We'll go for next.
Hi, good evening. It's my pleasure to be with you tonight. And my pleasure to introduce Dr. Ahmed Al-Wahabi. Dr. Ahmed is a consultant medical oncology from King Faisal Specialist Hospital, Jeddah. And I believe he will speak for about not more than 10 minutes. Please, Dr. Ahmed.
Inshallah. Thank you very much for giving me this opportunity to be part of this amazing event. And I think this is going to be my second year in a row to be part of it. So I'd like to thank the organizing and scientific committee for extending their invitation for me. So I was given the task of talking about the Empower 010, which looked at the primary results of a phase 3 study of atezolizumab versus best supportive care after adjuvant chemotherapy in resected stage 1B through 3A non-small cell lung cancer. So the main idea of the atezolizumab, basically to be given in the adjuvant setting, has been followed by other adjuvant treatment options, such as the anti-EGFR and the ADORA study, and the fact that atezolizumab might play a role in the adjuvant setting after resection of non-small cell lung cancer, accordingly after receiving adjuvant chemotherapy, which we all know that it leads only to 4 or 5% overall survival improvement at 5 years versus observation. So the main study design looked at completely resected stage 1B through 3A non-small cell lung cancer based on the AJCC edition 7, not 8, and they stratified them according to stages 1B with tumors more than or equal 4 centimeters, as we all know, ECOG 0 to 1, and patients either had lobectomy or pneumonectomy, and they looked at tumor stages based on PD-L1 analyses. And they stratified them either to TC2 or 3, and accordingly to TC0 or TC0 to 1, and etc. And those equates to PD-L1 more than or equal 50%, or 1 to 49%, or less than 1%. And the primary endpoints looked at investigator-assessed disease-free survival, hierarchically based, and we're going to go over the statistical analysis because it's going to be very important. And they looked at all randomized stages 2 to 3A population, and accordingly from 1B to 3A. We have to talk about how they randomized these patients. Is that once the resection took place, chemotherapy was given accordingly to the histology. It was platinum-based, either pemetrexed or gemcitabine or docetaxel or vinorelbine for 1 to 4 cycles, and they randomized them 1-to-1 either to atezolizumab 1200 milligrams Q21 days for 16 cycles or best supportive care, and they followed them accordingly from there on. So the statistical analysis, it's very important to understand that in this trial, is that they looked at disease-free survival and PD-L1 TC more than or equal 1% from stages 2 to 3A population. So keep in mind, these patients had the PD-L1 positive, and then if they were positive, then they will move to the overall population for stages 2 to 3A population without looking at PD-L1. And if it was positive, then we'll move to the intention to treat analysis, and those included the stage 1B to 3A. And if they were positive, then they will move to a whole population of intention to treat population accordingly. So the baseline characteristics were well balanced between all arms of the study. I have to mention that they enrolled the EGFR and ALKs, although that they had very small, minute numbers, but the EGFR population were enrolled prior to the initiation of the ADAURA study. So the main results were when it looked at the disease-free survival and PD-L1 TC more than or equal 1%, meaning PD-L1 positive for stage 2 to 3A population, the primary endpoint was reached. The median disease-free survival was not estimable for the atezolizumab study arm, versus 35.3 months for the best supportive care, significant p-value, as you can see there. So when they look at the first plot, all population that were studied gained significant benefit, and it seemed that the higher the stage, meaning stage 2B and 3A, the higher the benefit, with hazard ratios of 0.77 to 0.62 respectively, and the same thing is true for diseases. So moving on, for the all population from stage 2 to 3A, regardless of the PD-L1, whether being positive or negative, again, that was positive with a median disease-free survival of 42.3 months versus 35.3 months, significant p-value, although the hazard ratio is 0.79. And as you can see there, it seemed that all populations had received significant benefit, although that the PD-L1 negatives might not have had a similar benefit as to the patients who had the PD-L1 positive for the study. So keeping that in mind, we had followed up the statistical analysis as it has been predetermined before the initiation of the trial. And now we're going to look at the intention to treat population, meaning that all PD-L1 positive or negative for stages 1B to 3A. And unfortunately, at this point in time, the disease-free survival and intention to treat population from stage 1B to 3A did not cross the significance boundary at this interim, and they will still follow up with these population accordingly. So when you look at the subgroup analysis that we have spoken about, on the far left-hand side, the PD-L1 tumor cell more than or equal 1%, meaning positive PD-L1, gained significant benefit for stages 2 to 3A with a 0.77 hazard ratio. And when you look at all PD-L1s, whether it's being positive or negative, the hazard ratio is 0.99 for stages 2 to 3A, and the overall intention to treat population was 1.07. Keeping in mind the study is not mature yet to come up with the overall analysis and the understanding of conclusion of the study. So the overall safety summary, as you can expect, patients who had undergone atezolizumab had more adverse events as opposed to the patients who only had best supportive care. Nothing that is more than the ordinary when you give immunotherapy for this population, as you can see there. So main conclusions is that Adjuvant atezolizumab following complete resection and adjuvant chemotherapy showed statistically significant disease-free survival benefit and PD-L1 positive more than equal 1% for stages 2 to 3A with a hazard ratio of 0.66. Over randomized stage 2 to 3A hazard ratio of 0.79 population had been not detrimental, but it showed some benefit with the caveats of stage 1B and the negativity of PD-L1. So the main conclusion they had when the abstract was first presented is that atezolizumab should be considered as a practice-changing adjuvant treatment for patients with PD-L1 positive from stages 2 to 3A non-small cell lung cancer. Some new updates as per the most recent World Cancer Lung Conference is that the intention treat analysis of 1,000 patients or so showed some significant benefit when atezolizumab was given. However, subgroup analysis based on disease stage, lymph node status, type of surgery, and chemotherapy regimen, there was a trend for present for all these groups to be positive when atezolizumab was given, except for patients who had stage 1B disease, undergone bilobectomy, or had a cisplatin gemcitabine chemotherapy accordingly. And they looked at more specifically at the 476 patients with stage 2 to 3A disease and PD-L1 expression more than equal 1%. And again, the DFS was again improved with the addition of atezolizumab. However, the patient whom had cisplatin and gemcitabine did not gain as much of benefit. And this might reflect on the underlying histology of squam rather than adenocarcinoma. And lastly, as you can see there in the last bullet line, patients who had bilobectomy seems that they didn't have gained a lot of benefit when atezolizumab was given. So with that, I conclude my presentation, and thank you very much for your kind attention.
Thank you, Dr. Ahmed, finishing on the time. And I will move now to my colleague, Dr. Ashraf, to introduce the next speaker.
Thank you, Dr. Shaggy. Assalamu alaikum, everyone, and good evening. My next speaker will be Dr. Shadi Al-Khayyat. Dr. Shadi is a consultant medical oncologist in King Abdulaziz Medical City in Jeddah. Dr. Shadi will speak to us about the role of sotorasib as a second-line treatment in pre-treated KRAS mutant lung cancer patients. His data from phase 2 called Break 100 trial. Dr. Shadi, the floor is yours.
طيب بسم الله الرحمن الرحيم الحمد لله رب العالمين والصلاة والسلام على أشرف الأنبياء سيدنا محمد وصحبه أجمعين. First of all, thank you, Dr. Ashraf, for this nice introduction. I'd like to thank the organizing committee for inviting me to the second year for this event, and really I'd like to thank the colleague in Prince Sultan Medical City for arranging this important update. Special thanks to Dr. Assam Merchant, Dr. Al-Hamid, and also to our dear colleague, Dr. Mirfat, for her activity in arranging this educational activity every year. So I was asked to, just let me put a full slide. So I asked over the next 10 minutes to present about this important topics in patients who's having metastatic lung cancer. As we know, it's one of the difficult disease. So this presentation has been presented by Dr. Frandilis Skoulides from Brazil about the overall survival, as well as subgroup analysis from phase 2 Code Break 100 trial following the sotorasib in non-small cell lung cancer. Okay, so this has been presented, as all of us we know, in the ASCO meeting that was held virtually in 2021. The reason behind this presentation or this topics, because we know that now non-small cell lung cancer has become an oncogenic driver cancer where we find mutation. The KRAS G12C is one of the oncogenic driver that I defined in 13%. So almost like, 1 in each 9 or 8 patients would have that mutation. And we know that there's no treatment has been approved in mutant KRAS patients for this population. The novel therapies that has been done for these to improve the outcome in mutated lung cancer, in mutated non-small cell lung cancer KRAS type, These have been after progression of first line checkpoint inhibitor, and this is very important. So still this studies will not interfere with the standard of care as first line. In this phase 2 trial, the Stressor was first in the class. It's irreversible selective KRAS inhibitor has clinical benefit in this population. So it's a kind of a treatment specific for patients who would harbor this specific mutation. And the analysis here, they're presenting the updated data, and the cutoff of the collected data and overall survival here was on March 15 of 2021. And I think more and more subgroup analysis will be presented later on. Okay. So we know that the sotorasib, in this trial, it was a phase 2 trial. It was a single arm trial. So in this population, in patient who was enrolled, patient had a local advanced or metastatic disease. They harbor the mutation of the KRAS G12C, so the 12C mutation, and that has been assessed all in central group to make sure, we have the harmonized group. And they should have been progressed in the prior standard therapy, and we're going to go through that when we talk about patient groups. But they also have I need to have a stable brain metastases were allowed. So this patient population, they were treated with the standard dose of sotorasib of 960 milligram once daily until disease progression. The patient was assessed, with the radiographic scan every 6 weeks for the first 48 weeks. And then after that, they changed, the frequency to be every 12 weeks after that. The primary endpoint was an overall response rate, which is sounds very logic in such trial because they're looking for, it's a single arm. The secondary endpoint was the disease response and the durability of response, the disease control rate, the time to therapy, and progression-free survival, overall survival, and the safety, which I think an important aspect in this population, mainly because it's a new medication that we're trying in this patient population group. So if you see here, the baseline characteristics, so majority of patients was elderly, where the median age was 63, with a reasonable good performance status, either 0 or 1, more than that was not allowed. Majority of them were smokers, and this patient who what treatment they received earlier, so 1, 2, so there's some patients who received 3 lines of therapy before. And here just to go for the focus, where majority of patients, if you see that they had the platinum-based chemotherapy with the PDL, which would be considered to be standard of care in the practice for these patients. So almost 80%, they received the platinum chemotherapy with the immunotherapy. So the population, the study represent the practice that we're doing in the clinical practice. The primary endpoint, the overall response rate, so in a percent was 37%. So that was amazing, as these patients usually they don't respond. If you see here, there's 4 patients has achieved complete response. Where if you take it only 24% of 20% of population they progressed, while the majority, the remaining 80% of population, they had response, so either stable disease, partial response, or a complete response. And again, I remember that this medication is giving, in the best situation, second line or third line. So that would be an amazing for such a medication. The disease control rate was 80%. Durability and response in month, it was 11 months. So that's a significant number in patients having a second line treatment or beyond for lung cancer. And then the time to response, the median months was 1.3. So the response rate of 30% has been reflected to give progression or time to response by 1.3 months. So here, when you see the progression-free survival curve, because it's a single arm, but we see clearly the number came to be 6.8 months, and that's quite harmonized group. So we see the curve is expected because it's a single arm study. So to see the curve, and again here the shocking or the promising result of having a median overall survival for 12.5 months. So it's a secondary endpoint, but it was quite impressive. And we see the population, we start to lose patient earlier as the first and second month, but then majority of patients, they start the curve will start to improve. We're going to see flattening of the curve after that. This is, I guess, the more updated data is going to show later on. but the rate of failure after the 12th month has been significantly decreased, supporting that patient who responded early will have a good response. When you talk about the data, because like, we know this population is very fragile population. So like, you see here treatment-related adverse event. So yes, there's a significant number of patients who develop that, with the most significant side effects would be in the diarrhea and nausea. And also we see elevated liver enzymes, kind of a significant component. And when we go like, to how many patients, only like, 1 in each 5 patients needed to have a dose modification, and 7% of patients, they need to have a discontinuation of the treatment. And when we see that, the majority of the reasons were related to the liver problems. So like, drug-induced liver injury, elevated liver enzymes, specifically ALT or AST. So that's what been the major number of cases has needed to stop. Other causes also is there, but mainly like, it looks that liver toxicity is a major issue with this medication. But then the adverse event was mostly grade 1 and 2. So majority of these cases, like, was able to be managed, except in patients who needed to stop the treatment, which is by default considered to be like, 7%, which is not a big number in this population. So when they go to subgroup analysis, and I believe that this is the updated part of this ASCO, like, you see, like, they put the patient by the groups, but the most important, like, things when it comes to treatments, that like, patients who had the anti-PD-L1, so treated like, with immunotherapy, but no cisplatin, they have like, the response of longer duration of survival of 17.7. So whether this is like, related because they didn't receive the chemo early, we cannot like, have a justification on that. And I believe more theory is going to come during the discussion of this abstract about like, why this population, they have a better response. But if you see here that almost all subgroups, they have a good response to the sotorasib treatment. It's when they see the presence of the frequency of the mutation. So we know that this study has like, the study has like, the assessment of the mutation done centrally, where we have better control on that. But then when we see here the overall response by the tumor mutation burden, because like, we see a clear correlation between the immunotherapy and the sotorasib. So like, both patients who had like, high TMB or like, low TMB, they responded well. And then the overall response rate, like, has been checked, like, for the mutation, the STK1 and the KEAP1 here. So we note that the mutations of the STK11 and the KEAP1 has kind of like, different aspect, because patients who had the KEAP1, they have usually a poor response or like, worse outcome. So it's seen like, they have a suboptimal outcome standard of care, such these mutations. So this is like, quite interesting when they did the assessment. So if you see here, the overall response, like, when they talk, so this kind of like, is an assessment, but then in the duration time, you see like, the response here, the progression-free survival in patient who had a mutation of the KEAP1, they have like, a worse outcome, like, survival. But again, like, this population, they benefited when they received the treatment. So the treatment was like, irrespective of the status of this mutation, they would benefit. But again, keep in mind that the size of this population here would allow, this is maybe as a, like, whether this is a conclusive, effect, or this is just like, a theory generation. This need to be kept in mind, because the number of population was not that enough to draw this as a conclusive evidence. So in conclusion, the sotorasib was continued to provide durable clinical benefit in these specific population where they have the KRAS G12C mutation. The median follow-up of 15.3, the median overall survival was 12.5, and that was in second line, was quite impressive. And the median progression-free survival was 6.8 months. The response rate was 37% with the some responders, complete responders. The efficacy was observed across the patient subgroup, and this is an important, so all patients, they should benefit from this treatment. The efficacy was observed, in the all analyses, including the STK1 mutated that exhibit inferior outcomes in majority of patients. The confirmatory phase 3, I think this is what we need to say whether this is like, going to be evidence practice changes. But I guess because this population right now, we don't have anything specific and they have a worse outcome, whether it works to start treatment or that, I think we're going to come to that during the abstract discussion. So this data was published in the same time New England Journal with the presentation. Then I just denoting how much of an important of data that they come in this population. And again, there was acknowledgement by speaker for the all patient who was involved in this trial. By this, I'm gonna conclude my presentation and the mic to you in the German part. Thank you.
Thank you, Dr. Hayat, for this elegant and timely presentation. Now we'll move to the next speaker.
It's my pleasure to introduce our next speaker, Dr. Nafisa Abdelhafiz. Dr. Nafisa, she is known to everybody. She is medical oncology consultant in National Guard Riyadh. She is interested in lung and GI. She will give us a talk about the abstract 5-year survival outcome with durvalumab, the Pacific and update in Pacific study. Dr. Nafisa.
Assalamu alaikum. Good afternoon, everyone. Thank you, Dr. Milfat, for the kind introduction and invitation. I would like also to thank Dr. Al-Hamad and Dr. Asam Murshid for their invitation, and I would like to thank the organizing committee. I had been asked to present the follow-up or the latest update from the Pacific trial. So we know that Pacific trial started 7 years back. It is like a new standard of care. It studied durvalumab in stage 3 non-small cell lung cancer and resectable after concurrent definite chemoradiation. So as I said, trial started 7 years back. It gave very excellent BFS. Hazard ratio was high. It was like 0.7. And this was for the overall survival. And lately we discovered that there was overall for PFS, and then we discovered that it has overall survival. So the durvalumab was found to be tolerable, and the side effects were not that severe. There is no new safety signals, and all the side effects were manageable. So it changed the landscape of the treatment of patients on that setting. So just quick look at the rationale behind the Pacific trial. We know that durvalumab is monoclonal antibody, and it blocks PD-1, and then so it activates the immune system. So by that, we can get suppression of the we can reverse the suppression that happened from overexpression of PD-L1. So it will enhance the T cell activity and killing of the cells. So what about concurrent chemoradiation? We know concurrent chemorad can cause immunogenic cell death. So release of antigens, so that will affect the immunity and enhance the immune system. Then the presence of PD-L1 will lead to evasion of the cell or escape of the immune cells. Then what does durvalumab do? It blocks the PD-1, so it reverses that effect. So what about chemoradiation with what the effect of radiation on PD-L1? So they found a murine model that radiation can increase expression of PD-L1, and then they found that there is synergism between radiation and response to radiation and PD-L1. So this is a schema of Pacific trial. It was phase 3 randomized trial. They randomized around more than 700 patients. Randomization was 2-to-1. The first arm received durvalumab after concurrent chemoradiation. They start giving the medications like 6 weeks from after completion, not maximum, not more than 6 weeks after completion of concurrent chemoradiation. Durvalumab was given at a dose of 10 milligrams per kg for a total of 1 year, and the other arm, 1/3 of the patient received placebo. So they enrolled patients who are 18 years old and above, proven histology of non-small cell lung cancer, having excellent performance status 0 to 1, and life expectancy more than 3 months. Also, they at least patients should get 2 cycles of chemotherapy concurrent with chemoradiation. PD-L1 positivity or presence of PD-L1 result was not part of inclusion criteria or being enrolled in this trial. So looking at the characteristic feature of the patient 2 group, it was well balanced. They look at the patient by age, disease status, presence or absence of PD-L1, but this was not necessary. As I mentioned, only 63% of the patients were having PD-L1 result at the time of enrollment. They look also at EGFR mutation, and they look at the stage of the disease, as I mentioned, and they look at the performance. So looking at the curve of overall survival analysis, we can see very clear that the early separation that we saw earlier on, it maintained, so the separation continued. We had very good, excellent overall survival. We never saw this in patients who are having stage 3 non-small cell lung cancer after completion of concurrent chemotherapy. So the hazard ratio for this was 0.72. So there was like 28% reduction in the rate of death. 43% of the patients were alive at 5 years, while this happened only in 33% of the patients who are in placebo arm. So what about BFS? Again, 33% of the patients were alive and no evidence of disease progression at 5 years. So 33% of the patients had BFS at 5 years, while this happened in 19% in the placebo arm. So looking at the subgroup analysis, irrespective of the disease status, type of chemo, amount of total dose of radiation, they classified a patient by the total dose of radiation. So presence of absence of EGFR, irrespective of all these, patients had good overall survival benefit from the medication and had overall survival benefit. What about BFS? The same, all subgroup, all patients had improvement in BFS. What about PD-L1? As I mentioned, it was not one of the requirements for enrollment, but they classified patients to have it into 2, having percentage of PD-L1 more than 25 and less than 25. Irrespective of that, all patients had improved overall survival and PFS. The only patient who did not benefit like the rest of the patient, those patients who are having PD-L1 less than 1%. So what about secondary endpoint? Looking at the complication, side effect, and adverse event. As I mentioned, there was no new toxicity signals, respiratory symptoms, GI symptoms, and headache and mild fatigue. Most of the side effects were grade 1 and grade 2, manageable. Grade 3 and 4 was very minimal. And definitely patients who received durvalumab had a higher toxicity than the placebo arm. Even the immunotherapy-induced toxicity, like if we're talking about pneumonitis and dermatitis, still the patient get only grade 1 and grade 2 toxicity. The number of grade 3 and grade 4 were minimal toxicity. So, in conclusion, durvalumab became the standard of care. It changed the landscape of stage 4 non-small cell lung cancer after completion of concurrent chemoradiation. Now we have new kind of treatment, new benchmark for clinical treatment and assessment. We found that BFS improved significantly, overall survival excellently improved. We have almost 43% patients are alive after 5 years. 1/3 of the patients were alive and has no evidence of disease progression at 5 years, manageable side effect and toxicity. So all the patients did benefit from the addition of the medication, irrespective of the PD-L1 level, irrespective of the kind of chemotherapy had been used, irrespective of the total dose of chemoradiation. So I think this is like a new era in the treatment of stage 3 non-small cell lung cancer. And we try to adopt this as much as we can, because really it improved both overall survival and BFS. Thank you.
Thank you very much, Dr. Nafis. Excellent presentation.
Okay, now we will move to the next speaker, Dr. Walid Al-Gharib. Dr. Walid is a medical oncology consultant and comprehensive cancer center from King Fahd Medical City in Riyadh. He will speak about first-line Nivo plus EP plus 2 cycle of chemotherapy versus chemo alone in patients with advanced non-small cell lung cancer. Please, Dr. Walid.
Assalamu alaikum. Thank you for the kind introduction, and thank you for the scientific committee and the organizing committee for inviting me to participate in such an event. I will be talking to you about the 2-year update for the Checkmate 9LA. This trial has been published earlier, which including comparing the efficacy of nivolumab, ipilimumab, plus 2 cycles of chemotherapy versus standard of care, 4 cycles of chemotherapy in the management of non-small cell lung cancer as a first-line treatment. And here we have 2 years update. So the combination of nivolumab, ipilimumab has been efficacious, and it has distinct complementary mechanism of action, and we have seen it in different disease sites in non-small cell lung cancer, and melanoma, and renal cell cancer, and mesothelioma. And in this randomized 3 trial, the 9LA trial, the combination of nivolumab, ipilimumab plus chemotherapy has improved overall survival, progression-free survival, and overall response rate compared to the standard of care chemotherapy treatment. The regimen is approved in US and Europe as a new first-line management for management of non-small cell lung cancer in the absence of targetable mutations. And here we'll present the efficacy and over a minimum follow-up of 2 years, and even the post-hoc analysis for patients who discontinue the treatment due to adverse reactions. A total of 719 patients, including this trial, all stage 4, no prior treatment, and no targetable mutations. They included all patients with PD-L1 low and high score. They include patients with CNS metastasis in this trial, and squamous and non-squamous histology. So the trial divided into 2 arms: nivolumab every 3 weeks, plus ipilimumab every 6 weeks, plus 2 cycles of chemotherapy treatment for a total of 2 cycles, versus chemotherapy treatment for 4 cycles, and maintenance Bimetrix if non-squamous histology. Sorry. And the primary endpoint was the overall survival. Secondary endpoint was progression-free survival and response rate, and efficacy of PD-L1 expression. Thank you. And almost 13% of patients completed the maximum 2 years of immunotherapy treatment as a maintenance, and 3% were in the standard group. 3% still receiving the treatment group, which is a maintenance Bimetrix treatment at the end of the data lock. Patients who had disease progression, they were switched to chemotherapy, and in the chemotherapy arm, most of the patients were switched to the immunotherapy treatment. As you can see from the 2 years overall survival in all patients, there is a clear separation of the curve favoring the combination group. And you can see the median overall survival was 15.8 versus 11 months, with a hazard ratio of 0.7 significant. And the overall survival rate at 2 years was 38 versus 26, favoring the combination group. The overall survival and subgroup analysis, it was across all subgroups. Didn't for squamous and non-squamous. Patients with CNS metastasis, they did improve also. They did well with the treatment. And also for those with the low PD-L1 score, they have also improvement of the treatment. The 2 years progression-free survival and disease response rate also showed an improvement with the progression-free survival 6.7 versus 5.3, hazard ratio of 0.67 favoring the combination arm. And the progression-free survival rate at 2 years was 20% versus 8%. And overall response rate was 38 versus 25 favoring the combination arm. At 2 years, the patient with responding disease were 34% versus 12% in the chemotherapy arm only. if we they divided the group also as planned analysis for PD-L1 low. Even the overall survival for those with the PD-L1 less than 1, they did benefit in the overall survival. Overall survival was, median overall survival was 17.7 versus 9.8 with a hazard ratio of 0.6. And the 2 years overall survival rate was 37 versus 22. Same for the progression-free survival and even the duration of response. Response rate was 31 versus 20, favoring the combination arm. And at the patient with the responding disease at 2 years was 45% in the combination arm versus 0% in the chemotherapy only. Further exploratory analysis done also for this patient for those with the low PD-L1 comparing the squamous versus non-squamous. Again, it's favoring the combination arms. For the hazard ratio for the non-squamous was 0.7 with the rate of 38 versus 26. And for the squamous was 0.48 only hazard ratio. 33 versus 11%. For a patient with PD-L1 more than 1%, the efficacy also favoring the combination arm with the median overall survival 15 versus 10.9 with hazard ratio of 0.7. Response rate was 42 versus 27, favoring the combination arm. Again, subgroup analysis was done for the squamous and non-squamous, still hazard ratio of 0.7 for both squamous and non-squamous, favoring the combination arm. For patient with PD-L1 more than 50%, the median overall survival was 18.9 versus 12.9, and with hazard ratio of 0.67, favoring the combination arm. Progression-free survival was also positive with hazard ratio of 0.59. And the response rate was 50% versus 31%, favoring the combination arm. The adverse treatment-related adverse reaction were more with the combination group compared to the chemotherapy only alone. The grade 3-4 was 48% versus 38%, almost 10% increase. However, treatment-related adverse events leading to discontinue one of the treatment medication was 18 versus 5%, and discontinuing the whole regimen was 14 versus 3%. Median duration of therapy was 6 months with the nivolumab, ipilimumab chemotherapy, and 2.5 months with the chemotherapy alone. Majority of these side effects were in the initial cycles of the treatment, majority in the cycle 1 and 2. When you go to cycle 3 and 4, you can see there is a drop in the reporting of advanced treatment-related adverse reaction. Go beyond cycle 4, it's dropping even further. So the first 2 cycles were the major thing to decide the treatment side effects. Post hoc analysis was done for those patients who required discontinuing the treatment of nivolumab, ipilimumab plus chemotherapy due to transfer treatment-related adverse reaction to compare their efficacy. What's their overall survival? What's their response rate? As you can see from the dashed line, this is represent those patients who discontinued the treatment due to treatment-related adverse reaction. And the continued line is the patient all patient. You can see the median overall survival was 27%, and the 2-year overall survival rate was 54%, and the response rate was 31%. And the ongoing response for after 1 year of discontinuing the treatment was 56% in those groups. So even those patients who discontinue the treatment, they still having some response over time. So in summary, at 2 years follow-up, overall survival with the nivolumab, ipilimumab plus 2 cycle of chemo was durable, and it showed 38% versus 26%. And progression-free survival and duration of response was also maintained with longer follow-up. Benefit of first-line nivolumab, ipilimumab plus chemo the benefit was observed across all groups, including the PD-L1 expression, the histology, and presence of CNS metastasis. No new safety signals were observed with the longer-term follow-up. The onset of this grade 3-4 treatment-related adverse effects were in the initial 2 cycles. In the post-hoc analysis, discontinued the treatment, leading to patient maintained their response rate, which was almost 56% of the patient. So at the end, they concluded from this trial that the addition of nivolumab, ipilimumab plus 2 cycle of chemotherapy, limited chemotherapy, it's an efficacious first line in the treatment for the non-small cell lung cancer. It added, we have so many lines of first line treatment, and this is one of them, inshallah. Okay, thank you.
Thank you, Dr. Walid, for your excellent presentation. I believe before closing the session, if there is any question or comment, my colleague Dr. Ashraf will.
We'll go for our next speaker, Dr. Christian Groh. Dr. Ashraf, please.
Hello to everybody.
It's my pleasure to present Dr. Christian Groh, which is the head of Department of Pulmonology and Medical Director of MC Clinic, Warren der Morts in Germany. Dr. Groh is have many publications in the field of lung cancer. He will give us two presentations. First presentation will be for abstract discussion, and the second presentation will be a keynote lecture about the adjuvant therapy in resectable non-small cell lung cancer. Dr. Groh, the floor is yours.
So what we can do next is, would you just like present the original talks first, or should we start with the lecture?
Hi, Chris. I think you will go first for the abstract discussion regarding what was presented, and then you will go for the keynote lecture. So please start first with the abstract discussion. Did you hear me?
I can hear you.
Okay.
Maybe you can start with this. Can you see my presentation?
Yes, we can.
Okay. So just to be exactly what you are up to, because I have a lot of slides, but it would be helpful to understand, would you, because this is the timing now, are you still presenting these talks and I discuss that, or do question and answers, or how we can proceed?
You can just only take three or four abstracts and discuss them like in plenary session, Christian.
Okay, so then what I do, I will show you the lecture and discuss exactly what you want to see, okay?
Yeah, just like a summary and your point as an input.
Okay.
Agreed.
Okay.
Thank you.
See if that works. So, because you have just discussed the abstract of the Empower 101 study, I would like to start with that. Unfortunately, this is not very well established, that slide, but I will start with that information for you. So recently, we have seen a change of paradigm, how to cure patients at early stage cancer. It used to be the case that the patient was presented to the thoracic surgeon, and then there was a decision to be made if this patient is resectable. Now we have a lot of new data, in particular in immuno-oncology drugs, which helps us to understand that this is a multimodality treatment option, which is central to have a multidisciplinary board before any decision has to be made. So in this case, I would like to understand how we can treat these patients, in particular in patients who have the situation in both adjuvant and neoadjuvant. So we would start with the ongoing data from the Empower 010 trial, which is an adjuvant trial. This was initially presented at the last ESCO meeting by Heather Wakerly. And this is a clinical study which tries to understand how a maintenance therapy with an immuno-oncology drug, atezolizumab, will help to improve the overall survival of these patients. This is the natural endpoint in any adjuvant study. We have seen so far only data from earlier studies which show us data from disease-free survival on overall survival in these contexts. But up to now, we have to understand that obviously that immuno-oncology drugs haven't been tested in that context. So this is the first study to look for classical adjuvant platinum-based chemo, and then in addition, maintenance therapy. Earlier last year, we have seen that in driver-mutated adjuvant therapy, osimertinib will lead ultimately to an improvement of the DFS. So IMpower now looked for that in the understanding that we have a situation that this is an all-comer population, and the all-comer population was tested for PD-L1 expression and then given, and this is one of the central critical points of that study, different kind of combinations of cisplatin plus a combination partner, pemetrexed, gemcitabine, docetaxel, vinorelbine. So up to now, we all know that only cisplatin works in patients in an adjuvant setting. And given this scenario in your country or worldwide, we do know that our patients become older and older, and not all patients will qualify for a cisplatin-based chemo. The excuse to use in these patients carboplatin never led to an improvement of overall survival. And in particular, we do believe that the addition of cisplatin is not pemetrexed or gemcitabine. It should be a taxane or a vinca alkylate. So this was the initial idea, but then we get mixed results. And then we had 1 to 4 cycles, and then we had atezolizumab. Overall, if you talk to our patients in medical oncology and thoracic oncology, we try to convince these patients to get any kind of adjuvant therapy, especially in earlier stage, for instance, in large 1B or 2A, and to convince patients to have a medication for up to 1 year is really a challenge. So this is something we have to learn. So this was overall a large clinical study. They just encompassed at that time in the old classification, stage 1B tumors larger than 4 centimeters. Normally, we would classify that now as 2A. And then they looked for lobectomy, pneumonectomy. I come to that point later on. Overall, this has the classical primary endpoints DFS, which is an intermediate endpoint. We always look as a key endpoint for overall survival in the ITT population. So the real problem here, and please look at the little arrows I tried to incorporate in that presentation. We started with 1,200 patients. Now we are down after screening to 1,000 patients. And then we had to realize that obviously in some of these patients, the data quality is very variable. First of all, we do know that only in a minority of these patients were tested for the EGFR mutation status or ALK, the most common drivers at that moment. And if we do not know that, we do realize by now that obviously we do know from stage 3 patient from the Pacific protocol that these patients behave differently. This is not the intention to treat population anymore. And we should ask for screening at all stages to exclude driver mutations for this kind of protocols. So this is the first problem. Then the second problem was that obviously while recruiting, they had to change the immunohistochemistry, and the SB263 markers was exchanged to different other markers. So the immunohistology is variable too. Overall, if you look at the 3 different stages, then you see a proportion of patients which have above 1%, and only a minor proportion of these patients has below 50%, above 50%. So again, what we have learned by now is that these patients, obviously, at the time of recruitment, had variable patterns of driver mutations. They had variable patterns of immunohistochemistry. And finally, and this is what I would like to discuss in the whole field, this is the most important issue, how to treat these patients in terms of quality of thoracic surgical approaches. So we have seen now that was on Tuesday, or on Monday night, the recent update of the IMPAWER 101. And I think this is very important because it's a change of paradigm coming up, but we have to understand what's going on. So earlier on, we had learned that the data from the IMPAWER 101 study, the DFS in all patients with TC greater 1%, was positive in terms of the DFS had a significant p-value and was therefore valuable. What we didn't know, and if you look at the overall treatment proportion, we initially started in a population with 1,200 patients, and now finally we are down to about 460 patients in that population 2 to 3A. So obviously this is only a proportion, a significant, but a major proportion of all patients under evaluation. If you look at the results in the proportion of the patient which had a PD-L1 expression greater 1%, you see a couple of classical clusters of the readout. We do see that it's good for both male and female patients, white or Asian patients. It's good for all performance status, current smokers, as we do know, sometimes do not behave as properly as other ones. And squamous and non-squamous obviously do have different kind of response patterns. They tested some of these patients for EGFR mutations. And if you see if the patient had certain kind of mutation like EGFR or ALK, the results were variable. In this update, if you look at that, we had data up to 24 months. And we had data showing obviously that the median DFS was 42 months compared to 35 months in a risk population, which had a higher PD-L1 expression in the primary endpoint. This is all randomized patients. So as we have learned from the IMPAWER results in earlier studies, we had to break down these results in the different kind of cohorts we try to consider to be important these days. This is the PD-L1 expressor population below 1%, 1 to 50, and above 50. And this was asked for, and I think this is very important. And now we have new data basically based on the presentation of Heather Wakely, which at that time showed that obviously the runner is again the above 50% population, and the low expression level obviously doesn't do any major benefit to the whole population. So at the ESMO meeting, now we had a randomized stage 2 to 3A population with and without EGFR ALK disease. And again, now this is the antibody tested in, has been retested in this population. So as you see, if you look now, you have evaluable patients, 882. As I have mentioned before, we have different kind of cohorts tested, obviously, compared the patients which the subgroup excluding the tribal mutation, then you're down to 740 of known tribal mutations. And then you realize out of 882 patients, 383 patients had a proportion of TC less than 1%, and they didn't have any benefit, 0.97. On the opposite, the higher expressors had a proportion and a 0.43 hazard ratio, which is significant. So obviously now we have three different kind of groups. Again, from the overall proportion of 882 patients, we have the benefit population, which is the patient of above 50%. So you have here 2 to 9. I think this is important that we have to learn. And this is out of 882, obviously only a fourth of the population. If you exclude the EGFR ALK tribal mutated patients, as we all know, usually they have a low expression of PD-L1, then you come down to the same proportion. About 25% of the whole group probably do have the major benefit. Yeah. So taken together this information, we finally come to the situation that we have to realize that these patients do have a certain kind of pattern of response. This is very important. And this is in particular important as we do have this adjuvant and maintenance therapy in a situation where we do confront ourselves with a certain kind of immune oncology adverse events signals. Are these signals different from the signals we have known before? Overall, atezolizumab as durvalumab as PD-L1 modulators are usually very well tolerated. We do not know what is in the long run, at least 1 year of maintenance therapy, a problem. So what you do see here, overall, the proportion of these patients receiving any immune-mediated adverse events is fairly low. And overall, this is okay tolerated. You see hepatitis and you do see pneumonitis, but overall, these patients have a benefit. What we all learn now in the long-term survivors of IO therapy is that we do have thyroid problems and we have to take care of that. But overall, this is a well-tolerated scheme compared to others. So the incidence of disease relapse is very important in understanding how IO long-term maintenance therapy does work. We do see certain kind of patterns between local regional disease patterns of relapse or distant only. And this is, I think, a very important issue overall in the situation if we develop adjuvant therapy in the near future. Do we see an eradication with the help by means of immuno-oncology treatment of the clonal lung cancer? Or do we see only a suppression of that clonal expansion of the lung cancer? You know, this is an important issue in particular in the prevention of the development of distant metastases, in particular cerebral metastases. And here we see a certain kind of pattern, which I think is very important to understand in the patterns of relapse of these population. Overall, the pattern is pretty similar, independent of the PD-L1 expression levels. But overall, we do see more local regional problems than distant problems. This is, I think, very important to understand. This is the same pattern by means also what we do see with osimertinib in the 3-year follow-up. Mostly patients do have a local regional relapse. And the question is that a second lung cancer, or is that early relapse of a clonal micrometastasis of the original lung cancer? That's what we have to learn in the near future. Again, what we do not know, that's the same after failure of stage 3B or 4 disease lung cancer patients, our new medication after failure are limited. We don't really have good data on that. And the recent ESMO meeting has presented data from different kind of new studies showing after failure of a platinum-based chemo IO combo, what to do next. For instance, there are new data from the Mirati compound, zitrafinib plus nivolumab. There are data from a new drug, like a TEM regulator, a new drug called the Dublin trial, pyroglobin. And we have seen more data from nintedanib plus docetaxel. Here, I think it's very important to understand the same situation as in stage 3 Pacific patients, what to do next. And I think this really calls for registry, national, regional registries to understand what to do with these patients and how are the response rates. This is in combination with the patient cohort that should have now biomarkers. So our call would be at the end of 2021 is to have an additional information for all our patients from the time of diagnosis that they should have biomarkers or a genetic signature which will help us to understand that certain patients should be excluded from an IO treatment or should be included based on the certain protocol, what we do see here. So, for instance, in this cohort of that patient, you see in the patient cohort which has above 1%, we do see a certain kind of pattern, what came next. So most patients received chemo and less patients received targeted therapy. So this is, I think, very important. And you see CIT does mean an additional mono IO therapy. And you see very variable response rates. You see that. So saying that, in summary, this is a positive phase 3 study of adjuvant chemoimmunotherapy after surgical resection. But what to do with that? You know, this is definitely a very, very well-established matrix of what to do with these patients in the near future. But I think it's very important to understand for us that obviously the effect in terms of DFS and maybe that translate into the OS is driven again by the patients who have a high level of PD-L1 expression, well above 50%. And the rest of the population, the hazard ratio, like in the group of 1 to 49%, is not reaching statistical significance. And in the large group of patients who do not express any PD-L1, obviously that's not the central core patient cohort we would try to use maintenance therapy. Saying that, this is a very important issue that we should discuss that in detail, because this is one of the first studies we will be presented in the near future. There is coming up soon the PEARL study. This is a study with pembrolizumab in the same kind of protocol, even without cisplatin-based chemo at the very beginning. And then there's a large canopy study coming up. This is a study combining pembrolizumab in addition to canakinumab as a long-term treatment option. So obviously, the suppression of the clonal expansion after surgical resection is a big topic. And maybe we can stop here at that moment and maybe take questions and try to understand what we're going to do next. Overall, this calls for a very strategical and very well-balanced multidisciplinary board before any kind of conclusion and recommendation is done in any patients by the year of 2021. Thank you very much. Maybe we can discuss that now, and then I continue.
Okay, we'll go first, Christian, to the keynote lecture, and then we'll have voting and the questions at the end.
Again, I do whatever you want. If that's more for me, more you feel more comfortable, then it's fine. Okay? Then I continue?
Yeah, please.
Sure. So next step would be, as I mentioned before, would be what is coming up next. That's the keynote 091. That's the PEARL study. And I try to add that to the adjuvant protocol before I switch to other options, what we're going to see. What is the PEARL study about? The PEARL study is at the moment evaluated. So we do see the first results early next year. And this is, I think, important as this is the next step to understand. And because, as I mentioned early on, we do have a large proportion of patients which have an average age about 70 plus. We do not really know if these patients really qualify for an adjuvant therapy, in particular for cisplatin-based chemo. And if you talk in detail with people who only give cisplatin-based protocols, you have to realize they do split proportions of cisplatin at the very beginning to that these patients tolerate up to 4 cycles. So this is what we have to realize, is that in reality, even at certified lung cancer centers, we only see a proportion of patients having really cisplatin-based chemo up front. Saying that, this is the reality because our patients become older and older on average and have a lot of comorbidities like cardiovascular disease or large-scale emphysema or COPD. So now we asked for a certain kind of a change of paradigm. Is there an option to omit the treatment option platinum-based chemo. So in the adjuvant setting, the PEARL study at that time asked for stage 1B versus 2 versus 3A, the classical protocol, in patients who either received cisplatin-based chemo or a proportion, this was well balanced, in patients only received pembrolizumab as a treatment option 4 to 6 cycles after the initial operation. And then again, you have the three groups. You have below 1%, 1 to 50, and above 50. And then we have the combination of Eastern Europe, Asia, and Central Americas and the other countries. And again, we do see DFS. And the question we do see DFS at the moment is that we do have an intermediate endpoint because usually it takes years before you really have overall survival data for these patients later on, usually 5 to 7 years later on. And this is, I think, important because that has to do with patents and other things. So this is what we're going to see. So again, in this patient cohort, we do have almost 1,200 patients, and then a maintenance therapy is pembrolizumab. If you compare the situation for rest of oncology and in surgery in particular, you look at different kind of clusters. So one cluster definitely is the cluster of understanding other disease entities in solid oncology, for instance, in breast cancer, where we can really learn a lot how to treat patients in a neoadjuvant and adjuvant setting. And the other is the runners-up of stage 3. The stage 3 patients, by now, we have to realize that even in the best of our worlds with radio chemo and the addition of durvalumab for 1 year, we do see patients who develop other cancer entities or a new lung cancer. So the question will be, is pembrolizumab for 1 year in that protocol enough? What we have learned in stage 4, obviously 2 years is better. So this is something arbitrary why 1 year was chosen, and at the ADAWA study, for instance, osimertinib was given for 3 years. So if you want to suppress a clone and eradicate the clone, I think the 12 months period is difficult to be kept as a standard. Yeah. So overall, the next study, what we do have is a combination called Alchemist. It's chemo IO. I think only go that into detail, but you realize obviously we have understood that there are more things coming up, and we hope to see more data soon. So the next study will be PEARLS, and then we have the Canopy trial. So this is the situation, what we have to learn over the years, that IO as a standard of care in stage 3B and 4 is something which is set by now, but in earlier protocols, this is difficult to achieve. And I give you an update of something which is by now almost historical, like the picture of these people here. That's the Ithaca trial. That's a large-scale trial we did start to recruit in 2008. This is a large study, and Silvia Novello and Giorgio Scagliotti at that time tried to internationally tailored chemotherapy adjuvant trial. This is a big study, and that has been presented as a, you see at the World Lung this year in January. This is really the time frame what we have to consider to be the standard of care these days. You start to recruit in 2008, and by 2021 you have the data. So if you have to realize, if you want to change that, then we really have to come up with different kind of intermediate endpoints that would be both valuable, evaluable, and standardized as a thing. And this is something we have to think about. Going back to this historical situation, you see at that time we looked for ERCC1. You remember ERCC1 was meant to be something to say something about cisplatin-based chemo or the response to that. And then we had thermalite scientists and things like that. So obviously, even if you randomize at that time, you see the time frames, what usually that is. And I don't say that to spell the good results of the new data. It just really shows how long it usually takes for adjuvant trial in thoracic surgery to come up with statistically significant endpoints. So this is something what we have to realize and integrate in our new algorithms. I think this is very important. What we realized, the study flowchart, it's a long-way Tipperary, I termed that way. There is a non-statistically significant trend for OS favoring the customized arm. So this was, at that time when we did that, the idea, if we customize, personalize, then we come up with a better endpoint. And the final analysis we had to say was performed, the study was underpowered. We talk about this, that's pretty much the same as the study we have just discussed before, the Empower 010, almost 800 patients under evaluation is still underpowered. So this is a difficult issue. And I think we have to realize, despite the fact that we see new drugs on the block, we have to be very, very sober how to approach the overall situation. And I think for us, it would be very, very important to realize that we have to think about that we have to select for the right patients. And that's something I would like to discuss with you next, is we have good data, early data with immuno-oncology drugs. We have good data from the selection bias we have generated. And the next step would be, what is the right patient? The right patient is a little bit easier because tribal mutations by now is the standard of care that we have to look for tribal mutations. We didn't do so up to now in patients who have early stage lung cancer, but in the recent data generation of especially colleagues in Eastern Asia, we have to realize that obviously there is something to it if you screen for certain kind of mutations. So if you look for the common mutations, then we had data from the Radiant trial. This is a TKI and erlotinib versus placebo. Then you had the adjuvant trial. And then you had the ADORA trial, as I mentioned before, what we have published last year showing if you look for EGFR activating mutations, this obviously drives a certain kind of profile. And this certain kind of profile is something where we have obviously integrated something which helps us to personalize adjuvant therapy. And I give you some more updates on that. The targeted therapy in early stage lung cancer is probably pretty much at the same time when we have learned in 2005 that gefitinib worked and erlotinib worked, that these early stage trials like Radiant and Select were initiated. And the results at the very beginning was very sobering. We didn't see any major differences. And this again is a question of, I think, selecting patients. By now, if we look for instance, the major tribal mutation in exon 19 deletions or L858R in taxon 21, if you just stratify for those, then you come up with a situation where we really can say this is a patient cohort which has a benefit in terms of understanding that we just have something in common with these patients. So in the ADORA trial, we have an outcome measure of having 3 different kind of proportions. We had the chemo patients in 4 cycles, and you had 80 milligram of osimertinib once daily or placebo, or they had the group, and I will give you some more details on that, of the group who had no chemo at all. I apologize that this is, these slides have been deranged a little bit due to, I think, the transmission. What we had realized that in the data set that we had generated, that these patients, this is the blue line, osimertinib patients, obviously have a definitely higher benefit in terms of DFS control in the stage 3A. Why I'm talking about stage 3A? This is, for instance, this stage where we discuss radio chemo, we discuss operation, we discuss adjuvant therapy. So at that stage, we definitely have to realize that today standard of care would be the genetic phenotyping of the patient for all our patients. There is, for instance, I think no indication for radio chemo for these patients. And the recent results from the Pacific protocol in JTO showed clearly that patients who have an EGFR mutation in the Pacific protocol did not benefit from that. So early on, please test, look for the mutation. If the patient has a mutation, the surgical approach definitely is something we would like to look for in these patients. Is that helpful with and without chemo? And this is very interesting. Obviously, that we have learned from stage 4 patients that osimertinib compared to placebo does work even without chemo, adjuvant chemo. You see that on the right side. So obviously, you can probably save your adjuvant chemo options, platinum-based chemo, for instance, with pemetrexed for later on if the patient relapses. So very important is what to offer, what kind of proportion of patient. And I think, first of all, that should be a global study so we can just clearly say this is, for us, an intellectual kind of no-brainer to say this works everywhere worldwide. The next option would be, do we include stage 1B patients with a large primary tumor site, or do we just say, is that the proportion of patients that we discuss later on in terms of they should receive only ritual kind of follow-up controls. In general, you see in the proportion of patients stage 3A, it's 80% in 3A. And what we have to realize, the benefit was as high without chemo. And I think this is very important. Again, here in this study, we do see patients above 70 years of age. I think this is very important for approval worldwide. And I think the overall proportion of patients enrolled worldwide everywhere led to the conclusion that this is a standard protocol. I come back to the idea of local versus or local regional versus distant metastases. And there is a difference between our understanding how TKI work compared to immuno-oncology drugs. We do believe that immuno-oncology drugs should eradicate the clonal expansion of the lung cancer entity. And TKI treatment usually does suppress it. If we have very convincing data up to 36 months by now, showing that osimertinib obviously suppresses the distant metastases in the brain. So this is a drug which obviously works in the brain, and I think this is something we can offer. Again, that doesn't lead ultimately to the idea is that accompanied or associated with a better overall survival, but it definitely helps us to understand what is quality of life for our patients. And the next step would be to help that patient cohort in the context of combining clinical trials with the idea that we should have a sequential control not only by radiology or morphology measures, but by the idea that these patients should be treated or evaluated by a liquid biopsy. So there will be upcoming data from the ADAURA trial showing the liquid biopsy results in these patients who had a relapse compared to no relapse. I think this is something we have to realize that overall, in the near future, we have in a setting in early stage lung cancer that we can test and we can screen for lung cancer in different kind of situation, but we should combine radiomorphology with liquid biopsies, in particular in patients who have a mutated lung cancer. And this group of patients becomes larger. And if you look at the ongoing randomized phase 3 trials of an EGFR TKI as an adjuvant treatment, this seems to be a big ballpark. Yeah, there are larger studies, of course, in China and in Japan, because the overall proportion of patients who do have a tribal mutation of the EGFR subtype is larger. But we have seen new studies now for ALK, we have new studies for RET, and we probably see more studies coming up that we should have tribal mutations excluded early on and have them treated in a different kind of proportion. What are my future considerations for that? What can we do for these patients if we try to bring it back from the tribal mutation back to immuno-oncology? First of all, I think, what is our patient selection? And I think this is coming back to the point where I showed you that slide of the cartoon of where is our multidisciplinary board to be found. That should be early on. And if you look at the development of solid oncology entities next to lung cancer, breast cancer, colorectal cancer, for instance, then we do have learned that we have to decide in the multidisciplinary board to have patients cohorted. So if we start treating patients in an early setting and even consider neoadjuvant setting, and I didn't go into 816 because this is a different kind of issue again, this is something, what is the subset of patients who have a clonal expansion of a tribal mutation? And exclude these patients, they should come into a certain kind of protocols. And as you know, there are protocols running also for TKIs in a neoadjuvant setting, difficult to recruit. And then the next step would be, if we look for patients who have a tribal mutation, then we're going to treat them after the operation in a different kind of pattern than patients who have no tribal mutation. And the next step would be, if patients have an adjuvant situation, then we have to discuss that and we ask for certain kind of options beyond cisplatin-based chemo. In the near future, while waiting for the mature results of ADAURA, of the IMPOR 101 or PEARLS, we have to have the situation that we obviously need new data showing that adjuvant treatment is beneficial, but even without cisplatin-based chemo. So what? We try to treat these patients with a new situation that they are third generation TKIs. We all know there is a fourth generation already. And there is this combination of a fourth generation in combination, for instance, with cytotoxic antibody drug conjugates like avimantanab. So there's more coming up. And how? How would definitely mean tumor evolution will mean that there will be no clonal expansion. If you look back, for instance, at squamous cell carcinoma of the head neck cancer subtype, we all know that about 25% of these patients later on, if they survive the head and neck cancer entity, show up with squamous cell carcinoma of the lung. So obviously we will generate new patients, and that definitely asks for a very solid and straightforward formal data registry in our countries on national and regional levels to understand what is the real world evidence in our situation. And while I'm talking here from Germany to you, and I really feel honored to have the option to give that lecture, we have different kind of approval situation worldwide. So what we do need is that what are our tools in our country and how we can use these tools to do the best to our patients. And I think this is a very dynamic field, and I really feel honored that I had the opportunity to give that lecture, and I'm more than happy to answer any questions and discuss with you things in detail. Thank you very much.
Thank you very much, Professor Christian, for excellent presentation. We'll go for polls first, and then we'll go for the questions. Can I ask our eminent speaker to come to join us, please? So the first question to the audience, and also I'm not sure that the panelists can vote as well. So the first question, did you attend the ASCO, WCGI, or ESMO this year? Can you please vote yes or no? Give 10 seconds. Yes. So 47% yes, and no about 53. Okay. Second question. Okay. What type of attendance you prefer? Do you prefer virtual, physical, no preference? Sorry that the attendees are unable to vote as well. So 65% they are voting for the virtual, which is really not expected, and physical about 25% and 10% no preference relevant. And here we can share the results as well. Third question. Immunotherapy became standard of care in many disease sites because tolerability, convenient, I'm still not using it. Can you please vote? So the answer is tolerable for 32%, convenient for about 45%, and 23% for I'm still not using it. Okay. Last years we had unprecedented data for non-small cell lung management. Do you agree, disagree? You are not sure. So 47% agree about that it was unprecedented and 10% disagree, and about 44%, which is huge, not sure. Do you do PD-L1 test in all non-small cell lung cancer patients? Yes, no, only metastatic patients. Can you please vote? So we have 27% they doing for all the patients and 32% no, and almost 42% only metastatic. This means that for almost half of the physician, they are just only go for PD-L1 test. So Christian, you are doing the PD-L1 test in all your cases, or are you just only metastatic patients?
Well, we started to do that now in all our patients for the reason that I just tried to lay out in, it's difficult. The issue, we talked about that before, reflex testing. It's no good, but we have learned if you have standards, then it's easier because you lose a lot of information if you do it very individualized. So we negotiated with the insurance companies, and they offered us that we have a package and we give them the registry data we have generated. So this was the deal. For that reason, we now do PD-L1 testing in all our patients, because we believe that especially in the patients who have no PD-L1 expressions, we still have a large unmet need.
Yes, I agree. Dr. Shadi, you are doing the PD-L1 test for all patients or just only metastatic patients?
Well, thank you, Dr. Mirfat. I guess at this time we're doing it part of the panel, so we're doing the PDL plus the all the EGFR mutations for adjuvant setting. So yes, at this time we're doing it, but because it's part of the panel, as the data of the adjuvant treatment for immunotherapy in the future will be depending on that. So I think it should be included now in all the members, once the practice guideline change to include immunotherapy in adjuvant setting, because those patients, they need to have at least 1% positive to benefit.
Perfect. And Dr. Nafisa, I know that you are doing in-house, so you are doing for oral patients?
We are doing it for all patients, PDL1 as well as the molecular test, irrespective of the staging.
And you, Dr. Walid, as well?
For metastatic, it's done for all patients. However, adjuvant, we are asking, it's not still reflex testing by our pathologist. We are pushing for to be done for all patients, but still we need to ask sometimes.
Perfect. Thank you very much for your feedback. Going back to the voting, the iEmpower 010 study is a changing practice. Yes, no, I'm not sure. Can you please vote? Dr. Ahmed Al-Lahibi and Christian, it's your response and your impact as well. So we have 60% saying yes, we have 9% saying no, and not sure about 32. I think, Christian, you had an impact on them, and Ahmed, you made a great job for yes. Can I have your comment first, Dr. Al-Lahibi, and then Christian, please?
Well, thank you very much, Dr. Mervet. I think it's just exactly as what Dr. Christian had mentioned in his brilliant presentation. There are a lot of ifs, ands, and buts, but really it's all about choosing the right population for the right treatment at this point in time. We always have to make sure that they are clear of any driver's mutations. They definitely have a positive PDL1 prior to commence them on the 1 year almost of therapy of atezolizumab treatment. So it all boils down to the right patient's population selection.
And you, Christian, what is your comment?
I can only say everything is absolutely right what you said. It's just, it's very important. We still are within a big learning curve. And if you look back, there was no major improvement in the last 15, 20 years in adjuvant therapy. And now all of a sudden we have 12 months where everything is going to be discussed, at least, not changed, but discussed. So I think the Empower study is very important, but we still have to learn a lot how we treat these patients. And, as you have pointed out, it's just like, what is the standard for us? And we have to do that in our situation, in our hospitals, in our countries, and to get a good feeling for that. And I think this is what I really just like, is I'm an advocate for that. We do our stuff at our hospitals for our patients, and we have to feel comfortable with that. And then we do the best thing.
How do you explain that the chemotherapy protocol has an impact on the patient population in Empower? I mean, the GEMSAS patient, they are not responding well, like the other patient. And in the meantime, of course, the patient with stage 1B as well. And this is what in the subgroup analysis, which is published in WCLC.
If you look back at our institution, we try to circumvent cisplatin-based chemo to say maybe we give carboplatin. We didn't change the partner Winker alkylates. But if you look back, obviously the suppression and the toxicity profile of this group is not, in favor for gemcitabine or for pemetrexate. So it's a very important question. The problem is that we are a little bit always lost to follow up. This is the standard group of patients who do not show up again. So we don't really have good follow-up data for that. And then we lose track. And then for that reason, we never really evaluated the quality of our data in adjuvant chemo platinum doublet. So I think that might be a problem. But we had to realize maybe we should stick with the standard taxane or Winker alkylate. And, this is what I would like to know. It's just, in our hands, convincing our patients to have that combination first for 4 cycles with a lot of toxicity in an elderly population, that's not easy. And I would love to have something new showing this is helpful for you. And, the elderly population always now asks for IO anyway.
Perfect. We'll go for the next question, which is Nivolumab in the stage 3 irresectable has benefits in all patients as a standard of care. Agree? Only PD-L1 positive patients, I have concern regarding post-radiation IO. Dr. Nafisa, your response after the voting, please. So we do have agreed about that the standard of care now, Nivolumab, it's about 36%, and only PD-L1 patient positive 19%, and about 19% of the attendees have concern regarding post-radiation IO. So Dr. Nafisa, what is your response, and Chris as well? Okay.
Yes, thank you. I think, yes, it should be the standard of care now. If we go back to the path and think of how patients were, the prognosis and the outcome of patients with stage 3, either A or 3A or 3B, overall survival at 5 years, they can hardly reach 20%, might be less. Even here, if we look at the Pacific trial, the placebo arm, the PFS was 19%, and there was more than 10% difference in overall survival between the experimental arm and the placebo arm. So it should be standard of care. Back to the PD-L1, as I mentioned in the presentation, PD-L1 was not one of the requirements for being enrolled. All patients actually did very well with the addition of durvalumab. And the only patient who did not get the maximum benefit in PFS or OS, those were having PD-L1 less than 1%. So 1% and above, all the patients had good PFS, improved PFS, and improved overall survival. Regarding toxicity, if we look back at the general toxicity or immunotherapy-induced toxicity, specifically, namely pneumonitis, it was mainly grade 1 and grade 2, and patient went back with addition of prednisolone, and grade 3 and 4 was the number was not that high, unfortunately. So it did not affect the quality of life for the patient as well. When they look at the patient-reported outcome, there was no effect on the quality of life.
Thank you. Christian, do you have concern about the patient with PDL negative and Nivolumab as now as considered as treatment standard of care? However, for those patients, they are less benefit comparable with PDL1 positive patients.
Mm-hmm. So first of all, this is an excellent conclusion you have made just before me. But, there are two things are open, within the last 5 to 7 years, we had to learn that we have to become very standardized in the quality, how we treat all the material we have. So obviously the lack of data about PD-L1 expression is a problem. And by now, we do see, if you look for TC and IC both, the majority of our proportion do have an expression level about 80%. If not, obviously, this is a different kind of group, and we should exclude driver mutation in this cohort. And the rest of that is, this is a real problem. What it is that in squamous cell carcinoma or an adenosquamous carcinoma, this is usually the proportion who do not have a high benefit in an early relapse. So this is more a call for us to better understand what to do with these patients. And I think personally, I believe up to now, you can do that, try to treat patients out of this beside that protocol. But in general, this is a patients which should kept under close surveillance because they don't do very good. And again, because this is my mark this today is, I personally believe not all patients will receive any kind of radiochemo protocol in not 100%. It's maybe again 60, 70%, because the rest of these patients do not qualify for that protocol. This is another real world issue we have to discuss.
Yes, agree. Going back to the voting, code break 100 for sotorasib in KRAS G12C mutated non-small cell lung cancer is very promising. Agree, disagree, I'm not sure. Can you please vote? And we need the comment from Dr. Shady, please. And of course, Chris. So 71, you were very convincing, Dr. Shady. Most of the people, they agree about that it's very promising, and disagree about 8%. not sure about 22. What do you think, Dr. Shadi, specifically that this was heavily pretreated population?
So interestingly, that this study does not interfere with the guidelines. So, like, you know, almost majority of patients, they receive platinum and immunotherapy as an upfront. So still, like, you know, it's within our usual algorithm. I think we're talking here about a special population who has a poor outcome because of this KRAS mutation. So in my opinion, I think this is very promising. If we can convince this data, or, like, you know, have it repeated in a phase 3, I think it's going to be a practice changing. And like, you know, 12.5 months in a second line or a previously treated advanced lung cancer, this is for sure, it's like, you know, a big number. And once we have more that confirmed in a phase 3, I think it's going to be a practice changing for the specific population who get this mutation.
But you don't have a concern that most of the patients, they were IO pretreated, there was no platinum based, and we know that this can be a weak point regarding the study of this medication?
No, actually 80% of patients, they have both the IO and the platinum. So that's what the majority of the patients. We have, like, you know, well, we need to accept that IO is going to be like, you know, a big portion of patients, they will not receive platinum as a first line. So if I can go, like, you know, with these patients received only immuno as a first line, and then they get benefit from this in a phase 3 trial, in a case, like, you know, in this specific mutation, I think this will be a good point that I can defer platinum later on. But at this time, I still would imagine that if I give a patient immuno as the first line, and then they didn't receive platinum, I would still use platinum maybe as the second line, then later on go to the third line to be for like, you know, for this specific treatment of the thoracic.
And Christian, do you think that this population, as a KRAS, we know that they are responding to IO therapy? What is the sequence for this treatment for this patient? Chemotherapy, IO plus chemotherapy, then sotorasib, or what do you think?
You know, this is a very good question. You know, I personally believe it's practice changing. You know, it's very important to address that issue, because this is, you know, the poor outcome population very often. So, and giving the code break data, you know, we need more data, as you have pointed out. We need a phase 3. There are more drugs, compounds coming up soon for the same cohort. But I personally believe, you know, we had data from our registry showing that the G12C plus P53 aberration patients have a high benefit from Pembro. So we would like in the higher expressors, so we would definitely look for sequence having triple or mono, and then continue with sotorasib. So I would like to see these data to understand what is the role for that compound in what kind of sequence. And the other is that, you know, if there are data for first line option, then we really have to understand that we need data of the G12C patients for the overall outcome without sotorasib. We have to really learn more about these patients.
Thank you. We'll go for the last question in the voting. Nivo-Ipi plus 2 cycles of chemotherapy for stage 4 non-small cell lung cancer as an upfront therapy is a good option and less chemotherapy. Yes, no, I prefer to wait. And we'll need a comment from Dr. Walid and Christian, please. So as a result, 78% they found that it's a significant study, and about 4% no. 19% I prefer to wait even after 2 years of the updated data. What do you think, Dr. Walid?
Luckily for non-small cell lung cancer, we have nowadays multiple options for the first line treatment, including immunotherapy combination with a chemotherapy treatment. For a patient who you prefer to give less chemotherapy treatment, this is a good treatment options. If your hospital have all immunotherapy agents, nowadays we have multiple agents. Not all hospital they have access, not all patients they are able to take care of the cost of this treatment. So it's a good options if the patient want less chemotherapy treatment. However, even recently, this is the first treatment, this is the first trial that's proving dual immunotherapy in non-small cell lung cancer. And recently in WCLC, we have the Poseidon trial, durvalumab, tremelimumab, again, in combination with dual immuno plus chemotherapy. It also showed overall survival. So having different options, it's always good for the sake of the patient. The only difficulties will be the cost and the availability and whatever the patient prefer.
Perfect. Last comment from you, Christian, and we have to little bit, we are run of time.
I personally believe that the role of ipilimumab in lung cancer is an important one. And the most intriguing data set I've seen from the CheckMate 9LA is the patients who had severe side effects due to the nivo-ipi still had a higher benefit even if they were not re-exposed to that combination. So obviously we do not know at all how much or how many shots we need of the IPI drug. So this is, I think, would be helpful to understand. You give 2 cycles of chemo, 1 shot of IPI, and that's it. And we have to learn, though, we use this now for pleural mesothelioma patients, nivo-ipi. This is a toxic combination. And if we could just have a learning curve for that, maybe we need less and it's still effective, that would be very helpful.
Thank you very much, Christian. That was lovely. And it was very comprehensive as well. And thank you for all attendees and all speakers for excellent presentations and discussion. I will close the session, the lung session now, and we'll go for the satellite symposium. Thank you very much and have a great night. Thank you.
Thank you very much for everything. Bye-bye.
Bye. It's my great pleasure to now we'll start the Kirin satellite symposium, and it's my great pleasure to introduce our eminent speaker, Matteo Apro. Professor Matteo Apro is known for everybody. He's medical oncology and director of the oncology department in Switzerland. He will give us a talk about from Nopogen to Neulasta, legacy in protecting patients from febrile neutropenia. Thank you very much, Professor Apro, for accepting our invitation, and the floor is yours. Thank you.
Thank you very much for your kind introduction. So sorry, I saw at one of the votings that some of you prefer to be online rather than face-to-face. I must say that after 18 months of communicating using these sophisticated systems, I would really like to be there, see some of my very good friends, see others that are going to become very good friends, and have discussions also outside of the main room. But the reality is this one. So I was asked by Kiowa Kirin to share some thoughts around the growth factors to avoid the febrile neutropenia. I do have some conflicts of interest. They are all highlighted here on this slide. As I always say, I have enough conflicts not to have any. So I will go through various areas. Of course, the guidelines that exist, highlighting, as I'm a European, the European contribution, but I also mentioned the excellent contributions from elsewhere. And then as I was asked to look at the data that support the use of long-acting growth factors like Neulasta. And then finally just mention about this on-body injector that I understand is going to be available relatively soon in your area. So the URTC guideline that I suppose is quite well known to the majority of you was published in 2010 and highlighted the fact that you have to evaluate what is the risk that the patient has of having a febrile neutropenia. You are quite familiar with the chemotherapies you use. However, if you are not familiar with the new chemotherapy, usually on the websites of the learned societies like NCCN and ASCO and ESMO, you will find these listings that will help you. However, very importantly,
There are areas of uncertainty. The age of the patient, and all the data show that age 65, because of the way the studies were done, is increasing the risk of febrile neutropenia, and also increase the risk that the febrile neutropenia is going to be a complicated febrile neutropenia. It is certainly a surrogate for comorbidities. It is not the number, but this is what we have that we can put there as a level 1 evidence. And then, of course, the more advanced the disease is, the more frail the patient is, the higher the risk of a complication related to the febrile neutropenia. ESMO then updated the data, not change much compared to what we had already published several years ago, but insisted very much on the management of febrile neutropenia in its paper, and we'll come back to this at the end. And of course, ASCO has its guidelines. We have the NCCN guidelines of the United States that many of you are extremely aware of, but they all come to very similar conclusions because the majority are evidence-based. As we are here, we know that throughout the world, we have this pandemic going on. We have some issues in many countries still today. And as soon as it started to hit, there were reactions from various learned societies, and ESMO was probably the first one to publish modified guidelines for the use of GCSF because of the pandemic, stating that if only possible, with the approval of regulatory authorities in your country, you should expand the use of GCSF prophylaxis to all patients at intermediate risk. In some settings, maybe use antibioprophylaxis, which is nevertheless something that we always are nervous about because of the risk of increasing the number of resistant bacteria strains, and then use the mask index that I will mention at the end. Of course, ASCO has come with its own guidance. You can go to the ASCO website. It is updated regularly. Here is what it looks like. And it gives you very good guidance, which, as I said, is updated regularly. And NCCN has not only on its website some guidance, but has a very nice paper which published by Elizabeth Griffiths and colleagues, and which very nicely summarizes not only the use of GCSF, but of issues also related to anemia and thrombocytopenia. So what are the data that are available to us to indicate that we might want to think more about the use of pegfilgrastim, Neulastime in the case that we are discussing here, rather than a short-acting compound? Well, we have several reviews, and one of was published by Mitchell and colleagues in a very good journal read by the Pharmacists. And this is a meta-analysis looking at not only studies, but at the real-world clinical settings, on the data that was available to these authors from 2002 to 2014. And they found 18 real-world observation studies. The majority can be criticized for being retrospective, but nevertheless, all of these studies pointed to the fact that within the limits of these studies, there was an advantage for a better prophylaxis with pegfilgrastim compared to short-acting GCSF. With a group of colleagues whose names you can see on this slide, we did the review of the available data using a very systematic approach. This is a publication that is freely downloadable on the website of Supportive Care in Cancer. And we came to very similar evaluation, especially looking at the data that was put together by our German colleagues that showed that in the German studies, when long-acting GCSF was used rather than the short-acting, there was an advantage in terms of a better control of the potential of febrile neutropenia with chemotherapies that were leading to high rates of febrile neutropenia, like the combination of docetaxel, anthracycline, and cyclophosphamide called TAC. And finally, there has been a very nice systematic review by Wang and colleagues that looked at all the G-CSF drugs, and they came to a very similar conclusion in that they studies showing that there is a clear advantage for pegfilgrastim from all of these different studies, because probably, in my opinion at least, there's a misuse of the short-acting, which are used for too short of a time, as indicated in many studies, where the short time period that many of us use for short-acting is clearly less effective. But fortunately, we don't see that because often our chemotherapies are not that neutropenic as we might believe they are. So what further arguments do we have about the use of pegfilgrastim compared to filgrastim, of Neulastine compared to Neupogen? Oops, I lost the line. There we go. We have to understand the differences between these compounds, and this is what I'm showing on this particular slide. As you all know, pegfilgrastim, the long-acting, is long-acting because the pegylation makes it not amenable to renal clearance as filgrastim is. The clearance of the pegylated form is a clearance by the white blood cells. So when there's neutropenia, the clearance is modest. As soon as the white blood cells start under the stimulation of Neulastine to come back, they will metabolize Neulastine. So there is no risk of Neulastine remaining too much on board. Many people ask, oh, but there's a risk of overshoot. No, there's no, and there are data from studies that show there's no overshoot when Neulastine compared to a long-term use of a short-acting compounds. So another way of looking at this is also the fact that the short-acting ones, which should be normally used according to the label until you have come over the nadir, and who can inflict on the patients the need for blood counts every 2 to 3 days, whether they come back from a nadir or not, especially in these COVID times, in order to use the appropriate dose. Well, what we have for the long-acting one is that we don't need this. We know that it's going to stay in the body. It's simple to use. It's a single dose, no further complications, and it has some clear advantages, therefore. Here's some of the data that I was mentioning to you from that are included in the meta-analysis that have shown that the rate of febrile neutropenia is lower with long-acting with Neulastine, except in the study of VOS. There's always this one study which doesn't show these impressive data that you would like to see. As said, the single injection once per cycle simplifies, reduces the need for hospital visits, reduces discomfort for patients. When we discuss with patients that for one reason or another were started on daily injections, this is what annoys them, it's the daily injection, and they will ask for that. This was the case when in our clinic we were switching to long-acting. As we now use as a standard long-acting for the last few years, we have no such problems. And of course, there's always the question of when are we going to give the injection? We know that unfortunately, there are some issues, even though there's ample literature, and this was very nicely reviewed by Gary Lyman, that show that the indication that is in the label that you should inject the drug 24 to 72 hours after the end of the chemotherapy is absolutely valid. Some colleagues continue to use the drug also injected on day 0, neglecting the data that is out there in the literature to show that actually injecting on day 0 is counterproductive. As injecting 24, 72 hours later can be somewhat complicated depending on your healthcare environment, there has been the development of this very interesting device, which is a self-injector, which is now approved and in the Kingdom of Saudi Arabia and has been approved in many other countries throughout the world, and simplifies the approach for the patient. It is very simple to use. You just put it on the patient arm. It's a very simple instructions, and then it will automatically do the injection at the timing that is appropriate, i.e. 24 hours after the end of the chemotherapy. And there are ample scientific data to show that this injector behaves very much the same way as a manual injection through a syringe. And there are many studies that have shown that when you ask the patients about the comfort and of this compound, of this device, and the way it works, patients that have experienced the two ways have, in the great majority, more than 90% stated that they prefer the on-body injector that also allows them not to have to go to see or be seen by a healthcare professional when they are in the privacy at home. So to conclude, I have shared with you 3 types of arguments that favor the use of long-acting growth factor pegfilgrastim. Is the superior efficacy that I showed to you, and also I didn't share to you the low antimicrobial use, but this is in the Mitchell paper that I gave you as a reference. Then this issue of the poor dosing that we have for filgrastim in situations of high risk, 5 days is not enough by all evidence that we also reviewed. This is the reference number 3 on this slide. And we know that unfortunately, in the Kingdom of Saudi Arabia, some of our colleagues still give an injection on the day of chemotherapy, which should not be done for any growth factor. And then, of course, it is so much easier for the patient, so much more convenient, that I think that there's no discussion about the advantage of PEG versus several days of injection of a short-acting compound. And finally, during this pandemic period, let's not forget that there's support from all learned societies for liberal use of GCSF prevention, with just a caveat: in patients at risk of lung toxicity. This is in all of the guidelines. With this list, our slide here, you have a QR code that, of course, Kiara Karina is going to be happy to share with you for further information, should you wish to have further information about prevention of febrile neutropenia or the use of neolastin. So thank you very much for your attention.
Thank you, Professor Abro, for excellent presentation and update. We do have one question from the audience regarding that.
I lost the voice connection. Mic still not working.
Okay. Did you hear me now?
Now I hear you.
Okay, thank you. So the question from the audience that, did you change all your patients from Nopogen to bifilgrastim, putting in consideration the cost? And what is the daily practice you are using?
I do understand that the cost could potentially be an issue. We do have data in the healthcare environment of the United States that show that the long-acting pegfilgrastim, specifically Neulasta, as they call it in the United States, is cost-effective. In our environment, in Switzerland, I mentioned earlier, we have switched to a long-acting many years ago because of the convenience for the patient, because in our environment, the daily injections given by the healthcare professional to patients do have a considerable cost that oversets completely the increased cost of an ampoule of long-acting compared to 7 days or 10 days of injections of a short-acting. So for us, that is a non-issue.
Okay. Another question regarding that oral medications, which in some cases can cause grade 1 to grade 2 neutropenia, like palbociclib, like Xeloda and Lonsurf. Do you are using the GSF, either Neopagen or Neulasta for the patients or in specific situations?
This is an excellent question. All the data on the use of GCSF have been developed with chemotherapies giving over 1 to maximum 3 days, rare data with 5 days in the setting of, for example, testicular cancer treatment, according to one protocol, which is probably not used anymore because we have switched to the 3-day one. You mentioned some of these drugs are given on a daily basis. There are no data to use GCSF in these settings. The majority of these patients never have a febrile neutropenia. They're followed most often than not on a weekly basis the first few weeks. And then you mentioned something very important, which are the cyclips. There's a clear indication, and there's a very nice review by Maria Katzaniga, if you want to look it over on the internet. I can't remember in which journal it is, on the fact that all the data we have point to the fact that growth factors are not needed when you have a neutropenia related to the use of cyclips. This neutropenia is very quickly reversed when you stop the cyclips. It's a completely different mechanism of the progenitor cell damaging toxicity of cytotoxic chemotherapy, and therefore all guidelines indicate that the growth factors should not be used in that setting. You simply allow the recovery, which comes just as quickly and without the need for these agents.
I would like to thank you again and thank all the attendees. We will close the satellite symposium and we'll move to BMS satellite symposium, Professor Dr. Al-Hamad and Dr. Ahmed.
Thank you very much.
Thank you, my dear.
It's my pleasure. Can you hear me? Hello. It's my pleasure to present the next symposium, satellite symposium, sponsored by BMS. Dr. Ahmed Al-Habi, attending consultant, King Faisal Specialized Hospital in Jeddah. He will lead us and talk about deep dive in advanced non-small cell lung cancer treatment landscape in the era of immunotherapies.
Well, first of all, assalamu alaikum wa rahmatullah. Thank you very much for your kind invitation and kind words, Ashley, for the introduction as well. I was given the task of talking about the deep dive in advanced non-small cell lung cancer, mainly in the era of immunotherapy. And here I'm going to be talking solely about the metastatic setting of non-small cell lung cancer. So the main objectives of the talk are going to be to identify the new studies in the management of metastatic non-small cell lung cancer with the use of IO, what are the new potential IO therapies that we can use in this setting, and what are the recognizable potential role of dual IO therapy in metastatic non-small cell lung cancer, and to identify key differences in favor of dual IO versus mono IO or in combination with chemotherapy. So the main outlines of the talk will be going over the single agent IO therapies, the form of Keynote-24, pembrolizumab, Empower 110, atezolizumab, and Empower Lung 1, cemiplimab, which is a new player in the immunotherapy world of metastatic non-small cell lung cancer. Chemo IO will go over Keynote-189, 407, the Empowers 150 and 130, and then dual IO with 227 Checkmate and the Checkmate 9LA. So single agent IO. Keynote-24, as we all know, is the most infamous trial that was conducted a few years ago with the use of pembrolizumab versus platinum doublet chemotherapy in stage 4 non-small cell lung cancer as a first-line therapy. As you can see here, the patients that were enrolled were stage 4 non-small cell lung cancer, PD-L1 positive, more than equal 50%, ECOG 0 to 1, no drivers mutations were allowed, no untreated CNS metastases, and no active autoimmune disease, as we all know. The main stratification were based on ECOG 0 to 1, tumor histology, squam versus non-squam, and the region where the study was conducted. They were randomized 1-to-1 to either pembrolizumab versus platinum doublet chemotherapy, with maintenance pemetrexed was allowed in non-squamous histology. The main primary endpoint was PFS. Secondary endpoints were overall survival, then overall response rate, and there was a crossover that was permitted for pembrolizumab, should there be progression on the control arm. So the overall survival, as we all know, it was strikingly positive with the hazard ratio of 0.62 and the median overall survival in favor of pembrolizumab of 26 months versus 13 months of chemotherapy. As you can see there, actually the graphs, the lines separate early on and they stay well separated from thereafter. At 60 months, the rate of overall survival would be around 32% versus 16% in favor of pembrolizumab. Again, the response rate was in favor of pembrolizumab, namely with a duration of response of almost 29 months versus 6.3 months for chemotherapy. Again, in the first plot, you can see that all subgroup analyses would have gained significant benefit when pembrolizumab was introduced. Keep in mind that the brain metastatic disease, despite having some benefit, it was not as clear because they did not enroll untreated CNS metastatic disease. As we all know, with immunotherapy, the never smokers did not yield as much benefit. Moving on to the Empower 110, and that study looked at squam or non-squam non-small cell lung cancer that is stage 4, PD-L1 positive, and they were stratified according to sex, ECOG, and PD-L1 expression and histology. And they were randomized 1-to-1, either atezolizumab upfront or arm B, which is the control arm. They were given the respective chemotherapy according to the underlying histology, and pemetrexed was allowed to be on maintenance should it be a non-squamous non-small cell lung cancer for that arm. And atezolizumab was given until disease progression or intolerable toxicity would occur. Primary endpoint would be overall survival in the wild-type population, and the key secondary endpoints would be investigator-assessed PFS, overall response rate, and duration of response. Here, the overall survival in the high PD-L1 expressors was quite positive for patients who were treated with atezolizumab at the 12 months. It would be 64.9% versus 50% for chemotherapy. Hazard ratio is 0.59. As you can see there, the median overall survival would be about 20.2 months versus 13 months on the longer follow-up for these patients. Again, the first plot showed significant benefit when atezolizumab was given, regardless of the underlying histology, but mainly in the ones who had the PD-L1 positive of TC3 or IC3, as you can see there, with a hazard ratio of 0.59. Again, as you notice here, the never smokers did not yield as much benefit as we all know. How about the overall population? Again, on the overall population, despite having some benefit, with overall survival being 17.5 months versus 14.1 months, it was not statistically significant. So we only use atezolizumab as a single agent in high PD-L1 expressors, as I just showed you. Moving on now to the new player in the world of metastatic non-small cell lung cancer, although it's not new in the world of metastatic squamous cell carcinoma of the skin, but in the lung it is new, that is cemiplimab. Cemiplimab is a well-known high-potent anti-PD-1 immunotherapeutic agent, and the Empower Lung 1 is a phase 3 open-label randomized controlled multi-center global study. As you can see there, with patients being enrolled, they had to have a stage 3B or 3C, ineligible for concurrent chemotherapy, or stage 4 non-small cell lung cancer, squam or non-squam, untreated. ECOG of 0 to 1, PD-L1 had to be at least 50%, no activating drivers mutation allowed, and they allowed adjuvant or neoadjuvant chemotherapy should have been received in the past. Stratification factors based on tumor histology, geographical location, and smoking status. And as you can see there, they were randomized 1-to-1, either to cemiplimab at 350 milligram IV Q3 weeks, given it every 30 minutes for up to 36 cycles, versus the investigator's choice of chemotherapy based on the underlying histology. As you can see there, non-squam, again, they got the pemetrexed, and should there be progression on the control arm, then they can go ahead and receive cemiplimab. Sorry, that was an error. It should not read pembrolizumab. Primary endpoint would be overall survival. PFS, secondary endpoints would be overall response rate, duration of response, health rate, quality of life, and safety. As you can see there in the population, it was well balanced between both arms. Most of the patients were non-squam, and most of the patients basically had metastatic disease as opposed to locally advanced disease. So the overall survival in the PD-L1 more than equal 50% when cemiplimab was given versus chemotherapy, it was not estimable during the analysis that was shown in the recent lung cancer conference, and the hazard ratio was 0.57 versus chemotherapy would be 14 months. Again, progression-free survival with PD-L1 more than equal 50%. It was in favor of cemiplimab of 8.2 months versus 5.7 months with a hazard ratio of 0.54, as you can see there. Again, on the forest plot, all patients in the subgroup analyses where cemiplimab was given a PD-L1 positive more than equal 50%, again, significant benefit. And I have to point out the very metastatic disease at baseline showed significant benefit despite the small numbers, but the hazard ratio was quite significant, 0.17. In conclusion, treatment with cemiplimab resulted in significantly longer overall survival and progression-free survival, reducing the risk of death by 43% in the PD-L1 of at least 50% population and by 32% in the intention to treat population. I just made this small table where I can go over the adverse events differences between the pembrolizumab as well as atezolizumab versus cemiplimab, and with all the limitations in the cemiplimab because it's just been released when we need further follow-up, it seems that the adverse events are almost similar between pembrolizumab and atezolizumab, and cemiplimab, although being 14% for grades 3 to 5 for adverse events, but we need further assessment when the data becomes more mature in the future. Moving on to the chemo-IO evidence now. For the Keynote 189, as we all know, it is a phase 3 study looked at chemotherapy plus pembrolizumab in the non-squamous stage 4 non-small cell lung cancer, ECOG 0 to 1. Again, they did not enroll driver's mutation, and they had stable CNS metastases before enrollment. The main stratification factor were based on PD-L1 more than equal 1% versus less than 1%, and platinum-based chemotherapy was cisplatin versus carboplatin, and smoking status was enrolled. They were enrolled 2 to 1. For the experimental arm with the use of pembro plus chemo versus chemo, and pembrolizumab was carried out along with pemetrexed in the non-squamous histology, and as we all know, it's a purely non-squamous for Keynote 189. Primary endpoint was PFS or overall survival. Secondary endpoints were safety, overall response rate, duration of response. The overall survival, and that's the final analysis, intention to treat population for all subgroups. It was in favor actually of the pembrolizumab when it was given with chemotherapy of 22 months versus 10.6 months and significant hazard ratio of 0.56. I'd like to point out the 24-month rate of overall survival being 45.7% versus 27%, which is almost doubling with pembrolizumab was given chemotherapy in the all intention to treat population. When you look at the subgroup analyses on the left, on the right, on the left far side, you can see on the graph that the TPS more than equal 50% was significant with pembro and chemo, and on the more negative population or not highly expressive of 1 to 49%, it was in favor actually of pembrolizumab plus chemotherapy of 21.8 months versus 12 months, and the negatives or TPS less than 1%, it was in favor of pembro plus chemo, and it actually that goes in line with the most recently presented abstract and study in ASCO 21, which showed and stated very clearly that patients who had not as highly expression of PD-L1, meaning that less than 50% should receive pembrolizumab plus chemotherapy. So moving on to the Keynote 407, again, that is a study that's similar to Keynote 189 in terms of pembrolizumab was given with chemotherapy for 4 cycles, and then pembrolizumab as maintenance versus the arm where chemotherapy was given alone. I have to point out that this study was only done in the squamous population of stage 4 non-small cell lung cancer. Again, the eligibility criteria was quite similar with the stratification factor based on the PD-L1 of less than 1% versus more than equal 1%, and the choice of taxane, paclitaxel versus not paclitaxel, and the geographic location. Primary endpoints was PFS and overall survival, and then secondary endpoints were overall response rate, duration of response, and safety. The overall survival, and this is the updated analysis of overall survival, showed significant benefit of pembrolizumab when it was given with chemo in favor of the pembrolizumab arm of 15.9 months versus 11.3 months with a hazard ratio of 0.64 and significant p-value. And the first plot shows significant benefit of pembrolizumab across all subgroup analyses, as you can see there, regardless of the choice of taxane or the region where the patients received the pembrolizumab chemotherapy. So when you look closely at the subgroup analysis, I'd like to draw your attention to the graph on the left far side of the slide, with the TPS less than 1%. Pembro, when it was given with chemotherapy, the median duration or median overall survival was almost 16 months versus 10.2 months, with a hazard ratio of 0.61, and the low expressors gained significant benefit as well of 14 months overall survival versus 11.6 months and hazard ratio of 0.57. As we all know, the higher the expression for TPS more than equal 50%, the more the benefit. So with that, we'll move on to the Empower 150, and that is the use of atezolizumab with different agents of chemotherapy plus minus some bevacizumab. As you can see there, the study was done in stage 4 lung cancer metastatic, stratified based on sex, PD-L1 expression, and most notoriously is the liver metastases. So it was predefined prior to the study was done. They were randomized to 3 arms. Arm A was atezo chemotherapy, carboplatin, paclitaxel. Arm B was atezo, carboplatin, and bevacizumab. Arm C was carboplatin and bevacizumab, and they were continued respectively for atezo, beva, or bevacizumab accordingly. So baseline characteristics were quite well balanced, and they actually enrolled patients who had EGFR mutation and positives, although that they were small numbers, but they were enrolled in the study. So the overall survival and intention to treat wild type population, meaning the EGFR wild, they were not mutated, it was in favor of the atezolizumab arm of the arm B, which is the quadruplet versus beva chemotherapy of 19.2 months versus 14 months with a hazard ratio of 0.78. And in the arm B, the overall survival and intention to treat population, including the mutants and the wild types, again, it was in favor of arm B of almost 20 months versus 14.9 months for atezolizumab with a hazard ratio of 0.77. So how about the addition of bevacizumab to atezo and chemotherapy? When they looked at a very subgroup analysis of EGFR and ALKs, as you can see there on the left-hand side, it showed that there might be some signal of benefit when atezo was given along with beva and chemotherapy, and the patients who had EGFR or ALK positive versus beva and chemotherapy. It was not estimable during the time of analysis for overall survival versus 17.5 months with a hazard ratio of 0.54 versus when arm A, which is atezo plus chemo versus beva and chemotherapy was given. So that slide on its own raised a lot of controversies and a lot of discussions amongst different thoracic oncologists. Definitely, it is something to be taken as a point or face value, and we need further analyses and exploratory studies to confirm what we had seen as a signal in this study. So moving on to the Empower 130, which is basically atezolizumab that was studied with chemotherapy versus chemotherapy in patients with non-squamous, non-small cell lung cancer. Again, they were stratified based on sex, liver metastasis, and PD-L1 expression. As you can see there, atezo was continued as a maintenance therapy versus best supportive care in the control arm. The primary endpoints or co-primary endpoints were PFS and overall survival in the intention to treat wild type population. And as you can see there, the definition of wild type population were patients who were excluded of having EGFR positive mutations. And the key secondary endpoints were overall survival and PFS in the overall population, including the EGFR and positive ALKs. So the overall survival in the wild type population of intention to treat analysis was in favor of atezolizumab with chemo with 18.6 months versus almost 14 months, although hazard ratio is 0.79, which is not striking, but a significant p-value. Forest plot, again, it was shown that it is in benefit of the atezo plus chemotherapy. However, the liver metastatic disease, it did not seem to be gaining as significant a benefit with atezo and chemo alone. So there might be some significant role when bevacizumab was given along with atezo and chemotherapy, and this speaks of the role of anti-VEGF and the metastatic non-small cell lung cancer, especially when the metastasis is being identified. So based on the PD-L1 status, it seems that every single PD-L1 status, regardless of high or low expression, gained significant benefit when atezolizumab was given along with chemotherapy, as you can see there. And this is a slide just to remind myself and our colleagues of the adverse events that you can see with different chemotherapeutic agents along with immunotherapy, which was being given, as you can see on this slide. So now moving on to the dual immunotherapy, we'll be talking first about the Checkmate 227, which has been presented by my colleague and earlier. As we all know, the Checkmate 227 looked at stage 4 or recurrent non-small cell lung cancer, regardless of histology, no prior systemic chemotherapy, no driver's mutation allowed, no untreated CNS metastases with an ECOG 0 to 1, and they were stratified accordingly to squam versus non-squam to one of two groups. The first group had the PD-L1 more than or equal 1%, and the second group less than 1%, and they were randomized to 3 arms respectively in each group. Nivo plus epi for the PD-L1 more than or equal 1%, or chemo or nivolumab, and if it was less than 1%, they would receive nivo plus epi versus chemo versus nivo plus chemo. And the primary endpoints would be PFS in high tumor potential burden, overall survival, and PD-L1 more than or equal % population. As you can see there, when they looked at the 3-year update of our survival of nivo plus epi versus chemo and PD-L1 more than or equal 1%, it was in favor of nivo plus epi of 17 months versus almost 15 months of chemo, has a ratio of 0.79. But I'd like to draw your attention to the graph. As you can see that in the first 6 months, there was not as good of a response rate when the combination of immunotherapy was given as opposed to chemotherapy. But after 6 months, that initial dipping of the curve would resolve and would go away from there on. So the 3-year update of nivo plus epi versus chemo versus nivo, again, it was well maintained when nivo plus epi was given of 17 months versus 15.7 months. So this speaks of the potential benefit of the synergistic benefit with nivo plus epi, as you can see there. So how about the PD-L1 negatives, or less than 1%? Again, this actually when nivo plus epi would win in this battle. As you can see that the median overall survival would be 17.2 months with a hazard ratio of 0.64, significant benefit with nivo plus epi in that population. So moving on to the CheckMate 9LA, if I can remind you about that initial dipping of the curve that you can notice in the CheckMate 227, and this is exactly the basis of why CheckMate 9LA was done or studied. And as you can see there, right, it was done on metastatic non-small cell lung cancer, squam or non-squam, no driver's mutation, ECOG 0 to 1, stratified based on PD-L1 negatives or more than or equal 1%, and SACs along with histology of squam versus non-squam, randomized 1-to-1, either to nivo plus epi plus chemo for 2 cycles only versus chemotherapy for 4 cycles. And the primary endpoint would be overall survival, PFS, overall response rate, and efficacy by tumor PD-L1 expression. So the initial deepening of the curve that we had seen with CheckMate 227 had resolved completely when we had added the 2 cycles of chemotherapy to the dual immunotherapy, as you can see there. And the overall survival was in favor of the dual immunochemo, 14 months versus 10.7 months, and the hazard ratio 0.69, significant p-value, as you can see there. The updated analysis was in favor of dual immunochemo of 15.6 versus 10.9 months, and hazard ratio 0.66. And that's the forest plot, which showed significant benefit of all subgroup analyses, as you can see. And I have to point out the CNS metastatic disease, which showed significant benefit as well with immunotherapy chemo. Again, this reminds ourselves of the adverse events that we can see with different regimens. And this is not meant to compare one trial versus the other because of different population, different stratifications. And again, the same tables that I had shown before, and I'm just showing it again. So what's my approach with metastatic non-small cell lung cancer? I have to divide it broadly to either adenocarcinoma or squamous cell carcinoma. With adenocarcinoma, putting aside the EGFR mutations, I'm not going to be talking about driver's mutation. I look strictly at the PD-L1. If it was more than or equal 50%, and I need the rapid response rate, then I would have to go down the path of chemo-immuno. If I don't need a rapid response rate, then I can utilize the single immunotherapeutic agent. And if I'm seeing a patient who was negative or low expressor of PD-L1, then I would go with chemo plus immunotherapy. Squamous cell carcinoma, again, it's the same utilization. If I need a rapid response, I would go with chemo-immuno. And if I don't need a rapid response, it's going to be a single agent immunotherapy. And if it was a low expression or no expression of PD-L1, then I can use and utilize single agent immunotherapy accordingly. With that, I conclude my presentation, and thank you very much for your kind attention.
Thank you very much, Dr. Ahmed, for this very rich and comprehensive talk. I don't know if there is any other question, or should we move to the next satellite symposium?
Thank you, Dr. Ahmed, for the excellent presentation. My question that for 9LA, we found that the patient more than 75 years, they are not benefit from the treatment. And we know that the theme of the study that giving less chemotherapy, but in the study, we can see that as patient over 75, they are not candid. How do you explain this, please?
No, yeah, I think this is an excellent question. And this all boils down to the single patient's tolerance of chemotherapy, to be honest, and whether or not basically they have any contraindications to chemo plus immunotherapy, if I can say that. Again, the chemotherapy that is being given with the immunotherapy can still have play a major role in determining the side effects that these patients can have, and potentially can be exacerbated should you deal with patients with a lot of comorbidities. And as you can imagine, patients who would have more than equal 75 years of age would have a lot of comorbidities. And that can be a limitation to us in terms of the chemotherapeutic options that we can provide for them, as well as the immunotherapies. And that can explain why these patients did not gain as much benefit. However, again, it all boils down to the right patient's population. Should you have a patient who have a lot of comorbidities and they are younger and fit for chemo, I would actually offer them this combination of only 2 cycles of chemotherapy along with the dual immunotherapy because of the significant improvement that we had seen in the trial.
Okay, thank you very much. Thank you, Dr. Ahmed, and also extend thanks to our partners and colleagues in BMS. Now the third satellite symposium, Dr. Mirvet.
I will start. Thank you again for attending, and I will go for the third satellite symposium for AstraZeneca. And it's our pleasure to introduce Professor Federico Capuzzo. Professor Capuzzo is a well-known name in lung cancer field, and he is the Director of Medical Oncology at National Cancer Institute, Rome. Professor Capuzzo, who will give us a talk about EGFR mutation non-small cell lung cancer treatment roadmap. Professor Capuzzo, please.
Yes, thank you very much for the kind invitation. I'm really sorry that I'm not there in person, but you know, this is a very bad period. So I don't know if you already have my slides or if I have to share my screen. I don't have any problem in any case to share my screen if this is the way in which we should proceed. Just a quick second and I take my, okay. So do you see my slides? Do you see my slides?
Yes, absolutely. Yeah.
Okay, so thank you very much again. So very quickly, this is my disclosure. So I'll give you an overview of particularly anti-EGFR therapies with some update, particularly in early stage and in advanced disease. And I want to just start my presentation just remembering that unfortunately, the vast majority of our patients present metastatic disease since the beginning. So approximately 60% of cases are already metastatic when we perform the diagnosis. But we still have approximately 40% of patients with local disease, locally advanced or potentially resectable. And in these patients, surgery is treatment of choice, of course. But unfortunately, when we look at the data, the survival at 5 years, even in very early stage disease, is disappointing. We have a consistent proportion of patients, unfortunately, relapsing and dying within 5 years. And this is the reason why in our practice, we are generally offering or proposing to our patients adjuvant chemotherapy. The problem for adjuvant chemotherapy is that nobody really believes in the efficacy of adjuvant chemotherapy because the benefit is marginal. And when we look specifically at the data, the absolute benefit at 5 years is only 5%. So clearly, this is a toxic treatment, reducing the risk of relapse, improving survival, but this benefit is marginal. So clearly, we need additional therapies. We need more effective treatment. And during the last years, different clinical trials investigated specifically in the group of patients with EGFR mutation the impact, the role of EGFR TKIs. And I want to present you data from a clinical trial that was presented very recently during the ASCO meeting, the IMPACT trial. That was a phase 3 trial that was conducted in Asia, comparing this one of the standard chemotherapeutic regimen that we use in our practice, that is the combination of cisplatin and vinorelbine, or gefitinib. And in patients, of course, EGFR mutant. But when we look at the data, there is no benefit in terms of disease-free survival, and most importantly, in terms of overall survival for those patients receiving gefitinib versus chemotherapy. So in addition to these disappointing results, when we look also at the site of disease relapse, it's important to note that distant metastases were more frequently observed in the group of patients treated with gefitinib. And importantly, specifically, one of the sites in which the incidence, the risk of relapse of the disease was higher was the brain. And we know that brain metastases represent an important problem in clinical practice, an important problem, of course, for our patients, impacting negatively quality of life. So the treatment with gefitinib was not able to prolong disease-free survival, was not able to prolong survival, was not able to reduce the risk of occurrence of brain metastasis. This is extremely important because these data are clearly in favor of another drug, that is osimertinib. And specifically, I want to show you the data coming from the ADAURA trial. Probably all of you know this trial. I just want to very quickly remember that the ADAURA trial was a phase 3 trial comparing osimertinib versus placebo in completely resected patients with stage 1B to 3A non-small cell lung cancer. In this trial, osimertinib was given for a period of 3 years. Well, when we look at the general characteristics of the patients that were included in the study, as you can see here, there is approximately 1/3 of patients with stage 1B, 1/3 in stage 2, and 1/3 with stage 2A. And approximately half of these patients also received adjuvant chemotherapy. And these are the data. So in terms of the disease-free survival in stage 2 and 3A, that was the primary endpoint of the study, you can see that there is a significant and amazing improvement in terms of disease-free survival, favoring patients receiving osimertinib. So clearly the two curves diverge since the beginning. There is a reduction in the risk of progression of approximately 83%. So this is a very important, relevant on the statistical point of view and on the clinical point of view, favoring the positive effect of osimertinib. Also, when we look at the whole population, so include also when we analyze the disease-free survival in patients in stage 1B, 2, and 3A, again, there is a significant benefit in terms of progression-free survival for patients receiving osimertinib versus placebo. In this trial, of course, was also important to analyze the outcome according to the different subgroups. And you can see here that the benefit was present across all subgroup of patients, irrespective of any clinical characteristics, irrespective also of biological characteristics, because you can see that the benefit was present in deletion 19 mutation, as well as in patients with mutation in exon 21. And according to clinical characteristics, the benefit was present in all subgroup, so in young and elderly patients, in stage 1B, 2, and 3A, in patients receiving or not adjuvant chemotherapy. And I want to provide you also some additional details on these subgroups. These are the data in terms of disease-free survival in stage 1B, 2, and 3A separately. And you can see that the benefit was present in all of these subgroups, specifically in the group of patients with stage 1B. The benefit clearly was lower simply because this is a group of patients with the lowest risk of relapse. But even in this group, the treatment with osimertinib was able to reduce the risk of progression by 50%. So clearly there is a significant impact even in this group of patients. One of the most relevant questions we have when we discussed about the results of the ADAURA trial was if we really need adjuvant also chemotherapy. So if we need in EGFR mutant to add chemotherapy. Well, in this trial, approximately half of the patients received adjuvant chemotherapy. Of course, the percentage of patients receiving chemotherapy was higher in stage 2 and stage 3A, as expected. And when we look at the results, again, the benefit was present irrespective of the fact the patient received or not adjuvant chemotherapy. So these data are confirming the efficacy of the drug irrespective of the previous exposure to chemotherapy, but are not able to solve the question whether we really need chemotherapy or not. This remains clearly an open question. Of course, when we discuss about adjuvant therapy, the most critical endpoint is survival. In patients resected, in patients receiving a curative treatment, of course, what we need is to demonstrate a favorable survival impact of the treatment. We want to try to increase the curability of the disease. Well, at the present time, we don't have data on overall survival. The data are very, very immature, and the very preliminary data that are not that we cannot consider as accurate suggests at the present time no difference. But I repeat, we need a longer follow-up. So this is an information that probably we can obtain in the next years. In the meantime, we have some additional data strongly convincing us that this is the new standard of care in the adjuvant setting. Because specifically when we look at the type of recurrence, clearly patients relapsing, the percentage of patients relapsing is lower in the osimertinib group. And you can see here that patients receiving placebo generally relapse by developing new metastases, while patients treated with osimertinib has a lower relapse rate, and generally those patients relapsing generally relapse in the local, so have a local relapse instead of a distant metastasis. And specifically, when we look at the site of relapse, you can see here that what is particularly important is that patients treated with placebo also had a relapse in the brain, while a relapse in the brain was almost zero in the group of patients receiving osimertinib. And specifically, when we look at disease-free survival in the brain, you can see here that at least during the 3 years in which the patient received osimertinib, there is almost no risk of relapsing in the brain, while patients receiving placebo, they could relapse in this very important organ. So these data clearly are enough convincing for considering osimertinib the new standard of care in EGFR mutant, in resected EGFR mutant non-small cell lung cancer, even if we don't have mature survival data. In fact, we know by this data that during the 3 years in which the patient received osimertinib, this patient is disease-free, and also this patient is not developing brain metastasis. This confirms the ability of osimertinib to cross the blood-brain barrier and to be effective in preventing occurrence of brain metastasis. So the consequence is that at the present time in 2021, in resectable stage 1 to 3A non-small cell lung cancer, EGFR testing is mandatory, and in patients that are positive for EGFR mutations, for classical EGFR mutations, so a mutation in exon 19 or 21, is recommended to give adjuvant osimertinib for a period of 3 years. That was the duration in the ADAURA trial. So moving from the adjuvant setting to the metastatic setting, in the field of EGFR mutation for 10 years, we had first and second generation EGFR TKIs that were used in clinical practice based on results of several phase 3 trials comparing these agents versus chemotherapy, and all of these trials were positive, were demonstrating that the EGFR TKI is superior to chemotherapy. The efficacy of this agent was very similar. In the past meetings, we had a lot of discussion of what was the best agent. At the end of we can conclude that all of these agents probably were very similar in terms of efficacy. And of course, the limit was that after an initial response, all patients relapse because of acquired resistance. So this algorithm that was the algorithm that we adopted in our practice for almost 10 years completely changed since the publication of the data of the FLAURA trial. So the FLAURA trial was a phase 3 trial comparing osimertinib versus first generation EGFR TKIs, so versus gefitinib or even versus erlotinib. Importantly, in this trial were included also patients with brain metastasis. And when we look at the results in terms of response, you can see that very few patients didn't respond to osimertinib. So generally, the vast majority of patients responded to this treatment. The failure rate was very, very low in the osimertinib arm. And in terms of the primary endpoint of progression-free survival and in terms of overall survival, there is a significant improvement in progression-free survival and importantly also in overall survival, favoring patients receiving osimertinib. You can see that there is a significant difference, but also a clinically meaningful difference favoring osimertinib. So based on this data, now we consider osimertinib the standard of care in first-line setting patients with EGFR mutations. Also because all the additional analysis were clearly in favor of osimertinib. When we look specifically at the different subgroups, you can see here that almost all subgroups benefited from the treatment, from the therapy with osimertinib. And importantly, the drug confirmed the ability to cross the blood-brain barrier to be effective against brain metastasis, and also osimertinib demonstrated the ability to prevent occurrence of brain metastasis. So this is a very important point, a very important information, because now we have an agent strongly active against brain metastasis. Unfortunately, even if osimertinib is an excellent drug, also very well tolerated, because I didn't present data on tolerability, but osimertinib also is less toxic than first generation or second generation EGFR TKIs. Well, even if the patient responds very well to osimertinib, unfortunately, even with osimertinib, the patients after an initial response finally relapse. And they relapse because of acquired resistance. The mechanism of resistance to osimertinib are quite complex, different compared to first or second generation EGFR TKIs, with occurrence of a secondary mutation or MET amplification as the most frequent event that we can observe in these patients. Of course, it's important to offer at the time of progression new therapies, because at the present time, the only option that we have in this patient is chemotherapy. But fortunately, there are many clinical trials currently ongoing exploring the possibility that other agents, other combination could result effective. And I want to show you some of the data that were presented specifically during the ASCO meeting, but also some update were presented during the World Lung Cancer Conference and more recently during the ESMO meeting. One of the most exciting and new combination is the combination of amivantamab together with lazertinib. Lazertinib is a third generation EGFR TKI and amivantamab is a bispecific antibody able to target EGFR but also targeting BET. So there is a strong rationale for combining these two agents, particularly at the time of osimertinib failure. And in fact, the preliminary data that we have from this trial that was repeat presented during the ASCO meeting are showing an important efficacy in terms at least of response rate and progression-free survival for patients receiving this kind of combination. So this is an approach very, very promising that probably could become one of the, if confirmed, of course, if the efficacy will be confirmed in the next future, could become one of the options at the time of osimertinib failure. And another possibility, another agent that is under development is also patritumab deruxtecan. That is a conjugate antibody against HER3. So this antibody uses HER3 for blocking the tumor cells because HER3 is frequently overexpressed at the time of progression to osimertinib. And so this is an agent in which the action is irrespective of the mechanism of resistance. And in fact, the preliminary data that we have, these are the data that were presented by Pasiyan at the ASCO this year. Again, you can see that this approach seems promising in terms of efficacy. The response rate was approximately 40% with a median progression-free survival of more than 8 months. That this is what we expect from target therapies. So this approach seems again very promising in patients with resistance to osimertinib. So in conclusion, we can say that certainly testing for EGFR mutation is now mandatory in all patients with non-small cell lung cancer, including patients that receive radical surgery. Of course, based on the ADAURA trial, now the osimertinib can be considered is the new standard of care in the adjuvant setting. And of course, in presence of metastatic disease, we can consider osimertinib the standard first-line treatment that we can offer to the patient. This is an agent superior to all the other agents currently available and particularly effective in presence of brain metastasis that we know represent an important clinical problem for our patients. So thank you very much. This is my last slide. I don't know if there is any question. Thank you very much. I don't hear.
We do have a couple of questions. I will not take so long. So the first question regarding that, for the patient with a stage 1B on the adjuvant setting, are we able to omit the chemotherapy for this patient? Specifically on the study, it was only 26% of the population they were receiving chemotherapy. Are we reached to the point that we can omit chemotherapy for this patient?
Well, this is a very important question. The problem is that if we consider the data from the ADAURA trial, we cannot use the ADAURA trial for deciding if we can avoid or not chemotherapy. We cannot say that. But what I can say, what is my experience, when I have a patient receiving surgery and the patient knows that she or he is EGFR mutant, generally the patient asks me to don't give chemotherapy. So I think that in stage 1B, in which the role of chemotherapy is very controversial, I think that we can avoid chemotherapy in stage 1B and we can go directly for the EGFR TKI. The real question is if we can avoid chemotherapy in stage 2 or in stage 3A, because these patients have a higher risk to relapse. And at the present time, we don't have enough data for deciding to avoid chemotherapy.
And with the circumstances for the CTONG and the other studies like impact for the, we know that osimertinib is a third generation and it's the most powerful one. Is it approved in Europe now for all the patient or a specific population?
No. In Europe now received the approval in the adjuvant setting for all resected according to the ADAURA results. I think that also the company AstraZeneca is really confident in the efficacy of this agent. And in fact, now they are running a trial even in stage 1A. So in patients with very, very early disease, I think this is reasonable because if we consider patient in stage 1B, the reduction in the risk of relapse was 50%. So it's amazing. It's a huge reduction. So I think this is reasonable also to explore in very early stage. I think that even those patients present a risk of relapse. And particularly the risk of relapse in the brain is the big problem that we have in EGFR mutant.
Perfect. We do have a practical question. If we do surgery for the patient and we have a residual disease, are we able, patient with EGFR positive, are we able to give this patient chemotherapy followed by osimertinib, specifically that in the study it was R0 resection?
Yes, that's a very good question. I can tell you, of course, we don't have data from clinical trials. I can tell you what I do in my practice. In my practice, if I have a patient that is operated and the surgeon say, okay, I was not able to remove all the cancer, so there is a residual, or there is a clearly evidence of residual at the histological examination. Generally, I consider these patients as a patient with locally advanced disease, meaning that I generally propose to these patients a chemoradiotherapy like at the locally advanced stage. The question is, in these patients with, locally advanced disease treated with surgery, incomplete surgery, and then chemoradiation, if these patients are candidate for durvalumab, for example, because durvalumab is indicated after chemoradiation. Well, the data of durvalumab in EGFR mutant in locally advanced disease are negative. So I think that in that case, after the radical approach with chemoradiation, probably I will offer still osimertinib in the adjuvant, as an adjuvant therapy. Yes.
Would like,
but I strongly recommend to consolidate the local results because the higher risk that we have in terms of relapse with adjuvant osimertinib is a local relapse. So yes. I think that local treatment is very, very crucial.
Perfect. Again, I would like to thank you very much for excellent presentation and the excellent talk and the discussion as well. And hopefully that we can see you in person next week, next year, sorry.
I really hope to visit your country. I was there many times in the past and I really hope that I can.
Yeah, our pleasure. Thank you very much.
Thank you very much. Thank you for the invitation. Thank you.
Have a great night for all the attendees and thank you very much for your questions as well. See you tomorrow. Thank you.